Hi, good evening to all of you. Am I visible and audible?
Yes, sir.
Okay.
Yes, we can see you and hear you.
Okay. Great. Great for that response. Thank you so much. And a very warm welcome to all of you. And today, definitely, what we have gone through is the grand mock test for your part one. Before moving ahead with the discussion, I just need to know about your feedback, about your response, how you felt. Were you able to complete all the questions or not? Was it difficult for you to maintain yourself for the 3 hours? Did you have any kind of anxiety? What were the kind of questions, the difficulty level? How did you find that? Before jumping onto the discussion, I need to have that kind of discussion, that feedback. Can I have that answer? Hi, Dr. Honey.
It was easy.
Hi, how are you? Good to see you again.
Thank you so much. Yeah, what about you? How's it going? And what about the grand mock?
Yeah, it was really good opportunity. I had the anxiety that today is the real exam, so I woke up really early and prepared for it, and I felt the exam was fair. I mean, it wasn't too hard, too easy. So there was a mix of different difficulties. I thought it's fair and good questions.
Mm,
Generally speaking, I mean, I've been revising few of my mistakes since I finished, so it's good to have the discussion now.
mm,
The only thing probably that would have made it a bit more comfortable is to have the font bigger because it was so small. And if you zoom in, then you can't read the edges.
besides,
But I think that kept me more focused because your eyes were were staring all the time.
mm,
I
mm,
managed to finish it on time,
mm.
barely on time. So I had like 12 minutes.
Okay.
Usually I have more time, but because lots of questions had like different ideas. Well, I managed to finish it within time and only maybe few minutes break just for stretching. But overall, it was a really good opportunity. So thank you.
Okay, great.
I
Thank
really like that the website has explanations as well. So
you.
that's a really good thing.
Okay, great. Thank you so much for the feedback. And definitely what you just mentioned is you were able to finish the questions, all the questions barely on time. And this is what needs more practice, right? And definitely you have given the previous attempt. And if you were able to complete in your previous attempt in the actual exam, but over here just 10-12 minutes, I would say it's absolutely okay. It's good. But try to increase your speed, and that comes after the practicing, right? And definitely right now I'll not say you have to practice more question. The more you know the facts, the more you are able to recollect. Definitely it becomes very easy, and it becomes the speed just goes on a double or triple side, right? So it is about the recollection of the facts, I would say. So great, so thanks for the feedback, and definitely you perform very well. How much did you score? You are on third or fourth, I would say.
72.
72.
Yeah, I think I took more time answering because I wanted to make sure I exclude the other answers. So
Good.
usually I just tick what I know, but I intentionally slowed myself, to be honest. But
Good.
I was looking at the time every 30 minutes.
Hmm.
So that's good.
Then I would say that is the perfect strategy. In MRCP, the best thing if you want to score high in the exam is not how fast you went ahead with the exam, it is how clearly you are ruling out the other options in the questions which you are somewhat not sure. You have a doubt, you have flagged that question. Obviously, you can't spend extra time for each and every question. There are 100 questions, so you need to be fast. But wherever you are stuck, you are not sure about the fact, please try to rule out the option. That is the best thing. Good, great. What about others? Hi, Dr. Sultan. You scored 70, if I'm not wrong.
Yes, sir. I was because completing the last stretch of the basic sciences, so I
Hmm.
had only one day to revise. So I could not revise. Actually, it was purely literally without any
Without
revision.
revision.
Yes,
So,
sir.
so should that come with a smile, or that kind of face which you have right now, expressionless face? If you have
I
scored
was somewhat,
70,
I was thinking that it is because in the mocks, the questions we have been doing, they have a large question stem, they are a little bit complex. Seems like it was on purpose an easy test was made so that we don't get disheartened. Is it so?
So you are thinking the exam was easy. This is your feedback, is it?
Yes, yes.
Okay, good, 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 perfect. I'll just have a word with others also. I can see some other people who are smiling. Some other smiling behind, might be smiling behind the screen because they have not switched on the cameras after multiple requests. Can I again request? Please switch on the cameras for next 5-10 minutes so that we can interact and then we can start, right? You can switch off after that. But once we have joined, please try to have that interaction. It should not be one-way interaction that I'm just having a word with you guys. It is always good when we have an interaction from both the sides, right? That should be mutual. So great. Thank you so much for your feedback, Dr. Sultan, and thanks to others who have just switched on their cameras. Thank you so much. Okay, now I'll just ask others. Dr. Arshia, hi. Just 10 minutes of the chat with some of you guys and then we'll start, right? I don't want to waste much time, but with this discussion, some other times you get to know where are you in the journey, right? Are you with the other people? Are you somewhat away? And because MRCP is a journey where you need to have people around you, otherwise you will feel suffocated, otherwise you will feel that you are on a lonely journey, which somehow becomes boring, right? And can be stressful at the same time in the last few days. When you have people around you, when you are able to relate to their stories, when you are able to relate what they are saying, as Dr. Sultan is saying, it seems to be very easy. And he had that expressionless face at the start saying that I was not able to perform much, scored 70 without a day of revision. So anyhow, so that's his feedback. I totally agree with it. Okay, yeah, Dr. Ashia, hi.
Hello, sir. For me, I felt like there were a couple of things that it was more of a reminder. This exam it made me like think of things that I'm not confident about. And this is not my first attempt. This is like my third, fourth attempt now. So I think there are things that I know for sure that I do not understand. Like say, for example, the spirometry, obstructive, restrictive. It's just no matter how many times I go through it, I just can't get it into my head. So I think I've just learned those kind of topics which I absolutely have to like properly go through in these 2 weeks to make sure that I get those right. And then the ABGs, the interpretation, there was a question on ABG interpretation as well, which I got wrong. Yeah, so I mean, I could have definitely done a lot better. I scored only 61%, but at least I'm a little bit more confident. I'm like, I think I can somehow scrape through this time.
Good.
Hopefully.
Perfect, perfect, perfect. So definitely, as you rightly mentioned, that this exam might have given a reality check to some of you that, yeah, these are the topics which are your weaknesses. Let's say it's about ABG, which you just mentioned, or you are not able to recollect the topics which you have read. It can be pulmonology, cardio, neuro, whatever it is, right? So with that kind of reality check, let's say you were expecting more from your side, and very important line from one of the cool drinks in India is "Dil mange more," right? So you keep expecting more from yourself. That yeah, if you have scored 61, you will expect 70, and that is what is needed, right?
Yes, exactly.
Scored
Yeah.
70, you will expect for 80. Whosoever has scored 80 will think about 90. So that is what we keep expecting from ourselves. That, oh, why didn't we thought about this particular question, or why didn't we thought about this particular option? So great. I would say thanks for that feedback, and don't demotivate yourself. Don't be hopeless. Don't feel that you were just scoring 61, the other person have scored 75 or 80 or whatever the highest marks are. I would just say it's a reality check for each and every candidate. If you have scored 70, it's good. If you have scored less than that, again good. Because you know these are the places you have made the mistakes, and there are few days left. There are 15 days left for you to again come back in the same race, in the same competition. So if you are a person who feels that, yeah, I want to score more, I can score more, then yes, that is a motivation to all of you guys that please, you have to utilize each and every, not a minute, each and every second in these last 15 days and try revising as much as possible. Try to increase your pace as much as possible. Obviously, you might have responsibilities, you might have your duties, many other things, right? And there are many ups and downs going. But I would say if you try to utilize each and every second, definitely you can do it. Even if a person who has scored less than 60 also, then also. So yes, if I just talk and summarize just about this mock, whosoever has scored more than 60, definitely you are doing good. Definitely. Whosoever has scored in between 50 to 60, you are on the verge. You are somewhere on the verge. You need that push. You have to push harder. And less than 50 for this kind of mock, where I also feel it's a mediocre, it's not that difficult as compared to the mock exam which we used to have in our weekly days, or let's say the whole course, 3-month course. If you compare, it is relatively easy. But at the same time, some are the questions which were confusing, some are the options which are very nearby, which we'll be talking about today, right? So great. Now I'll just have our Dr. Honey. Yes, you had the hand raised.
Yeah, just wanted to ask you about the revision because I'm not sure. Sometimes I feel I have a few notes, so I've been doing few topics that I felt I needed to revise, not the full subject, but few topics. But then I started to read my notes, revise the notes that I did, and sometimes it feels like I'm reading like bullet points.
Hmm.
And I start to think, is it the right thing to do? I mean, I know it's good to revise our points because these are high yield and I appreciate them when I did the mock. But
Hmm.
sometimes I feel if I do it all day, is it the right thing to carry on, or do I need to do a bit of reading or solve questions, or is it fine just to go through all the notes that I've written after mocks and courses, basically?
Okay, so great. Perfect. And that is a question from majority of you, right? That is a question in many of the minds right now. How to revise, how to utilize those last few days. And definitely I'll be talking more about it in the session, during the session, after the session also, right? But I just like to answer, right, very briefly right now at this point of time is you don't have to practice any more question at this point of time. It is just the points you might have jotted down, you might have written. You can see those points or the incorrect questions from your question bank or the flagged questions or the PDF which we'll be providing you, the flashcards. If you talk about just the points right now, you cannot delve into, you cannot jump into the concepts. You just need to know those bullet points. If it's about ASD, you need to know the important points about ASD, or let's say VSD or cooptation. You just need to know those points. So I would just say restrict yourself from practicing more questions at this point of time. Yes, you can go ahead with one or two previous A papers. That's it. Just to again get that reality check, just to again see whether you are able to cope up the time, whether you are able to sit for 3 hours with that same energy. That's it. But at this point of time, please, please, please do not analyze yourself by going with different mocks here and there, right? Let's say from past tests, past medicine, PMG, or any other place. Yes, now the plan for the next 15 days should be strategically towards the bullet points, towards the high yield points, which has been asked in the exam or which might be asked in the exam. Is that okay, Dr. Hani? And I'll be clarifying more about the revision in the next few minutes. Okay,
Right.
then I can see Dr. Sadia. Hi, Dr. Sadia.
Yes. Suha
Hello,
or Adam?
Dr.
Hello.
Dr. Sadia, are you there?
yes, I'm here, but
Yeah.
I don't know if there's another Sadia.
No, I don't think there is another Sadia. There is only you, I believe. Okay, yes,
Okay.
Dr. Sadia Siddiqa. That's,
Yes.
I think, you. Yeah. So, what about your mock, your experience, your feedback? Were you able to
Uh,
finish on time? And what do you think about your performance?
so I so basically throughout the course, initially I started well. However, for the last couple of weeks, for some other reason, I wasn't studying properly.
Hmm.
However, I attempted this mock, and it was 61.
Okay.
I think that so that gave me a bit of encouragement that yes, I will be able to, if I now, at least from now, I can be consistent
Hmm.
and I mean attending all the revisions and try as hard as possible.
Yes.
But yes, I think I have a lot of revision needs to be done, especially for the minor subjects as well, because that was the time I wasn't able to focus for the commitments and other issues. Uh,
Great. So
so
this is the outcome you need from this exam, not just a number of 61. What you need is the answer where you are lacking. What are your weaknesses? Are you making silly mistakes in the exam or not? And how to decrease that? How to overcome those?
I
So
I
that,
did.
yeah. Yes, I know, that is a human error. And definitely, I would say there will be 2 or 3 silly mistakes in the actual exam also. But I would just say, if you know the facts, if you are well versed, definitely those silly mistakes that decreases in the exam, right? So it is about, as you mentioned, it is about revision, right? And obviously, we'll
Yeah.
be focusing more on the last 15 days. And that is what a kind of motivation I want all of you to have, that yes, whether you have scored 50, 60, 70, 80, whatever the number is, you have to revise in a better way, in the best way possible, right? And definitely will help you good. Yeah.
Also, I was
Yeah.
thinking if I want to practice some past papers, I only solved like 2. So I was thinking that is this a good time just to have the, practicing questions.
Now, at this point of time, this is again a commonly made mistake that people or the candidate, they try to solve all the previous year papers at the last moment in the last 15 days. No. Again, the point comes are the topics. If you have seen a question, let's say, of atrial fibrillation, yes, the topic is important, not that particular question. This time might be the question asked was about anticoagulation. Next time, they need to ask what are the indication of cardioversion? What are the 4 indications? If you're not well versed of those 4 indications, obviously you have lost the question. So there's no point right now just practicing going with previous A papers only. No, what I just mentioned is 2 or 3 previous A papers maximum. If you have time, if you have revised, if you are well versed, if you're confident with the theory, yes, why not to? You can go with 5, 10, whatever the number is. But if you have not practiced, if you have not revised your theories, your PDFs, I would say that is the priority. First, finish them and then try solving 2 or 3 maximum previous A papers. Right? Is that clear, Dr. Sadia?
Thank you, sir.
Okay, most welcome. Yeah, Dr. Suha.
I had 2 questions. The first one was about solving past papers in the last 15 days, but you just answered that question. Would it be if I don't solve any questions, like any past papers at all, I just focus on my PDFs and the mocks and the PYQ, is that going to be enough on top of like revising my notes and everything, or is it mandatory that I solve a 1 or 2 past papers at least? This is the first question. The second question is, you can answer this one and then I can remember. I actually got confused. I forgot my second question.
It's okay. Absolutely okay. Hi, Dr. Ajila.
Hi, sir. Hi.
What about your feedback, your score? Just 5 minutes,
Uh,
and then we'll start our discussion in the next 5 minutes. Yeah.
I actually didn't get time to revise the whole thing, but then I still gave the exam because I wanted to know how to sit for 3 hours after a long time, and then if I'm able to recollect things. So I scored around 67. I think, yeah, 67. And I felt like there are things that I'm not able to recollect. Like that point is there. So I think we need to revise, which we can do in the next 2 weeks. And then even that silly mistakes about some things, like once you go back and see this is the answer, then you were like, yeah, I could have got it right, but then you're not able to get it right. So I think doing that revision will make it better, I feel. So, but it was really, really helpful because at least now we got a insight about how it's going to be, how the questions are going to be. Yeah.
Good. So you also got that reality check, right? And obviously that just mandates, that just tells you the importance of revising, right? And obviously you just finished your course this week, yesterday itself, I believe, day before yesterday or yesterday. So definitely you didn't have the time to revise, and the last 15 you have to invest for revision. Great, perfect. But 67 is a good score. So be motivated, right?
Yeah,
Now,
I remembered my second question. Sorry. The second
yeah.
question is the minor topics. If do we actually need to solve questions on them if I did not get the chance to solve questions on like the ophthalmology, dermatology, or is it enough to go through the PDFs and the PYQs from now on?
So again, for the minor units, for the basic sciences, if you have time, please go ahead with practicing the question. And this is what I kept saying from the start of the course. These are the 3 units, one minor units having further 3: your dermatology, psychiatry, and ophthalmology, basic sciences, and biostats. If you have time, please solve the question, please practice the questions from these 3 units, I would say, I would prefer. But if you don't, obviously, the last option is a PDF. That is what I can say. And there are many candidates, right? I might have shown you the screenshots, the scores also. There was Dr. Dharam. I might have mentioned his name also. He scored 803 in the exam. And yesterday his part 2 result also came and he scored 660. And again the same feedback. He in part 1 he didn't even solve a single question from a question bank. Just 20 days of videos, just intellect medicos videos, just. And he started 2.5 months back. It's not months or years since into this. No, he was in academics. He's working in the UK right now. He's in Liverpool, and he just jumped into it, and he just invested 20 days. And similar happened with his part 2 also. So, and there are many others. There are many others. So I would not just say, but if you have time, practice the minors, practice the basic sciences. If you do not, the basic remains that yes, please go ahead with PDFs, try to cram it, try to understand it, and then it's the application in the actual exam. That's it. Right? Okay.
And what about sorry, Delane, the question about solving, is it mandatory to solve past papers, or if I don't have the time for that, it's fine?
No, again, I answered that already, that if you have time, you can. But if you don't, please don't have that as a priority. Priority is revising a topic. If you are well versed, if you are confident, you are done with the theory, then yes, you can move on to practicing the question from the previous papers. Right?
Okay.
Okay. Okay. Most welcome. Now we'll just start. I'll just have a last for Dr. Vidya and Dr. Mayuri also. Dr. Mayuri, I'll come to you as well. Dr. Vidya.
Hi, Doctor. How are you?
I'm doing good. Thank you so much. How about your prep, about your score, about your feedback, about the exam? How did you felt and how you performed?
So I was very stressed. I haven't obviously revised everything, but then the score was 65. Yes, if this is the score in the real exam, I would have been very happy. But because it was mock, I was a little bit like, could have done better. But obviously, there were lots of instances like how Dr. Ajala said that I can hear Dr. Baig's voice in my head explaining the topic, but I could not recall for the love of God that I was like, I know this, but obviously I sat there just confused between options. But I think it just reinstates that I just need to revise.
Okay. So that is the whole sole purpose. That is the actual whole sole purpose of having this grand mock right now, is because you know the importance of revision. You all have come across those points. Let's say it's about schizophrenia or schizotypal. You all know that. But somehow in the exam you get confused. Is it schizoid, schizotypal, schizophrenia, psychosis, depression? You get confused. So that is what the importance of revision. If you are well versed with the topic, you can manage any question about that topic, right? Great. Yeah, Dr. Mayuri, and then we'll just start the discussion.
Yeah, so I have a question like, so just, I have finished the mock half an hour before, and I'm thinking कि मेरे को ऐसा लग रहा है कि मैंने questions ठीक से मतलब I have not like read the options and I have not given time to that options. So that I'm thinking, so that's why my score was not that good, I
Okay,
guess.
so no worries. Whenever you are in doubt in the actual, I'm giving you that input, that feedback.
So
That
because I was in tension कि मेरा mock 100 questions I have not given, I have to manage the time. So
I know,
I have done it quickly.
I can totally get that. So for this kind of problem, what I would strongly suggest is please Whenever you have a doubt, you're not sure about a particular question, flag it. There is no problem flagging questions. You can flag 50 questions out of 100, right? And you can have a sheet in front of you, right? You can just write the number where you are very much confused, which you have to look after just when you have finished 100 question. Let's say you have written as 52, just jump onto the 52 52nd question and see it. Otherwise you'll be lost. And if you just keep moving forward without having a doubt, without flagging a question, it will be difficult to come again to that particular question, and you will be like, from where to start? So try flagging the questions in the exam wherever you are in doubt, right? That actually helps. So at the end, you'll be left with around 20 questions which you have to review. You mentioned you had 30 minutes. 30 minutes are way good for just 20 questions or maybe 25 questions, right? Okay, now I'll be just starting. Hi to others as well. I don't have much time, so hi to all who have joined, and hi to others as well. And thank you so much for joining, and especially writing this mock, because the main thing is taking that step. If you
Sir,
are
a
a person who
small a small doubt, sir. Actually, I was crammed between the time actually.
Mhm.
So unfortunately, I couldn't make out the whole question because it was very long stem. So I used to write for everything. I mean, what are the important things and all I used to write. After that, I used to make out what the
Hmm.
question is asking and what they're expecting. I'm doing that.
Hmm.
So that thing, I am not able to make it to the time actually.
So
I was
definitely,
behind the time.
there are definitely few questions which have had a longer stem, and this is what
Yeah,
you expect in your actual exam also. Definitely, there will be around 20 or 25 questions which have a longer stem, which have the investigations hidden in between, and having that question with 10 or 12 lines or maybe more. Now,
then my brain is not able to process that actually. What is happening? What they are asking and what am I writing?
I can totally understand. Again, if you are well, now we'll just go ahead with all the question, right?
Yeah,
Wherever start, we'll just discuss about this thing, right? How to see and how to search for those clues which are hidden in the stem, or maybe
exactly.
it can be a traps. So how to look for them, right? So don't worry, and I totally understand this is a very common issue which you are having, right? It's not a problem which you are the person who is facing. Many other candidates they face that I'm not able to. It's such a lengthy question. I was not able to focus. What is being asked? What is the information being given? So I'll help you with that also. Okay, now starting with the very first one, and one request. You can you if you are a person who knows what is the exact answer, explanation, not which is being provided in the application, but why this particular option is correct one. I just need to have that interaction so that it goes in your long-term memory, that what is the concept behind why we answered this one, and then we keep moving forward, because we have to cover 100 questions in a matter of 3 hours, right? And once we are done with some difficult question, I'll just run with the easier ones, right? Wherever it is required, wherever the topic is important, I'll emphasize over there. Okay, and whatever doubts you might be having, you are free to ask, but let me finish with the explanation. And in the end, definitely, I'll talk about how to move forward with these last 15 days, especially revising the PDFs or the questions or the incorrect ones, whatever it is, right? We'll discuss that at the end of the session. Okay, now starting with the very first one. I believe you all are able to see my slides, is it, in front of you?
Yes, sir.
Okay, now the very first question talks about ECG finding, and also they have given a CVS examination. My always funda and always my suggestion would be just see the last line. They are asking most likely diagnosis, so obviously you have to go with the issue which is mentioned in the stem, or let's say how the patient presented to the hospital or to you. Now, this particular question says CVS reveals a soft systolic murmur heard best at left lower sternal edge and a prominent V. Can I have the answer?
TR. So it's
Diagnostic
tricuspid.
vegetation.
Very good.
Good. TRV. Right? So remember the mnemonic TRV. Further, what they say, the remainder of the exam is unremarkable, and 12 lead ECG, which is, I believe, your favorite, short TR and
WCW.
delta. I believe this is great.
WTPW.
And everyone loves this WPW. Smile just comes up. Oh, this is a WPW. But they have not asked about this WPW, unfortunately, and that smile just goes away. Oh, what have they asked now? They have changed it. And so, anyhow, so this definitely talks about the pre-excitation, and which we all know is WPW. Now, what they have asked, most likely diagnosis with presence of the TR, tricuspid regurgitation, and WPW. So you need to know the association. And have you marked D as the answer or somewhat else?
D, sir.
D.
So I believe this was an easier one, right? Which you might have solved in your question bank or the mock exams. So this is Epstein anomaly. Can anyone tell me what is Epstein anomaly? Just in
There is atrialization of the
Utilization of the right.
RVs.
yeah.
And this is atrialization of the RV. There is a where the displacement of the tricuspid leaflet towards the ventricle, and that leads to this DR also. And there is also association with ASD, and also association with this accessory pathway also.
Good.
And there is also sometimes clubbing cyanosis is also found, but that's not always found.
Okay, good. Okay. What else? So there's a mnemonic with the name of delta. So definitely with delta, there are delta waves. Epstein, you remember with E, Epstein anomaly. Then you have low PR interval, or you can say decreased PR interval. There can be TR, which is associated, and especially remember the V wave, right? The V wave, prominent V wave. And there is accessory pathway. And with accessory pathway, I mean to say WPW especially. How do we manage WPW? Another important topic for the exam. Can I have the answer, please?
EP study.
Radio
Can I have
frequency ablation of the
yes,
accessory pathway.
Dr. Ajira, the definitive management remains the RFA, radio frequency ablation. What is the medical management?
Flecainide.
Right. What about patient having WPW with atrial fibrillation? Good. Answer is procainamide. Good, perfect. Okay, and any other pre-excitation syndrome apart from WPW?
There can be other atrial tachycardias.
Good. Lown-Ganong-Levine syndrome. Good. But it has short PR interval. There is no delta. If they say there is no delta wave, answer becomes LGL, not WPW. Why not discuss this? Because WPW is a hot topic being asked in majority of the exam, again, repeatedly. Okay, now moving on to the question number 2. What is the answer and why? What do you think about this particular question? Please, again, my suggestion, my request, please don't read the explanation which is provided at this point of time. Please concentrate what we are discussing and you'll be able to gain more, right? It's not about the explanations are there in the application so as to help you, support you. Later on, just go through whenever the discussion is over, right? So can I have the, yes, Dr.
Diagnosis is emphysema.
Dr. Arshia, yes, Dr. Arshia.
Yes.
The diagnosis is emphysema. That is a restrictive disease. But I got this answer wrong, so I'm too sure how to get to that.
Obstructive disease.
Okay.
So reduce FEV1 by FIC.
Yeah, and increase total.
So when they talk about hyperlucency, along with the flattened diaphragm, with that thing, definitely what you want, what you get the information is there's some kind of obstructive lung disease. And that is the reason there is a flattened diaphragm with more of air in the lungs. And that is why you have hyperlucency. Now, if we talk about, and the other symptoms are present, the presentation, if you see reduced breath sounds bilaterally with hyper-resonant, again, important word on percussion note. There's a prolonged expiratory phase. So they have given all the features which should be there in obstructive lung disease. And when we talk about obstructive lung disease, you all know FEV1 by FVC, which goes on a lower side. So which one is more significantly decreased? Is it FEV1 or FVC?
FEV1.
FEV1 in obstructive.
Good. FEV1, there is significant decrease, whereas FVC in obstructive lung disease is just reduced. If I talk about RLD, restrictive lung disease, opposite happens.
FVC is
FVC.
reduced.
And that is the reason if we take a ratio of the lung volume, right, then it comes less than 0.7%, or you can say 0.7, right? Sorry, points less than 0.7, or you can say less than 70%. Whereas for restricted lung disease, it is either normal or high. Why? Because the FVC is relatively much decreased. It is significantly decreased. Now, the other thing which you have to look for in your exam, especially the spirometry findings, is not just FEV1, FVC. Always look for the TLC or the residual volume. The TLC, which is a TLC is total lung capacity. That increases in a case of
Obstructive lung
disease, whereas it decreases on the other side. And the other one is residual volume. That also increases on this side. So always look for this as well. Plus, there is another parameter you need to look for is something called as DLCO. I believe you all know it. DLCO, what does it happen? How does DLCO behave in a case of emphysema, if I talk about?
Decreases.
Decreases.
Good. So emphysema, it decreases. If I talk about bronchitis,
decreases.
is normal.
Decreases.
If the other thing which is asked in the exam, asthma, and that too acute attack of asthma, answer?
Increases.
I heard creases, but answer is
Increase.
raised. It is raised. So definitely, right, in the acute case. So you know about the DLCO and the other causes for it, right? I'll not go into too much of that. Okay, now question number 3.
Syringomyelia.
Okay, syringomyelia. Reason behind, what are the features which goes in favor of syringomyelia?
Cape-like.
That's like
Sensation
burning sensation in shoulders and
arms.
Okay, good.
And there's
And there's preserved dorsal column.
and lower motor.
cape form like
Mixed upper and
pain
lower
and
motor
temperature
neuron.
Mixed upper and lower motor.
So
Yes.
symptoms exacerbated with warm temperature or a shower. There are two possibilities, right? One very common thing which should come into mind is which comes under
MS.
Sclerosis.
But over here, please do not get confused. They are talking especially about a dissociative one, and especially they mention the loss or the change, especially seen in the upper limbs. They have mentioned burning sensation in the shoulder and arms, especially while showering, despite water being lukewarm. Now, if this is the area involved, definitely. And further, what are the other features which goes in favor?
Increased pain and temperature sensation.
Preserved dorsal column.
The dorsal column is preserved.
Exactly. Now, if I talk about syringomyelia, if you remember, right, there's a syrinx and it just expands. So over here, we have the dorsal column, this area, which is preserved. So proprioception is always preserved until unless it is seen in very late stages. Initially, patient presents with spinothalamic and corticospinal tracts being involved, especially for cervical area, this area. So this is how it expands for spinothalamic and for corticospinal. So cervical area or the thoracic area, that will be involved. So upper limbs, the upper part of the trunk, the chest area, this is what is being involved initially in the initial years of syringomyelia. Now, further, this syringomyelia is also associated with one problem, one pathology, very important one.
Syringopulmonary.
That is an extension. That is a complication. That just, if syrinx expands vertically, yes, what it can involve is a 12th cranial nerve, and we call it as syringobulbia. But very commonly, remember, syringomyelia or bulbia is associated with Arnold-Chiari malformation. Remember that for your exam. This has been asked in the previous. Now, plus, if I ask about the presentation of a syringomyelia, will you see upper motor or will you see lower motor?
Both.
Mixed.
Both.
Both. Okay. Both. How come? In the upper limb, will it be a UMN or will it be a LMN?
Can be anything.
Can be anything.
Element.
Element in the upper limb.
Predominantly lower motor in the upper limb and upper motor in the lower limb.
Predominantly नहीं होगा ही यही. What you are talking about is something called as MND, where it can be anything. Over here in syringomyelia, remember, in upper limb, it will be always lower motor. In the lower limbs, it will be upper motor always, remember. Right? I'll just write it down. So upper limb, you have element, and lower limb, you have upper motor neuron. Now I need to know, can I have the answer from others as well? I need participation from all of you. Dr. Ramchandra, Dr. Lajwad. Hi, Dr. Lajwad. First of all, congratulations. I'm so glad, so happy to see your score. You scored 87. Your feedback about the exam?
So honestly, I've marked like questions I don't know. Like around 40 questions were guesses. And some of the questions, the correct answer, the option is in a different font in the app. So I've just gotten a high score because of that.
Because of?
Some of the questions, the font of the correct option is different compared to the other options.
Seriously?
Yeah. So I didn't know the answer, so I just kept that option as like a guess.
Oh my God. Has that happened? Has anyone else noticed that?
No, sir.
No, wish I had known.
It's not always the correct option. Like 2 or 3 questions, that's not the correct option, but most of them were the correct option.
It was not for all.
Now you are being humble. Just 2 or 3 questions, and we are talking about 100 questions.
No, sir. I've literally marked like which ones I've kept guesses. So like over 40 questions were guesses for me.
So I feel your luck was very strong, right?
Yes,
That's the luck. You being humble. So definitely your division, your thing are good, right? Have a good confidence on yourself. But at the same time, I'll not say going to the other side of a pseudo confidence that if let's say you have scored 87, that is very good, great performance, I would say. But don't have that feeling, oh, you don't need to revise. You will be able to manage the exam. No.
No, so definitely I felt like even questions which I knew, I had a doubt between 2 options if they were correct or not. So I wouldn't say I was still confident even like.
Okay. Good. So great performance, I would say, and definitely you need to perform in this manner, and may the luck be the same on the 17th of September.
Hopefully, fingers crossed.
Hopefully you will see those options in a bigger font in the actual exam also. because I think you only saw, because I have not received that feedback from anyone. Is it? Can I? Yeah.
It's been the same even in a couple of the weekly mocks which I've given. So
okay.
So certain questions were there, so which like had all the other answers like more boldly highlighted, and certain options were like comparatively, if you paid attention, you could see them differently.
Oh.
But I didn't do that, sir. I also should have kind of done that. But
okay, I'll have a word with my app team then.
Yes.
Okay, great.
Sir, this Euthos phenomena is present in both multiple sclerosis and syringomyelia, is it, sir?
Yeah, pardon?
This Euthos phenomena is present in both MS and syringomyelia, sir?
No. I just ask wherever it is present, the answer is Uthos phenomena in multiple sclerosis. It cannot be in syringomyelia. No, it has a cape-like distribution. The problem, the pathology is totally different, right? The point, what they want to say is there's a change in temperature sensation in the upper limb.
Okay.
So
So
they
the stem here, especially while showering, despite the water being
wanted to
lukewarm.
confuse you. This is what I wanted. That yeah, some of the
Herring.
candidates might have gone with multiple sclerosis, thinking about.
Yes, sir. I was confused, sir, but still I went for syringomyelia. Actually.
Good,
I
perfect.
went for MS. So.
Perfect. So that is a trap. That is a trap, giving you this kind of scenario of shower because you have done so many questions, practice the questions, and giving multiple sclerosis in the one of the options, right? So that was a trap actually. Okay. So now I need to know what are the causes. Yes, Dr. Atresh. Dr. Atresh, yeah.
Sorry to interrupt. You mentioned about the malformation. It was asked previously. What is it? I didn't get that.
Chiari malformation.
Oh, Chiari. Okay.
Chiari malformation. Arnold-Chiari malformation. It has 3 types, right? 1, 2, and 3. So it is basically based on the displacement or herniation of the cerebellar tonsils. And type 1, if you remember, I have discussed in one of my mock, or I believe in the theory session. So it is the displacement of the herniation or displacement of the tonsils of cerebellum. Then in the second, there is, can I have the answer? Second, what happens? There is downward displacement of the brainstem along with the cerebellar tonsils. And also there's a hydrocephalus. And with the third, which is almost lethal, right? Patient has spinal herniation also, especially in the cervical area. So third, they don't ask. Usually they ask about type 1 or type 2 Chiari malformation. Okay. Now I was discussing what are the other causes of mixed pattern having UMN and element, which are very frequently asked in the exam again.
MND.
Subacute combined degeneration.
Motor neuron disease.
One person. Can I have one person to speak? Dr. Honey, can I have the answer?
So motor neuron disease has both upper and lower motor neuron disease lesions.
Amyotrophic lateral sclerosis.
Okay. Yes, Dr. Honey, can I have the answer, please? One is MND.
So,
Just mentioned MND. I have other options also, other causes also.
Subacute
combined
degeneration of spinal
degeneration.
Combined degeneration
Matrix
of
attacks.
Yes.
Good.
dorsalis,
Conus medullaris, stapes dorsalis.
Good. Stapes dorsalis
Syringomyelia.
has the sixth one.
Syringomyelia.
Conus medullaris.
Conus medullaris,
Stapes
syringomyelia.
dorsalis.
Syringomyelia.
And stapes dorsalis.
Stapes dorsalis.
Stapes dorsalis.
so basically this is the smart monkey towards cute carrots.
Yes.
Yeah.
You remember that.
Yeah, absent ankle reflex and extensor planted, basically.
Good. For your exam, very important are these 3 1. Very commonly they keep giving, and especially SCD. Remember about subacute combined degeneration. Very commonly they keep asking that. Okay, now moving forward. So we have discussed about syringomyelia. Yes.
Sorry for the disturbance, sir. In the question, it was given planta was the flexor, not the extensor in the syringomyelia. The previous question, sir.
So that can happen. That can happen in the earlier stages. Later on, what happens? The problem with the syringomyelia, what happens? It is in the center, in the spinal cord. Initially, what happens is it just compresses on the nerve fibers, and that is the reason patient has element features in the upper limb. And all those inhibitory fibers are not inhibited initially, but later on, those inhibitions are inhibited, and that is the reason in the lower limb, patient presents with upper motor neuron lesion with extensor plantar, brisk reflexes, and all those things. So earlier stages, yes, patient can present with the flexor, right? Is that
I just missed something. So the MND, SCD, all of these, are they sharing ataxia, all of them, or
no? What I just discussed are the patients who have mixed pattern having LMN plus UMN.
Okay, thank you.
Is that okay with everyone?
Sir, here in the question stem, in the upper motor, in the upper limb, it has the brisk reflexes. So is this the case for the initial? Because you said that initially, usually upper motor, upper limb has lower motor.
Yes, usually in the syringomyelia. Now, if I give you a scenario where patient have upper motor, let's say in the upper limb and lower motor in the lower limb without sensory involvement, what will be your answer?
So then it will be like MND. I can.
Perfect. But if you have LMN plus UMN with sensory involvement, only one answer would be.
Then syringomyelia.
Plus, if I say patient has a posterior column involvement, UMN, LMN, posterior column. I'll just write it down. It becomes easy for you, all of you, right?
Subacute combined.
Wait a minute. What we are discussing right now, for all these points, we are spending next 5 minutes onto this also because this is important topic. UMN plus LMN, no sensory. Answer. One
MND.
MND.
MND. Second point is UMN plus LMN plus sensory involvement. Answer.
Syringomyelia.
Syringomyelia.
Syringomyelia. Third, if I say UMN plus LMN plus posterior column involvement.
SCD.
SCD.
And there can be an involvement, and if they mention about ataxia, yes, Friedreich's ataxia can be the other differential. Now, another point, if they say patient has radicular pain in the upper limb, tingling and needle.
Cervical radiculopathy.
Good, perfect. Answer is cervical spondylosis. You might have seen, right? Or a cervical myelopathy. It can be traumatic, it can be degenerative. Whenever they talk about an elderly patient, 65-year-old, more than that,
degenerative.
Talking about DCM, which is a degenerative cervical myelopathy. Or if it is after a road traffic accident, again, the answer just remains cervical myelopathy. Remember, they have a radicular pain. Wait a minute, I'll just write it down. It becomes easy for you to remember. What we just discussed is a radical pain. Wait a minute.
Radicular pain.
Radicular pain. Then answer. Can I have the answer from all of you?
Cervical
Cervical
spondylitis.
Cervical spondylitis.
Myelopathy or spondylitis. And one more. If I add on UMN, LMN, plus I just say early sphincter was involved. Sphincter can be involved in cervical myelopathy also. They can have autonomic dysfunction. Patient can be incontinent, urinary incontinent, fecal incontinent, right? But if I say early bladder involvement, early sphincter involvement, answer would be
multiple sclerosis.
Conus
medullaris.
Perfect. So you have got the crux, right? This is the crux. This is the crux, and this is high yield. This is very important for your neurology, especially for the exam. If I say early sphincter involvement, then answer becomes conus medullaris. And I believe you all know which are the reflexes will be involved in conus versus in quada, right? So conus versus quada is important. We'll revise in our neurology day also. Okay, now moving forward.
Cervical myelopathy is UMN plus LMN and radicular pain, right, sir?
Yes, yes. Or you can say spondylosis initially. But yes, myelopathy is nothing. There's a pathology in the spinal cord, in the cervical area. So the patient presents with the upper limb. So they can have lower motor in the upper limb and upper motor in the lower limb. Is that okay?
Yeah. Thank you.
What is the
And remember with the cervical, always remember sphincter dysfunction and autonomic dysfunction also. Remember, these are the key points you have to look for.
Okay.
But there is what is the pattern in tabes dorsalis?
What is the
pattern in the tabes?
Yes, tabes dorsalis also involved the posterior column, but that is what I said. Keep that as the sixth one. And you have a history. You have a history because tabes dorsalis is the tertiary one. It happens after years. Patient has syphilis in the background, and if that is the picture given, obviously the answer goes in favor of tabes dorsalis. Right? Okay. Now moving on to the fourth one. We are still in the fourth. It's already half an hour. Yeah, we need to speed up. Question number 4. Can I have the
Androgen
answer? Why?
abuse.
Testicular tumors.
Testosterone secreting.
Excreting.
Why? And I have, especially for the first 20 question, I have kept the question where there's a discussion where there are concepts being involved, and definitely I'll be focusing more on the concept, more on the points which has been asked in the exam. Now, you mentioned testicular tumor, right? Some of you. Why can't yeah, yes.
Yeah, so basically I answered as androgen abuse.
Good.
And I was thinking
This is
it's
what I
Yeah,
either
even
A or
me.
B.
For that, why not that question?
The history of androgen abuse.
Androgen
I
abuse.
thought it was androgen abuse. Yeah.
Good, good.
So basically, when I answer, I was thinking either A or B.
Yes.
Both of them, they come with high testosterone and they have negative feedback, so they have low LH and low FSH. Both of them, they're not. They have normal prolactin, so they fit the picture. However, the tumor goes with more progressive feature, like in this patient. It happened within few months.
True.
The only thing that made me at the end to choose androgen abuse, even though there wasn't anything mentioned, is that I thought there is testicular atrophy. So in the tumor, there is usually a mass.
Yes.
But in the androgen
Yes,
abuse,
sir.
there is usually testicular atrophy, and he's young. So I know that it is progressive, so the tumor goes best, but then there is atrophy. So I wasn't sure, and I thought I'll just pick it. I'll pick A because of the testicular atrophy and not a mass.
True. Perfect. Perfect. So right thinking, right kind of confusion, and obviously these are the two options which are very confusing, very nearby. Now I need to know the facts. Dr. Hani has already mentioned. First of all, I'll help you why we are thinking and considering these two options. How does a patient of Klinefelter presents?
They present from
That
birth.
Androgen
Younger
insensitivity.
age itself, you'll be able to identify.
Androgen sensitive.
Testosterone
Testosterone will be
Taller,
decreased.
female, like
over. Answer over. Testosterone is low in Klinefelter, so hence this is ruled out. If I talk about androgen insensitivity, what happens?
Testosterone is again.
No hirsutism, no what?
no
Female
testosterone.
characters is high.
Female characters.
And LHS.
It will be
High.
What happens to LHFSH?
high.
High.
High,
Very
high.
Why? Because androgen, the name itself says androgen insensitivity. It is not able to act. It is insensitive, right? Why? Because these are the patients who have a normal female phenotype, but actually they are XY. Now with that,
Also, the testosterone is normal as well.
yeah, testosterone can be
Androgen.
normal to high, can be normal to high. But what has made the difference is high LH and FSH in a case of androgen insensitivity syndrome. But over here in the question, you can see both of them are provided as a low. Why? Because the pituitary is trying its level best to stimulate the gonads, but it is not acting, right? It is insensitive. And that is the reason LH-FSH in these patients are pretty high. And that just goes away. So this option is also out. A primary hypogonadism, what do you expect?
Low
Everything is going to be low.
Increase LH and FSH.
The first thing is hypogonad. That itself says low testosterone, low estrogen. But this patient has a high testosterone. This is out. Now you are left with these two options. And very rightly mentioned that why not androgen abuse? Can anyone answer? When do we consider androgen abuse in a question? What should be the clues? What are the hidden things?
Bodybuilder.
History of going to gym.
Bodybuilder,
Exactly.
gym.
If they provide, patient has is into muscle building, goes to a gym regularly, or they say presence of gynecomastia or gym, remember, answer becomes first. But none
But
of
sir,
them.
doesn't increase muscle bulk.
It's a but muscle
Sorry.
bulk is there.
It
Increased
says
muscle bulk.
muscle bulk. Yeah.
Yes, increased muscle bulk, but they don't. So that increased muscle bulk is because of testosterone. What is the role of testosterone? It increases
Muscle
muscle mass.
It increases, correct.
That's it. That's a masculine nature, right, of testosterone, that it increases the muscle mass. If you have a testosterone person has a 38, definitely muscle mass will increase, whether he or she is going to gym or not, right? But
I think
if
just that one thing pulled me to
Yeah, same.
yeah,
Yes,
I know.
that
That
way.
is why. That is why this is
I
MRCP. This is called as MRCP. The pro questions of MRCP, right? So they are
So then
in
the
this mock.
testicular atrophy.
In this mock, I have tried with 20 questions, right? Especially Dr. Harini. And these 20 questions seem to be somewhat confusing with these nearby options. Which one to go for? Is it so? If you are stuck with A and B, this is what I want. If you have marked any option from these three, no, you need revision. You need revision. And in the exam, if that just clicks you, right? That yeah, there is no mention about gym build, going to the gym or patient person into a bodybuilding. If they have not mentioned or they have not mentioned about association with gynecomastia, this is again ruled out. So this question is particularly a confusing one, a difficult one, right? Okay, so this is how we need to interpret. This is how we need to rule out, and these are the questions I would say, Dr. Mayuri, to your question, to your doubt, is please flag the questions when you are attempting it. Wherever you are stuck between two options and those are very nearby, just give extra seconds, extra minute at the last. Okay, now moving on to the fifth one. A simple question, I believe.
Yes.
One of the simplest question, right? There are many other simpler question, but yeah, this is one of the simpler question, right? Perfidone. What is the another anti-fibrotic agent?
Nintedanib.
Yeah,
Nintedanib.
nintedanib. And prednisolone is not used. It usually worsens the scenario, right? So IPF, and what they have provided is FVC 70%, and they have already given all the information, right? And for pulmonary fibrosis, definitely we have to go with an nintedanib or this one. When do you go with, if I talk about ILD, which ILD you use steroids?
When it's FVC decline 10%, something.
Which are the conditions? Acha, what are the conditions which are related to your ILD?
Patient hypoxia.
Causes.
GPA, craniomatous polyangiitis.
COPD and asthma.
COPD asthma is not under ILD. COPD asthma is obstructive.
GPA.
Those are under RLD.
Idiopathic
Fibrosis. Can I have answer from one? Can you please raise your hand? Can you please raise your hand? Okay, Dr. Honey, can anyone also try answering? Dr. Sultan, okay. Dr. Sultan, yes, go ahead.
Sir, I think there is a fibrosing alveolitis, and there is a pneumoconiosis.
Okay, pneumoconiosis. Okay.
And there is
sarcoidosis.
sarcoidosis.
Good. Sarcoid. Sarcoid is the one I was looking for. Or patient presenting with connective tissue disorders. Let's say patient with rheumatoid. Patient with systemic sclerosis.
Scleroderma.
Yes, scleroderma. So with systemic sclerosis, they present with ILD. And very commonly what you use is immunosuppressant plus minus steroids. So steroids are used. The other one could be very important are the sarcoidosis, which is involved with ILD. Then another one which has been asked recently in the exam is EAA, or you can say hypersensitivity pneumonitis. So these are the cases where you will go with that. Wait a minute. You will go with
Steroid.
the steroids. Otherwise, when they talk about pulmonary fibrosis, the only thing you have to consider for pulmonary fibrosis is either nintedanib or pirfenidone. These are anti-fibrotic agents. There is no role of steroids. In fact, steroids worsens the scenario. Remember that. Hypersensitivity pneumonitis is a hot topic, right? There's one more question, I believe, right? I'll discuss about bird fancier and all those questions. Okay, now, so pirfenidone done. Coming on to the next one. Was this question easy one or a difficult one or a confusing? Can you just let me know?
Easy.
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 I felt a little confusing there.
Yeah, this was a bit confusing, but I got it right.
Initially, but
Every time it
later
was confusing for me. I tried lots of questions, but still I wasn't able to figure this HPSAG questions.
Okay, so I'll just try to help you out in a matter of two or 3 minutes. Now, always first of all see about HBsAg, the antigen. If it is positive, what does that mean?
infection.
He is infected.
Acute
Active.
infection.
Okay,
At some point.
Chronic.
he is infected at
Infection
some point of time, and right now maybe just a carrier. Maybe just a carrier, right? So it just says patient maybe in an active state or a carrier.
Yes.
Further, to see whether it is infective or not, or in that active phase of replication of hepatitis B or not, what you look for are two things. One is HBe antigen, the other one is HBV DNA. HBV DNA mentioned as undetectable. That means it is not there, it is not replicating, the DNA is not replicating of a hepatitis B virus. HB antigen negative, obviously there are something called as pre-core mutants, right? You might have those, but if they say HBV DNA also undetectable, then yes, it is not active. And one thing I can say is this is inactive. That is very sure. With just HBe antigen and HBV DNA. Is that okay, Dr. Kasturi?
Yes, sir. For active, we have to check for both HBe AG and HBV DNA, both.
Yes, yes.
Okay.
HBV DNA, we always see the copies, how it is multiplying. Initially, in the initial months, it can be just 2,000 copies. Then it multiplies to 10,000, then 200,000. So that is the multiplication. So one value is not important. But yes, if they say, let's say 100,000, that itself says the virus is replicating.
The quantitative analysis, no, sir?
Yes, yes. So it depends upon the quantity. You have to see the serial values. But if HB antigen is given as positive, that means infectivity is definitely there. If both are provided, sure, active disease, right? Active and replicating. Plus, now they have given only this information about hepatitis B, only this. So if it had been active, definitely what would have in the picture? HB antigen would be positive. HBV DNA.
DNA.
The other scenario is patient is a carrier. So inactive hepatitis B carrier, this is pretty sure with the first thing.
Okay.
When we go on to hepatitis C, what they have mentioned is antibody is positive. That means, yes, patient might have, which is a very common scenario to have a co-infection. And if we see the risk factor mentioned is a IV drug abuse. And very commonly, they get infected with Hep C. So patient having chronic hepatitis C co-infection, this is the only option available. Now this might feel, I would say, let's say in the exam, this might feel difficult. But if you see the option, none of the four options are giving you confusion. It is very straightforward option actually. It might look complicated, but it is very straightforward. Now, I would like to ask, what is the relevance of this ANA and immunoglobulin G provided?
Autoimmune hepatitis.
Chronicity or
good.
And
But they are trying to confuse you is with autoimmune hepatitis. But 1:40 is nothing. It is positive, but it is nothing, right? And it is 1:60. Definitely it is on a higher side. So it's almost slightly positive. Then immunoglobulin G, again, they say borderline elevated. So this is not autoimmune. And with this risk factor mentioned, IV drug user, you are not thinking about. And why the hell Hep C antibody is present in autoimmune? Why will they give you a Hep C? So all these things in a holistic approach, it should match, right? So please do not go with autoimmune hepatitis, not at all. IgG would be through the roof, very high, not a borderline in a autoimmune hepatitis. Are you able to get that? This kind of question?
Yes, sir. Got it.
Great.
Sir, and if in options they are giving inactive and carrier, they'll include both this, right, sir? Inactive carrier, the phrase they'll mention it, right, sir?
Yes.
The people who are carriers, they'll be inactive, right, sir?
Yes. Now, the other thing could be acute or a chronic. How do we say in a hepatitis B? It is acute or a chronic one?
IgG,
IgM,
IgM.
IgM and IgG.
IgM.
Acute.
For these are antibodies for
Surface.
Antigen, surface antigen.
Core antigen.
Surface
core antibody.
core antigen.
BC.
Core antigen.
anti-HBC, right? So this is a core. So this is how you need to differentiate. First of all, see whether the patient is active or not, whether the patient is carrier. And third, remember whether the patient is in acute phase or a chronic phase, right? Okay, now moving forward.
Sir, the order is?
What is a biomarker for a patient who is immunized?
Only HbS antibody.
Anti-HBS antibody.
Only that. That has been asked 2 times in the exam. Only HbS antibody present, that's it. Right? Everything else will be negative. Why? Because you are giving smaller dose of the antigen itself. So what do you expect your body to have a response as developing an antibody to HbS? That's it. And this is what you give as a vaccination, right? I believe you all are able to understand.
Yes.
Definitely, I'll go more into depth and we'll just discuss with all those points in our revision session. So don't worry.
Sir, could you please repeat the chronology which you said? What is active, this thing, chronology you said, right?
So first of all, you need to check whether patient is an active or an inactive disease, right? Which is taken care by HBE antigen.
HBE and HBV DNA.
Second, I would say is checking whether the patient is a carrier or not.
Okay.
Just remember, patient HbS is positive. Third is checking acute or chronic. Right? Is that okay?
Okay. Yes, sir. Thank you, sir.
Most welcome. Question number 7. This is a lengthy one. So this is the kind of question I need to discuss. Now, when you come across these kind of questions, again, restrict yourself. See what is being asked. The patient is concerned about his deteriorating renal function and ask whether any medication should be changed. And with that information, when you have practiced so many times the questions, and when you have heard in the sessions also that yes, they might be talking about inhibitors. You have seen there's no point right now going with this STEM 59 year with hypertension. They are confusing you. They want you to waste time. So right now you have to emphasize, see the lab values provided that 3 months ago, this was creatinine. Today it is 117. It is not much of a rise. Hardly, I would say 10% rise. Then EGFR, it's almost the same. And it is definitely more than 30 ml per minute. Potassium 4.7 and now 5.2. Then urine ACR is 70. It is almost the same. And HbA1c. Now, if you have these options, there is one option which somebody might have selected is discontinue metformin. Is there someone who has selected the E option? If not, what is the criteria? When do you discontinue metformin?
EGFR less than 30. Less than 30, we will optimize the dose.
Yes. 30 to 45 is used with a caution.
Reduce the dose.
But you can, right? And obviously the answer goes to, which is the answer to this question?
Continue.
Less than 10 to 15 hours.
So you need to continue. Why? Because obviously, and then when you have they are asking which are the drugs. Search for the drugs mentioned. This patient is on metformin and indapamide. Now, and also there is a ramipril also. Search for these drugs. Now, if these 3 drugs are there, obviously you have to search. Is there any contraindication or not? Is there any problem with them or not? Obviously, you can continue, right? So this is how you should evaluate. This is how you should approach a lengthy question. Starting always from the last, which is being asked. Then there can be scenarios where a list of investigation is provided. Try to search in between them and see how the patient presented. It is reviewed. Patient just comes for a review, right? Not in an acute state. And they are not concerned. They are just asking what is the next step, right? Okay. Now moving forward.
So just one clarification, sir. So metformin we are not giving, sir, because EGFR is not below 30.
So we are
Which
not
would
discontinuing. Yes, we are not
okay.
If
That will be if the CKD, chronic kidney disease is there and it is less than 30.
Yes, if I say it is the creatinine has rose up to 250, the EGFR approx, I would say, has dropped to 25. Obviously, the contraindication, you have to discontinue metformin in this case, right?
Thank you, sir.
Welcome. Question number 8. Again, an easy question, is it or not?
Yes, sir. Abdominals.
Rhabdomyolysis.
Can you please raise hand and talk about just 1 minute for rhabdo? What happens, how it happens, how to look for rhabdo, how to manage? Rhabdo is an important one. Apart from Dr. Sultan, Dr. Priscilla, yes, go ahead, please.
I think in crush injuries, you can see when there is muscle injury, especially, and I think long seizure attacks would be another clue. But CPK will be elevated. You can see myoglobinuria in the urine. Yeah, LDH will be elevated.
Good.
And here the main clue is hematuria, that is myoglobinuria and CPK elevation.
Why this patient is at a risk of rhabdomyolysis? Why are you considering? Why are you thinking? What's the risk factor?
The homeless male found stuporous, probably lying a long time and no one is.
Okay. Stuporous, okay, which
History of alcohol.
responding, okay, it might
So
be
alcohol, yeah.
good, perfect. Alcohol abuse, first of all. Second, what is the other risk factor?
Mobility.
Yeah.
Lack of mobility.
Immobility, okay. Immobility,
Prolonged immobility.
plus hypothermia. What do you mean by rhabdomyolysis? Why rhabdo in this case? First of all, alcohol is a myotoxic. It is toxic to the muscles, and when there is a muscle breakdown, myolysis, it's a breakdown of the muscles, and that is the reason you have CPK released, you have LDH released in the serum, you have potassium on a higher side, magnesium, everything is on a higher side except for one electrolyte.
Calcium.
Hypocalcemia goes in favor of, I mean, in both the situation. One is called
Tumor-lysis and rhabdomyolysis.
Good. Now I need to know why hypothermia.
Hearing.
Yeah.
Dehydration.
And why a patient who is immobilized? You might have seen, right? You might have practiced, we might have discussed also, patient lying in the kitchen, patient lying in the living room for 2 hours, 3 hours, unnoticed. And the patient is at a risk of rhabdomyolysis. Why?
Dehydration.
Okay, dehydration. Okay. So when a person is lying in this scenario, that particular area, the dependent area, goes into pressure necrosis. And muscles, there is a lysis of the muscle. So that is the explanation. Plus, for a hypothermia, again, there's a tissue hypoperfusion in a hypothermic state. And with that tissue hypoperfusion, there's a muscle lysis. So all these three risk factors there. Homeless, stuporous, yes, but you can consider, but you can assume patient might be lying, but that is assumption. Alcohol abuse is given, hypothermia is given, and definitely this is going in a direction of rhabdomyolysis. How to manage rhabdomyolysis?
IV fluids.
Just flush the kidneys with the fluid. Just flush the kidneys. Good. So that is for rhabdomyolysis. That is scenario 4. Yes, also. Okay. 9th is again a fact which I believe you all know.
Yes.
Simple one. A simple question. Is it?
Yes.
Yeah.
Antithrombin 3 reactions.
Why?
Because heparin has to act on antithrombin 3 for it
To activate it.
Yes. Heparin combines with or uses antithrombin 3 and acting on thrombin and 10. Right? So yes, if there's a deficiency, what they have asked, which would explain her thrombophilia and her heparin resistance. If antithrombin 3 is deficient, it will not be able to act. Right? So this is the question which is asked. So this is a fact which you need to know, that heparin works by binding to 83 enhancing inhibition of thrombin. So it is acting on thrombin and factor 10A, which you all know, right? So but it requires antithrombin 3. If it is absent, obviously heparin will not be able to act. That is what the question is. Okay. Question number 2. Yes.
I have a confusion regarding question number 7. I was just wondering, since the eGFR falls down to 42, why we can't half the dose of ramipril, like from 10 to 5?
What are the indications of holding or withholding ramipril or ACE inhibitor? Where is the question? 7th, yeah. Two indication in terms of one is
Hyperkalemia,
eGFR or increase in creatinine. How much will the increase in creatinine?
So creatinine
25% in creatinine.
eGFR
25%.
Yeah?
More than 30%.
More than
30%.
30%.
So
Creatinine.
creatinine increase more than 25% or 26 millimole per liter. eGFR decrease than 30%.
Is it this or the other way?
It's the other way. Creatinine is 30 and eGFR is 25.
Wait a minute, I'm getting a call. Sorry. Yeah. Creatinine, if it increases more than 30%, remember that. You have to withhold, you have to stop ramipril. And eGFR, if it decreases more than 25%, you have to withdraw. Now, in this case, Dr. Sadia, 51 to 42, hardly a decrease. There's not a decrease.
Okay.
We are talking about 25% decrease.
Okay. All right. I was just focusing on eGFR, but it's still not that decreased. Yes.
They wanted you to stress on that. This is what they want. So anyhow,
Yeah.
you have to just keep your eyes, your brain open. Is it a trap or is it actual scenario that you have to withhold? And in the exam, I would say, I might have mentioned earlier also, 90% for this kind of question, you have to continue and observe for a ramipril. They will give a slight increase and you would think, why not to stop? Patient has macroalbuminemia. So high, right? ACR is 70. Can you think? And with that, you have to continue ACE inhibitors. That is the thing. If you decrease, that's a worsening for the patient. So definitely you have to continue. And answer 90% of the time will be continue or maybe observe. But remember, if it is 30% increase from the baseline, you need to withhold, right? Okay. Question number.
For that question, it is like stopping ramipril or like observe, sir?
In that question, you have to continue.
Yeah.
Right, in 7th question. Okay. Now, question number 10th.
Idiopathic pulmonary fibrosis.
Idiopathic pulmonary fibrosis.
Pulmonary fibrosis.
Idiopathic pulmonary fibrosis. Reason? What are the hints being provided?
Lower
Reticular shadowing on the X-ray.
Lower fibrosis.
Okay.
Lower zone fibrosis.
Progressive
Lower zone
breathlessness.
fibrosis.
Okay.
Reticular shadowing basal volume loss.
Okay.
End inspiratory crackles.
Is it a occupational disease?
Construction farm.
So
Yes.
that's
Asbestosis.
Construction farm.
If asbestosis.
Yeah. Go ahead.
The project
PD courses.
not exposed to
All those who were there in the workshop in the UK, in the London. Are you there? How many are there right now? And we discussed similar question, almost this question in our Q&A part. Were you able to recall that? No?
Yes. Yeah.
Dr. Shruti is there. Dr. Gayatri, you are also there. Okay. So what they again are trying to confuse you is construction firm, but patient is just a project manager.
Project manager. Yeah.
Right? And often visiting multiple sites across the country. So this is not a risk factor. If a person is working in those sites, obviously that increases and that goes in favor of occupational lung disease, not this one. And if I talk about the presentation of ILD, very important examination finding is end in
Velcro.
It's very, very, very important, right? So this is very important. And obviously, the other thing which they have mentioned is bilateral basal loss, volume loss with reticular shadowing. This is a typical how we explain about ILDs, right? So definitely it goes in favor of, what is the answer?
Idiopathic pulmonary fibrosis.
Had it been they have given any clue about occupation with, let's say, pigeons, answer would have changed too.
EA.
But the patient will have systemic features, right? Right now, what they say, there is no fever, there's nothing. Patient definitely will have systemic features, acute exposure, and there's a antigen exposure, plus there will be systemic symptoms present in the patient having fever, having chills. Okay. Now moving on to the question number 11th. A neuro question again. Answer and why.
Spinal artery syndrome.
Yeah.
Everything is
Because
involved
the
except the
Everything is involved
posterior
except
column is
the
preserved.
vibration.
Posterior
column is
spinal
preserved.
artery.
So this area, the posterior area, right? Over here, you have spinothalamic, you have corticospinal. Obviously, the anterior two-third area is supplied by anterior spinal artery. If it is gone, definitely patient will present with both the features, having loss of pain and temperature and involvement of the corticospinal. Plus, what is being preserved?
Dorsal column is preserved.
Okay, there is a mark on the screen. Can I request to please erase? Otherwise, wait a minute, I'll just erase by myself. Yeah. Okay. Now, the next, so it is anterior spinal artery. Brown Sequard, how does the patient present?
Resection of cord.
Contralateral loss of pain and temperature.
Inside,
Ipsilateral
That means
weakness.
you all know it.
Ipsilateral weakness.
I'll just go forward. Okay, question number 12.
This is DPT and SLE type.
Diffuse
proliferative.
Diffuse. Reason? Why diffuse? Why not the other one?
Type 4
SLE.
SLE is present.
1%. Dr. Ajila. Why?
In SLE, there's type 4 diffuse proliferative glomerulonephritis, which is kind of a mixed picture.
Which is a mixed.
Which is.
And over here, first thing we need to be sure, patient has hematuria. 3 plus protein, 3 plus blood.
Protein.
So there is a hematuria. Now, definitely this goes out, this goes out. Plus, membranous, which is a part of nephrotic. What are the conditions in nephrotic? What conditions? 5 conditions which comes under nephrotic. Can I have the answer?
Minimal change disease.
1%. Dr. Kuteja. Dr. Kuteja, please.
Yeah, minimal change disease, membranous and focal segmental, and then diabetic.
Good.
Okay.
Amyloidosis.
Minimal change disease and FSGS. They are almost the similar. It depends upon the steroid responsiveness of patient, right? And obviously MCD are the children's with pediatric age group. Then you have the membranous. Very commonly they will mention about malignancy. Remember that. Then you have diabetic and amyloid. Now, SLE, you have these 6. And out of that, the more common one or the severe one, I would say, because patient presented with 3 plus and there's a worsening of the symptoms. Now, diffuse proliferative presents with severe form and especially the nephritic features because again, patient has hematuria. Mesangial is another option, but very rare. And it presents with a milder state, not a severe state, as in this case. That is the reason answer becomes diffuse proliferative. Again, has been asked in the exam. It is more commonly seen in SLE. Okay, question 13th.
Sorry, to go back to the question, because as far as I know that
I don't know what you mean by hastily you have the section out of that.
Yeah. Sorry, SLE was the Siri was trying to help us out with the previous question. Anyhow.
Yeah, I was saying that because of membranous can also present after SLE. So I chose the right one in the mock, but I was also confused that why not membranous, because it can also be caused by.
Membranous will not
Left
have hematuria. This is why I discussed nephrotic.
Oh yeah.
Nephrotic
Yeah,
has
yeah.
proteinuria mainly. There might be a situation there can be 1+. 3+ is actually very great. You will call it as nephritic state.
Okay.
Not a nephrotic state, right? So that is the reason I just marked nephrotic out, MCD, minimal chain disease out, membranous out. Is that okay?
Yes, thank you.
This is the way you have to approach your questions also. You need to have that hint, 3+ blood, rule out all the nephrotic syndrome or the condition associated with nephrotic, right? Okay. Now moving forward to the 13th question, which I believe is an easier one. They have asked, see the last line. Which of the following is an indicator of severe OP poisoning? Now, what will you get after eating whole of this unnecessary information? They just ask.
respiratory failure.
So respiratory failure.
That's it. You have to select, you have to read the options, and that's it. That will not change based on the situation provided above. And you are exhausting your mind by reading from line 1, a 40-year-old male presented to you in emergency department, the blood pressure so and so, heart rate so and so. Why? Start with the last line and many other questions. I would say out of 100 there will be 15-20 questions which makes the sense in the last line itself, and your differential somehow narrows down. Are they asking a diagnosis? Are they asking a contraindication? Are they asking a surgical procedure or a medical therapy? So your differential actually decreases, right? Your mind somehow narrows down that yes, you have to look for an investigation of choice. You have to look for a management option. So anyhow, now 13th. What is so they have asked severe OP poisoning. Obviously, the severe one remains respiratory failure. I don't need to explain much. And you have all those cholinergic excess, salivation and lacrimation and diarrhea and incontinence, all those things. Okay, sludge.
So wouldn't you see a small pupil also for no?
Why will it be indicator of a severity? If it is, let's say, a meiosis, very small, how will be that severe? That is an indication. You know, OP poisoning, there's a meiosis, but that is just giving a differential. Patient might be having OP poisoning. That doesn't say it is a severity. If it involves the respiratory muscles of a patient, if patient is a respiratory failure, that is a severity. Did you get that?
Yes, sir. Thank you.
So again, you have to look for what is being asked in the exam. They're not asking which are the features which goes in favor of OP poisoning. All of them can be present. But what they have asked is severity. Severity, definitely, if patient has respiratory failure, that's a severe situation, right? And a lethal for the patient. Like can be life-threatening. 14th, any question about ABG? And someone mentioned at the start, was talking about
That was me.
Dr. Arshia, yeah.
Yeah.
So we'll start with Dr. Arshia. Can we have
Okay.
this answers? Can you please try attempting it?
Okay.
Was that
So
correct in the exam during the mock? You attempted it correct?
no, I got it wrong. So I was confused between A and B,
Okay.
and I selected A, and the answer is B.
Okay, good. Now, I'm happy. I'm glad that you were able to narrow down to these two options, right? You ruled out the other three. First of all, if we come and see this question, they're talking about COPD.
Yeah.
FeV1 is reduced. She has an oxygen concentrator at home. Examination revealed depressed consciousness, respiratory rate of 24 with a shallow breath. They were decreased breath sounds with minimal air movement. ABG was performed. And if you see how she presented, which is also important in the STEM, present with a 5-day history of progressive, 5-day history, right, of progressive shortness of breath. Her family brought her the increasing sleepiness during the last 24 hours. Now, patient has been diagnosed COPD 3 years ago. Now, in a COPD, what do you expect pH to be? Just answer it. Will it be lower on a lower side?
Lower
Lower
side.
side.
Lower.
Acidotic.
Acidotic.
Acidotic. PaCO2 in
Yes.
COPD patients, what do you expect?
Yes, we high. High.
And
High.
the term which we use is called as permissive hypercapnia.
Yeah.
Carbon dioxide is on a higher side, but that is permissive level for a COPD patient.
Yeah.
Then what do you expect bicarb to be in this patient?
Compensating.
Compensate.
Is it normal or high?
Normal
Normal
because
or
of
high?
compensating.
Somewhat high, sir.
High because of compensating of PCO.
Exactly. Exactly. It'll be high. Why? Because it's been 3 years. Now the metabolic component of the renal system has got the time to compensate. Had it been it's a matter of, let's say, decompensation in a matter of minutes. Your renal system is not able to try, doesn't compensate. But it's been 3 years. Now with increased PaCO2, your body, the patient's body will try to compensate, try to get that bicarb in the level so that it goes to an equilibrium. The patient's body is trying its level best, right? I have discussed the ABG in detail that it is about the acid and the base. Now, if acid increases in the body, the compensatory mechanism of the other system is increase the alkali. Now, if PaCO2, which you just answered that PaCO2 is expected to be high in a COPD patient, definitely what you expect bicarb to be high. Are you does that make sense, Dr. Arshia? Are you able to understand?
Yes. Yeah.
Now, with this information, because you only answered this, right? And I believe all of you are also able to go with that. Anyone not understanding this point? Anyone?
Sir, how come this pH will be like so low patient presents with this condition?
Which low? Are you talking about option A or option B?
Initially both, sir.
Both. There's a major difference between option A and option B.
No, because I was thinking that it was been 3 years.
2 is a lethal as a life-threatening scenario. Right now, how they presented a patient, this is what I mentioned. 5-day history of progressive 5-day history of progressive shortness of breath. So it's being prolonged. And right now, the only thing is increased sleepiness. Why? Patient might be accumulating.
Over-oxygenating.
And I'm so sorry, over here, the options are given in millimeters, but in your application, in your mock, it might be in kPAs.
Yes.
Yeah.
That. It might
Yes.
be.
It's in kPa.
Yes, I changed that, but unfortunately not able to change over here in the PDF. So what I would just say, in a COPD patient, what do you expect CO2 to be high? Why? Because there's an accumulation, there's a retention. COPD itself says obstructive lung disease or obstructive pulmonary disease. The patient is not able to exhale the CO2 outside. There's much retention, and that is why, if you remember, I keep saying residual volume higher side, TLC higher side. So there is retention. There is a retention of CO2 inside the patient. So if CO2 high, the body will try to increase the bicarbonate also so that it compensates. And out of these two options, obviously the second option seems to be better. Why? Because bicarb over here is 30. Option A, it is just 24, which is not, cannot be the scenario. And this option answer would be, how do you interpret option A?
Acute acute respiratory failure.
Crisis with compensatory metabolic
acidosis.
Good, perfect. I would say this patient has respiratory acidosis plus metabolic acidosis, because what I expect this patient to have with a PaCO2 on a higher side, which I believe in your STEM might be around 7.5 kPa or 7 kPa, something
9.3. 9.3.
9.3 in option number 1.
9.3.
Yeah.
So with
9.3.
9.3 kPa, what do you expect bicarb to be around 30, 28, 29, 30 with the compensation formulas? But unfortunately, the bicarb is just 24. And that is the reason this patient has both acidosis. And hence, the pH has decreased so much to this level of 7.16. Are you understanding?
Yeah.
That the PaCO2 right now in the option A is less than in B, but pH is significantly decreased. Why? Because bicarb is an add-on factor. Bicarb is also less. So there's a metabolic disorder also. Kidneys are also not working fine. And that's the reason patient has severe acidosis, which is 7.16. Now, Does that make sense to all of you? Are you with me? Are you understanding what I'm trying to say?
Yes, sir.
Yes, sir.
Yes,
So,
sir.
Yes, Dr. Nikita. Go ahead.
Why not like option C? Because it has like 7.35 to 45 would be the normal range, right? So like from B and C, I was thinking that the pH wouldn't be that deranged. Rest everything is more or less the same. Like bicarbs are 30-30, oxygen is increased, and carbon dioxide is like the similar pattern.
Okay. What about others? Anyone has the same doubt?
Yes, I think I thought the same as well, that why the
same
pH would be low.
B and C option. Which one? Which one would you select?
C.
Which one?
C.
Second or third?
Third.
Okay.
Third.
Okay.
But the patient has consciousness is depressed.
Yes. Wait a minute. I'm coming to the answer. Good. But someone has uttered the correct answer. How does a patient, for all those who are answering C as the answer, how does the patient presented to the hospital, to the emergency department?
It can be breathlessness, not like
Conscious and breathless.
This is based on maybe hypercapnia.
What do you understand by increasing sleepiness?
Drowsy. Patient won't be drowsy.
Exactly.
Hypercapnia. Patient won't be drowsy.
Hypercapnia. So what do you expect PSU2 to be on a higher side? This is CO2 narcosis. And with CO2 narcosis, definitely the conscious level decreases. And that's the reason patient presented with sleepiness. It's not related to breathlessness right now. It is about CO2 patient has entered into a scene which is called as type 2 respiratory failure or CO2 narcosis. The CO2, increased CO2 has hampered the patient's, the female's conscious level. Is that okay with everyone? I'm just looking for PSU2 given in the C option. It is just 8. Yes, exactly. Now, if you compare, obviously, a PSU2 of 10 can be a scenario where patient is sleepy. Patient has depressed GCS, has depressed sensorium. So that's the reason B is the correct answer, not the A. And also, one more point to add on. What about the oxygen level?
It is quite high in the C, and I think B. It will be the COPD patient will come with hypoxic state with hypercapnic. So I think the C oxygen is 70 and B is 55. So.
And what is the patient using?
Oxygen
concentration. Yes, patient has type 2 patient might be hypoxemic also, which also goes in favor. So that's the reason, combining all the points, it's the B, which comes out the first, which wins the answer, right? Okay, so this is again a confusing one, but what I need you to know is how to approach, how to rule out the options. If you are stuck in the exam, it's not a straightforward question that, yeah, they are just asking what will happen to CO2, what will happen to the bicarbonate, what is a compensation? No, they are asking you to utilize your brain, utilize that concept, right? So again, this is the kind of questions which you have to spend time, or if you are in doubt, flag it, right? So always in the exam, I want all of you to manage the time effectively. That is another skill you need to have. You cannot spend 1 hour for just 20 questions. You cannot. So always, I keep saying, always set aside a time. 15 minutes for 10 questions. That is the smallest thing which you can do, right? 20 questions in half an hour. 40 questions in 1 hour. So this is the best scenario. 2 hours, you have 80 questions, and 2.5 hours over. Try to finish your exam in a matter of 2.5 hours, right? And try changing your speed accordingly. Some other times you might, you get these kind of questions where you are spending maybe more than a minute. So yes, that is required. But if it is exceeding more than 2 minutes in a particular question, please go ahead and flag that, come back later. Yes, Dr. Ramchandra.
So Sir, I got confused because of the respiratory rate, because it is quite high. So I thought their carbon dioxide will be washed out and.
Read the full line. Read the full line.
Sir.
Shallow breath. It doesn't matter if the rate I say patient has a rate of 35, then it doesn't matter. If it's a shallow breathing, patient is not expanding the lung. Patient is right now fatigued. Patient has a decreased sensorium. With that shallow breathing, obviously there is more accumulation of the CO2, more retention of the CO2. Is that okay? Dr. Suha?
Yeah, just because I don't want to extend it more than it is already, but basically what differentiated A from B is the level of compensation. Basically, that's I got it right, but
Yes, yes, true.
Yeah.
Compensation, which has changed the scenario, plus pH of 7.16 is a scenario where you have to intubate. Patient will not be just presenting with increased sickness. You have to.
Thank you.
Right? So patient is in severe acidosis, respiratory plus metabolic. But out of these options provided, the better, the most likely seems to be the B, where you have a compensation also, which you expect. Why? Because COPD was diagnosed 3 years ago. So you expect metabolic to be working. They have not mentioned anything about a kidney disease. Let's say they say there's a decreased urine output. Obviously, kidneys are involved. But right now they have not mentioned. So what do you expect? Because kidneys are working fine, alkali to go high as a compensation. Is that okay with everyone? Should I move forward?
Yes.
2 hours, we are
Yes, sir.
14.
Yes.
Are you all awake and well with me?
Yes.
Are there?
Yes, sir.
I need that motivation.
Yes, sir.
I need that energy.
Yes.
Please be with me, right? And if you yeah. So if you have a problem of waking up, only one thing, get your tea and coffee. You don't have to exit, right? There is no option. There's no option of backing out, right? As you have exam in next few days. So you need to be understanding the things, as well as obviously I'll just pace up after 20 questions or after 25 questions. The questions which are there are usually somewhat fact based or easier, doesn't require much of the concept, and then I'll just rush. Yes, Dr. Priscilla.
Like you said, if there is a CKD patient or any kidney involvement, then the bicarb would be low. Will there be like a metabolic acidosis as well in a COPD patient? So it will be like both mixture, like a respiratory acidosis and metabolic acidosis. Both.
If in the previous question I say for the past 6 hours, patient has poured less than 0.5 ml per kg per hour of urine, definitely patient is in metabolic acidosis also, and the answer becomes A.
Okay, great.
Goes into oliguric phase or anuric phase, obviously. Or maybe let's say they give a hint, patient has, I mean, you are giving a nephrotoxic agent to a patient, right? So obviously, so these are the things you need to consider when you are seeing. So the causes of the AKI can be patient in sepsis, patient in hypovolemia, patient with nephrotoxic drugs, right? So you have to just rule out. Okay, now moving forward, question number 15 is a difficult one, is a confusing one. How many of you were able to manage that? How many of you?
I thought this was
I think it's
or the went with
information.
Yeah, I thought it was
You had that smile on your face in the
And I
exam. Oh,
just
bubble
picked it.
contrast. Answer is PFO. We have heard, we have done, we have practiced so many questions. We cannot be wrong, right? But even
I was surprised to see that was not the answer.
yeah, you were surprised to see. Okay, but
I did notice that bubble is appearing late, 4 cycle. But still, I couldn't. Yeah, I marked wrong.
How many of you marked it correct? Dr. Lajwar,
did.
then the
No.
answer of E was in bold letters for you.
No, A was bold, sir. Atrial separated.
You answered which one?
I didn't read the questions. I wasn't aware of how to solve it.
Okay.
I didn't think it was patent foramen ovale, and the option in bold was A.
Okay. But why?
So that's
why the answer is E? That is the question. That is a big question mark. Why not PFO? Dr. Ren, are you there? The other person who have scored 82 in the mock, Dr. Z Ren. Are you there? Dr. Ren, who's there in the workshop? Are you there? Okay, no worries. Yes, Dr. Priscilla, Dr. Arshia, you are raising hand.
Yeah. So it's E, pulmonary AV malformation, because the microbubbles have appeared quite late, that is four cardiac cycles later. If it was PFO, it would be in the first 2 or 3 cycles.
Good.
Yeah.
Less than 3 cycles. Again, the scenario, you don't have to ratify, right? You don't have to cram it. If it is coming, the bubbles are coming over here and there's an exit, there's a path. Obviously, these will go to the other side. And that's what says it comes earlier in the cardiac cycles. Otherwise, cardiac cycle are full of the cardiac cycle, right? It goes throughout the systemic circulation, come back, right? From periphery as a preload goes. So if bubbles appear in 1 to 2 or maybe less than 3 cardiac cycles, answer is pathology lies over here. It is a PFO. But if they say later on, then there could be a possibility of pulmonary shunting. And very common answer for pulmonary shunting is pulmonary AV malformation. So they are taking time, right? They are taking time, but yes, they are appearing earlier, right? So after 3 cycles, yes, with all this history being provided, the other scenario or the differential would be pulmonary AV malformation. This is what you need to remember. This is an add-on extra information because you have done so many questions, you have practiced so many questions of PFO. But I wanted to add, and there is, I believe this is what I heard from one of the candidates from the previous exam as a recall question. The question was asked and they mentioned about a cycles. The candidates were not able to relate and recollect that were there 3 cycles or 4 cycles, and that is why they have this question. So remember, less than 3 cycles, PFO is the answer. More than 3 cycles, maybe 4 or 5 cycles, answer becomes pulmonary AV malformation. Is that okay with everyone?
Yes.
Yes, sir. Yes.
Intrapulmonary shunting, pulmonary AV. So 3 to 5 cardiac cycle, 1 to 3 cycle, right? PFO or ASD. Okay. Now, question number 16.
Sir, sir,
Yes, Dr. Shannon.
sir, in the previous question, can you please tell me what that sudden onset left side weakness and all is related with this?
Okay. Okay.
Is it because of thrombus formation?
Yes.
Okay.
It is going to the other side, but pathology, it has not moved from the foramen ovale. It has gone through a pulmonary AV malformation, right? So that's the thing.
Okay.
What exactly is the defect we're talking about
About
in the pulmonary AV malformation? Like where and what is shunted
so blood is being shunted. So
from?
passage from pulmonary circulation to the left atria. I mean, obviously from RV, there's a pulmonary circulation, then from pulmonary. So there's a shunting. There's a extra path or passage or a malformation where it is being shunted to the left atria. And now with that abnormal path, patient developed this embolus. But answer is not PFO. Are you understanding? Patient developed, this is called as paradoxical, right? Where it goes to the other side in the case of PFO. But over here, there's a shunting, or I can say abnormal path being mentioned, being created from, let's say, exit of the right ventricle to the input into the left atria. There's an extra abnormal path. That is a pulmonary AV malformation, right? Okay, question number 16.
Sir, one thing. This AST and PFO, like how to differentiate that?
Okay. Can I have the answer from the others? What is the difference between an ASD and a PFO? There's a difference, definitely.
Well, the PFO is basically closed all the time, and only when the intrathoracic pressure increases,
Good.
coughing, sneezing, etc., it transiently opens and allows the clot to pass. While
Precisely.
Yes.
But why, Dr. Sultan?
So because it's there is a slight gap between the ostium primum and ostium secundum, which is closed with like a flap-like thing. It is covering it, the PFO.
And you are working as a cardiologist, right? Is it?
Yes.
Pakistan.
Yes.
Here comes
Yes.
the answer from a specialist cardiologist. So now, very great. Thank you so much for explaining. Now, in a PFO, it is a patent foramen ovale. You have septum primum and septum secundum, right? They move in this direction during a development. Now, they are not able to close, and it behaves as a flap. It's not a hole. It's not a defect. It's just a flap. Now, if on the right side the pressure increases, it could be because of pulmonary hypertension. It could be because of, let's say, stenosis at the pulmonary valve area. So there can be any reason. If the pressure on the right side is high, now there's a shunting from right side to the left side in a case of PFO. Remember. Whereas in ASD, what happens? There's a septum, right? In the atria, there's a septum. Now, in between, there is nothing. There's a hole.
Yeah.
Previously, what I just mentioned, there's a flap. That flap,
Flap.
whenever the pressure on the right side increases. Now, Sajila, what will happen in the ASD? There should be the shunting of the blood, right to left or left to right?
Left to right.
Because there's a hole, exactly.
Mm.
Is that understood with everyone?
Yeah.
And
Is there any difference in the global study?
Yeah.
Different in the different answer for ASD and
Oh,
PFO.
both can have. Both can have. Usually, they will give you a scenario of PFO where you have to assume, and they will not give her that the pressure on the right side is increased. No. The answer, very common pathology seems to be PFO. But yes, ASD can be one of the option. And with ASD, what they will provide is a murmur. PFO doesn't have a murmur. Why? Because throughout, always it is closed. Whenever the pressure on the right side increases, now क्या होता है? If I further go into depth, although we are lack of time, otherwise I love cardiology and our cardiologist is also here, Dr. Sultan. Now you have embolism, right? Though some are the embolus, this goes into the pulmonary artery, they block it, and the pressure increases. Now with that, that flap opens, and the other embolus goes to the other side. Are you understanding? This is the physiology.
Okay.
Whereas
Yeah, yeah.
ASD, it cannot happen until unless again the pressure is high. There's a hole. If there's a ASD, definitely they will say there's a left to right shunt, or they will tell you the murmur. What is the murmur of ASD? It's a systolic.
There's a widely split S2 is there in ASD.
Widely split S2 is the one option which they can, one clue which they can provide, or they can say ejection systolic murmur. That's it.
Ejection systolic murmur.
Murmur cannot be present in PFO. Never ever. Is that okay with everyone?
Yeah.
Yes, sir.
Okay.
So, and the flow of blood in patent foramen ovale will be from right to left,
Yes.
and in ASD it will be opposite.
Yes, but not always in PFO. Always in ASD, it will be left to right. Why? The pressure on the left side is always high. But right to left, I'll just write it down so that you are not confused. PFO, right to left, only if right-sided pressure are high. RP is right pressure, right-sided pressures. But in ASD, it is always left to right shunt. Why? Because the pressure always on the left side is high. Right? Is that okay with PFO and ASD?
Yes, sir.
Okay. Next, 16th. We need to now speed up. Question number 16.
Men 1.
Why? Reason?
Multiple duodenal.
Because
insulin.
Pancreas is
Pancreas involvement.
Pancreas is involved,
and
pituitary is involved, and
Hypercalcemia.
hyperparathyroidism is there.
1%.
And pituitary involvement.
Dr. Tripathi.
Sir.
There's a?
Sir, there is involvement of pituitary, parathyroid.
How come pituitary?
So it is
because of primary infertility. Primary infertility.
Good. And there are duodenal ulcers.
Duodenals.
Favor of?
Ulcers.
This tells you?
Pancreatic involvement.
Pancreatic involvement.
Insulinoma.
Gastrinoma.
Gastrinoma, patient presents with increased gastrin, which is responsible for multiple duodenal ulcers. And when you have this kind of information, you have to think about men 1, right? Men 1 has three P's.
Pituitary, parathyroid,
pancreas, pituitary.
Pancreas.
We'll just move on to the next one, 17th. A simple question.
Diabetic.
Yeah.
Diabetic glomerular sclerosis.
Why? Reason? What's the reason behind that?
So because the patient is having diabetes, and so in urine there is proteinuria is present, 4+ proteinuria is there, glucose is also there, and 1+ blood is there, and so and serum urate is also high. So because of all these features.
Okay. All of you get that? What
Sir,
should be
but
the
I've studied in the
That's
past
shortage
paper
fixing.
regarding that.
Yeah.
And diabetic glomerular sclerosis will take long time to appear, and focal segmental glomerular sclerosis after diabetes will take a short time. So I option for the E.
Option for long-standing hypertensive with secondary. Okay. Okay.
So basically, it's
They're saying only
diabetic.
3 weeks, right? I thought it is a short time to get diabetic glomerular sclerosis, and the patient is having maintained by dietary management.
Okay.
So basically, because the patient has, there's one key information I think I missed in the exam, is that the creatinine is normal. So there's no glomerular nephropathy. So that excludes most of the answers. And then if you look at diabetes, usually we know there's early in the disease, it presents with preserved EGFR and significant proteinuria, which is the case here.
Exactly. Exactly. And hypertension, if you talk about hypertensive as the reason, it usually doesn't have this much of proteinuria. Can you please unmute your can you please mute Dr. 13 Pro Max? Wait a minute, yeah. So this kind of proteinuria is not. When you have a history, already a history, the more common reason becomes the diabetic glomerular sclerosis. Right? There's a history. There's always a history. So you have to think about. Again, we discussed about nephrotic, right? The 5 causes. Hypertensive. Did you mention hypertensive? Yes, it can, but it's not a usual cause. For a nephrotic, for this kind of proteinuria, it can be 1+, 2+, but not 4+.
Okay.
Right? And when we talk about hypertensive situation, the creatinine mentioned is just normal. When you're thinking about hypertension as the cause, definitely creatinine also goes on a higher side, right? So that these are the reasons why the answer becomes diabetic. Okay, now moving on to the next one, 18th. Yeah, 18th. A simple question again. I'll not waste much time. QT prolonged.
Sodium bicarbonate.
Sodium bicarbonate.
Sodium bicarbonate.
Reason is
TCA overdose.
QT
TCA
prolonged.
overdose.
TCA overdose.
Yeah, so this is repeatedly asked in the exam. Please do not make mistake. One answer is soda bicarb, right? Okay, because the reason is it is overcoming the sodium channel blockage, and it reduces the binding of TC to the sodium channel. This is the reason why we use soda bicarb in this situation. Okay, question 19th. Again, I can say a simpler question. You might feel a confusing one, but it's actually simple. What they have asked, which feature of the presentation makes the diagnosis of TTP more likely than HUS? Again, this whole information is not needed at all.
Confusion.
So TTP definitely
Neurological symptoms.
HUS, you have a triad. Now the difference are 2 symptoms or 2 manifestations. One is the fever, the other one is neurological manifestation.
Neurological symptoms.
Fever is non-specific, can be there with any other reason, right? So that's the reason you have to go with the better option is confusion, which has created the confusion in the exam. This option created confusion, but this is the right answer. Confusion. Is that okay, everyone?
Yes.
Dr. Pratibha, kindly mute yourself, please. Thank you. Question 20th. Question again on the spirometric findings. Can I have the answer now from your side?
C.
Okay. C. Reason?
So restrictive.
Restrictive factor.
Restrictive factor.
Dr. Vidya, can I have the answer, please?
C, because it's restrictive factor. Kyphoscoliosis causes restrictive lung disease, and then because FEV1 and FVC is significantly reduced, FEV1 is normal and TLC will be decreased.
And what else? Apart from kyphoscoliosis, there is one other hint, another thing which favors restrictive lung disease. Can I have the answer?
Obesity.
Obesity.
BMI.
Obesity.
BMI third. Okay, obesity.
So both, right? So it's an add-on factor. And definitely the TLCO will decrease, right? Okay. 21st. Simple question again.
Biliary cholangitis.
Simple presentation, very typical, very straightforward. Patient presented with just fatigue. This age group, a female, fatigue, plus isolated rise of ALP. Nothing much.
Cholestasis.
There's again cholestasis, right? And patient is has PBC. Okay. Now moving forward to, and what is the antibody? Specific
Anti-MI2,
Anti-MI,
M2,
IgM,
IgM and AMA.
M2.
Good. Okay. Now, and this is, remember, PBC is related to autoimmune disorders. So most likely, if they ask most likely antibody to be found, answer would be
ANA.
Please do not mark AMA M2. It is specific, but most likely to be found. Why? Because it is in association with other autoimmune disorders. And in this question, if I'm not wrong, patient has
Hyperthyroid.
thyroid.
There is a thyroid also, right? Okay. So that was a typical, a straightforward question for PBC.
But I went for Gilbert, sir, seeing there is no history of pleuritis.
Yes, sir.
Gilbert, what happens in Gilbert? Can I have the answer? What kind of
Only
presentation?
bilirubin.
Isolated rise of
Bilirubin.
Especially after some stressors.
Okay, which one? Conjugated, unconjugated?
Unconjugated.
And what happens to ALP and ALT?
Normal.
And is there any kind of stressor which is mentioned over here?
No.
These are the three things you need to remember about Gilbert. One, remember it causes unconjugated bilirubin, which is on a higher side. Second, there is normal ALP or AST or ALT. The liver enzymes are normal. Third, you always need a stressor. Patient met a road accident, or there's an infection going on, or any kind of surgery patient has to undergo. So there is a stressor to the body or stress to the body. Is that okay?
Yeah, okay.
Okay, great. And they don't present with fatigue. They present with usually yellowishness in the eyes. This is how they present, right? And in a stressful scenarios, right? Maybe any infection, something like that. Okay, 22nd. Again, a simple question, not a difficult one, I would say. Is it?
G6PD.
G6PD.
Good. So G6PD can happen, right?
Sir, the mnemonic 5 cans does not mention ibuprofen in that.
Okay. So I'm so sorry for that.
NSAIDs.
I'm so sorry.
And was nitrofurantoin, I guess.
Actually, it was nitrofurantoin first.
A with aspirin, and remember A with with the aspirin as the NSAIDs.
Even I was confused with the same mnemonic, sir, actually. There was no mention of ibuprofen, so I went for...
Remember, those 6 drugs or the group of drugs which we discussed are not the only one which causes G6PD precipitation. Remember, there are a lot of... If you just right now check with all the AI and all, you will get a number of drugs which are related to the G6PD exacerbation. But those 6 are the essential one which we discussed.
So yes, schistiocytes also we can take it for G6PD deficiency, the clue schistiocytes, right, sir?
Yeah. Again, now if we come on to the other options, there is no, right? There is no one which causes schistocytes or the fragmented RBC or a hemolysis after introduction of a drug, which is the option you selected, by the way.
Autoimmune hemolytic anemia.
Autoimmune, which is the other hint which is going in favor of autoimmune.
I went for PNH, sir.
You yourself are saying no. Okay. Yeah.
I went for PNH, sir. D, option D.
What is the one thing which you need for a autoimmune to say autoimmune?
Thrombocytopenia.
Coombs test for
antibodies.
Coombs test.
That.
You differentiate autoimmune versus non-autoimmune. Right. So Coombs test, they have not mentioned. So how can you say the patient has autoimmune hemolytic anemia? Right. So the only
but G6PD they can mention Heinz bodies also, no, sir?
Which one? Heinz bodies. Yes, yes. The other thing we need to remember are the hind bodies. True. Okay, then question 23rd. Not that difficult.
Endoscopy with small bowel.
Endoscopy with small bowel.
Most
Biopsy.
appropriate. Most appropriate medicine.
Patient has IgA deficiency. Patient presented with diarrhea, weight loss, rash on buttocks and posterior thigh. What does this signify?
Dermatitis
Dermatitis
herpetiformis.
herpetiformis.
Dermatitis herpetiformis with malabsorption. There's a these things mentioned. But further, what they have mentioned is anti-tissue transglutaminase is negative, which we expect. Why? Reason?
IgA
IgA deficiency.
We should actually check IgG, but they have not provided. Now what they have asked, which is the most appropriate next investigation? Out of the options provided. Out of the options provided.
Biopsy.
Although biopsy is the definitive one. The next you can go for a IgG, but they have not provided in the options. They have directly gone with the biopsy. Right? Okay.
For the biopsy, we need to introduce this gluten, right?
Yeah.
The biopsy for the accurate results, we have to introduce the gluten.
Yes, before that, yes.
So why not be the answer? First to introduce the gluten, then go for
No, that is a provocation. There's a trial. Provocation trial means what? You are trying to give gluten and see the symptoms. It doesn't say you are giving gluten and then going for a biopsy. Right?
Patient is already symptomatic.
The provocative trial means you are provocating a person. You are giving a gluten and seeing whether patient has increased worsening of the symptoms or not. Right? Okay. Now going forward is question 24th. A straightforward again. Protein, glucose, phosphate on a lower side. That means phosphaturia also. Glycosuria, phosphaturia, amino acid urea, proteinuria, everything out. Goes in favor of?
Fanconi syndrome.
And which type of RTA? Fanconi?
2. RTA 2.
Type 2.
Distal.
Good. Distal.
Proximal.
Good.
Proximal.
Which one? 2.
Proximal.
Is it a distal or a proximal one?
Proximal.
What about type 1 RTA?
Distal.
Type 2 is proximal. Please do not get confused, right? Type 2 and the proximal. Okay, then 25th.
MS.
Again, a typical question.
Yes.
A straightforward, a simpler.
Yes.
Right. So if you are not able to recollect, you are making mistake in this kind of questions. In the simpler question, I would say you actually have to, at this point of time, you have to take leaves from your job, manage your time, but you cannot make mistakes in such simpler questions. You cannot. It is a very, very straightforward MS question, right? So all the hint are being provided. Okay. MS is done, and all those you know the phenomena, right? Othos phenomena, Herpes line, and all those things. Okay, we'll discuss in our revision session. No worries. 26th, a difficult question for you.
Yeah, I marked dual chamber.
I did the dual.
I also marked dual chamber.
Okay. Anyone? Oh, we have our cardiologist, Dr. Sultan, with us.
So this is a scenario of AFib, and this is best treated with a single chamber ICD because the patient is not in sinus rhythm.
Okay, and what is the AFib? What is one thing you would like to again say, a prefix?
So we want to fix the rate at like 60 per minute.
Okay.
So that there is no Brady and the patient can.
Okay.
So it's a VVI pacemaker,
VVI.
basically. Ventricularly paced, atrial paced, ventricular stimulated, ventricular inhibited. So it's usually a single chamber
We can
pacemaker.
give a rate controlling medicine to control the tachy.
Okay.
There is no AV block in this.
Okay.
No AV dissociation.
What is the patient having? What is the syndrome? What it is called?
So basically 6 sinus flow, AFib, 6 sinus.
Okay. 6 sinus syndrome. And what is the management of 6 sinus syndrome? If I just ask 6 sinus, Dr. Sultan, one answer is
Pacing.
AAI. If you have a sick sinus with a normal conduction pathway beyond distally, answer is you have to place those electrodes, those leads in the atria. You have to sense, you have to pace atria, I is inhibited, right? Now, what they say, patient presented with complaints of palpitation to all those who are like, what is going on, pacemakers and all. Questions of pacemaker has been asked in part 1 also. Although this used to be a topic for part 2, but recently, unfortunately, they have asked in part 1 also, right? So I am just helping you out with that. Patient presented with palpitation, pulse rate was 40 and BP was on a lower side, 90/50. ECG showed irregular rhythm with absent P waves with ventricular rate of 40, which is good for the patient for the output. This is what we want to achieve. 35 to 40 is a good ventricular rate, right? That maintains the perfusion of the vital organs. Previous record indicate another bradycardic collapse and prior admission for rapid AF with a ventricular rate of 135. And this says patient has a Brady-Tachy syndrome. Now this says pathology lies above somewhere, right? In the atria, in the sinus area or sinus node. And this patient right now also presented with irregularity, which is an absence of PVA, which is AF. Previously also AF. So this patient has persistent
AF.
This is important. If you have a persistent AF, there is no point putting leads in the atria. There is no point. What we are worried, what we want from the heart is the output from the ventricles. We are not worried about atria. So persistent AF, we are not here to manage atria because we are least bothered. If ventricle is able to contract in a good pace, in a good rate, obviously that goes to whole of your body, especially to your vital organs also. And that's the reason we are going with a single chamber pacemaker, which is in the ventricles, not atria, because patient has persistent AF plus Tachy-Brady syndrome. The other scenario can be they can give a patient having just a Tachy-Brady, right, without AF and all, and there's a good conduction pathway beyond. Then answer becomes place electrodes in just the atria, right? Wait a minute, I'm just having those answers in the comments. Wait a minute. Patient with episode. Okay, VVI. Okay, Dr. Honey is putting questions. Okay. The answer VVI patient. Okay. So no worry. AI to 6 sinus syndrome, both single lead. Okay. Yeah. So persistent AF is the one which made you think about single chamber. Now, the dual chamber, right? If you put in atria and ventricle, there happens to be a asynchrony or dyssynchrony in these patients, and this is what you want to avoid. And usually now the preferred one, if you talk about, right, if they don't talk about this, or if you have any bundle branch block, which is the one to be used, it is always you put in, and have the answer. It is always
dual chamber.
Dual chamber. This is always better. That prevents asynchrony, right? If you have pacing one, the other one is not matching, there's a dyssynchrony or asynchrony, right? So just remember basic. Obviously, I'll go more in detail in your part 2. Don't worry. We'll discuss more pacemaker, what is A, what is V and all, right? There is a around half an hour discussion, pacemaker specifically. But right now, I don't want you to confuse and to think as a scenario that, oh, this is going way too far. No, what has been asked, this is what we are discussing right now, right? So single chamber is the answer over here because patient is in persistent AF. The best answer if there is no persistent AF and they say there is a conduction block, answer would be dual chamber, right? And if
How
they
would the
just say
question be if
six
the answer?
sinus, wait a minute. If they just say 6 sinus syndrome, which is Tachy-Brady, with normal conduction beyond distally, answer would be AAI, right? Why? Because right now pathology 6 sinus means the pathology, the sinus node is sick. You have to treat the atria. If patient is symptomatic with 6 sinus syndrome and distal conduction pathway is normal, why will you put a lead or electrode in a ventricle? Not required.
Okay.
So in that scenario, only answer would be AAI. And this AAI was asked in part 2. This single chamber, dual chamber was asked in part 1. And that is why I'm discussing both. And obviously, I'll be going more in detail in your part 2, not right now, right? Because there is a lot. There's a lot.
Sorry, Doctor, stupid question, but what is AAI?
Okay. So atria
I
being
mean, just the full form.
atria being sensed, atria being paged, and it is inhibited. So it is T or inhibited. So which chamber is sensed, which chamber is paged, and I, the third letter, means inhibited or triggered. So if you have a pacemaker lead in, let's say, atria, this lead sense what is happening in the atria. Then this will just pace atria, and if atria is working fine, it gets inhibited. That is called as AAI. If it
So
needs,
basically, oh, sorry.
yeah. So this is a nomenclature. This is called as pacemaker nomenclature, actually. Right? Again, don't go
So
into.
basically, it will be not very superior to pacemaker. Pacemaker is going to be superior to AAI. Is that the gist?
Pacemaker would be superior to
AAI, or it depends on the condition.
It's different, yes.
AAI is a nomenclature, is a way we speak about pacemaker. Right now, we are talking about pacemaker. So it is of various type, AAI, AAT, right? And they can be VVI. So ventricle being sensed, ventricle being paced, then is inhibited. Then it can be DDD. So it is dual chamber being sensed, being paced, and then dual means inhibited and triggered. Depends. It just changes. So again, I would just recommend, please do not confuse much. One thing is, for these kind of scenario, answer is single chamber. If they just say sick sinus syndrome, remember sick sinus syndrome or sinus tachy, and without any further conduction block, answer would be putting a AAI. Otherwise, all for other questions, answer would be dual chamber. Is that
Sir, what are the clues for AAI,
Yeah.
sir, if mentioned? Clues?
Yeah, pardon?
Clues for AAI, sir. If they're giving any question on AAI, what are the clues they can ask in the question system?
So this is what I just mentioned, where sinus node is sick sinus node with intact AV conduction or distal conduction. If this is the line mentioned, this is the only indication for AAI, for electrodes being placed in atria. Otherwise, we do not place electrodes in the atria. It is usually the ventricles, or the better is the dual chamber.
Okay.
Right?
Thank you, sir.
The reason why I answered transcutaneous pacemaker was because of the BP being 90/50. So I put transcutaneous because I thought maybe this is an emergency and
No.
we can do it as an emergency, like at
That's a
bedside.
separate question. That's a separate question. Over here, patient needs a permanent pacemaker. Why? Because there's a persistent AF with patient having Brady-Tachy syndrome. So you have to go with right now as a permanent pacemaker. And these nomenclature are for the permanent pacemakers, right? Again, don't confuse you much. Just let's move on to the next one. I don't want to confuse at this point of time with the pacemakers much. If a question comes, let's say of pacemakers, A, B, C, D, close your eyes, see which is the best option seen, right? And if you are not able to answer anything, right, you see clueless, wild, answer would be dual chamber. Just answer dual chamber, that's it. Or DDD or DDI. So just because right now, currently, the best pacemakers which are used are the dual chambers, most commonly, because there's no asynchrony, there's no dysynchrony. That's the reason, actually. Okay, question 27th.
Priyanka. Vaginals.
Good. GPA.
Yeah, it could be polyarthritis nodosa. I thought it was that.
Okay. Okay.
Yeah.
Bam.
Because there,
Okay.
yes, sir. Skin necrosis is there. Also, there is nosebleeds. In vaginal, there are sinus infections, but this nosebleed and skin findings, rash, and that favored more PA and so on.
So rash is more commonly seen where? Sinus infection, nosebleeds, more commonly seen in nosebleeds, epistaxis, nasal crusting.
Vaginals.
This is vaginals or GPA. right? So again, we have to look for most likely seen. Yes, PAN can involve all, right? And especially remember, the nasal area is also taken into the respiratory system, the upper respiratory tract. So nasal area is usually not involved. So in PAN, what is being spared are the lungs, the respiratory tract, the URT, the upper respiratory tract and the lower respiratory tract. So nose, if I talk about, or sinus infection is less common, very less common. Yes, if
Right.
they would have mentioned about liver dysfunction, renal dysfunction, especially the renal, or any aneurysms, answer would have been PAN definitely.
Right.
Right? Okay, so 27 done, 28. A simple question again. A management for cocaine toxicity initial treatment.
Diazepam.
Benzodiazepine.
Diazepam, right? And propranolol. What do you think about propranolol? It is
Contraindicated.
Contraindicated.
Absolutely contraindicated. And I believe you might have done such question, right? One question where propranolol is the answer. Is it? No?
Yeah. In pregnancy, there's a question on a pregnant lady having.
Yes. So there's a question, one question in the question bank. Anyhow, so propranolol is why? Because there's an uninhibited alpha action. So there's much of vasoconstriction. So it is not used. 29th. 29th. Again, a simple one.
MEN.
MEN. Second question about MEN. And the answer for this question is
Insulin.
Insulin.
So why MEN?
The
Patient having anxiety.
parathyroid tumor, which is leading to diplopia and headaches, blurring of peripheral vision. And there is this pituitary tumor, which is the insulinoma, and there is parathyroidism, which is causing increased thirst and hypercalcemia.
Why patient has increased thirst?
Because of hypercalcemia, sir.
Good. Perfect answer. Because of hypercalcemia. It's not
Sir,
because of diabetes patient. Yeah.
So why can't it be pheochromocytoma?
Pheochromocytoma with parathyroidectomy. Do you have any relation?
No.
Answer is in front of you, right? So that's the reason. Okay. And for pheo, obviously you need those symptoms as episodic headache, flushing. Obviously, the blood pressure over here is also on a higher side, heart rate on a higher side. So that's it. But if they have given a history of parathyroidectomy, they have given a history of anxiety, depression, that doesn't happen, right? Anxiety can happen, but the depression, diplopia, that doesn't happen, right? Obviously, there's something going on above. It is.
How hypocalcemia is causing thirst, sir?
Yeah.
Hypocalcemia is causing thirst.
Diplopia, peripheral loss of vision is caused by?
This one I got, sir. Previously, Sultan mentioned that increased thirst due to hypocalcemia.
Yes. Increased thirst is because of hypercalcemia. Why? Because calcium increases the osmolality in the serum. Right? And when the patient is in a hyperviscosity syndrome, the patient needs more of. And what do you do for calcemia? You give fluids. And some other patients who are not neurological depressed, they just ask for it. Why? Because viscosity in the serum has just increased on a higher side.
It's just about osmolality. So he got increased thirst.
Yes.
Thank you, sir.
Welcome. 30th. Interesting question again. Not a difficult, interesting question for this point of time when we have an update in the neurology.
Capra.
Yeah?
Capra is mostly the answer everywhere. Or actually, sodium valproate is not used anymore, just to make it easy.
It's not used
It needs
anymore.
consultants' consents.
Yes, this is an important line which is now mentioned, updated in the NICE guidelines. That sodium valproate is highly effective but not be started for the first time in people under 55, whether male or female, remember. So it doesn't matter now whether patient is female or male, both. Unless two specialists independently confirm that. So important line. So valproate is now out. Now the option becomes levetiracetam as the first choice. Second is lamotrigine. You might be.
And carbamazepine makes it worse.
Yeah, which one? Yeah.
And carbamazepine makes it worse. It's contraindicated.
True, true, true. 31st.
Amoebic dysentery.
Yeah. Which one?
Amoebic dysentery.
Amoebic dysentery.
Reason?
2 weeks history.
Blood mucus.
One thing very
blood.
important is one of you mentioned is there's a 2-week
2
history.
weeks history.
Right? Okay.
Yeah.
So he returned from a holiday, right? It's not.
India.
It's a chronic one, and patient presented with
Bloody
Bloody diarrhea.
Bloody diarrhea and marked tenderness.
yes, and marked tenderness, or you can say there is a tender abdomen, right? That is very important. And the other thing, the creatinine and all. So definitely it goes in favor of dysentery because it's 2 weeks, it's a bloody diarrhea, and after a vacation in India. Okay, now moving on to the next one, 32nd.
Observation.
Okay, reason?
There is no clinical evidence of mercury exposure.
Exactly.
My doubt was, did he swallow the whole thermometer?
Yeah.
Did he swallow the whole thermometer, the patient?
It's surprising and shocking, right? You are not able to come out of that shock in the question itself. Oh, how that can be possible?
I read twice.
I want to meet that patient. I want to see live. Forget about the mock. I want to meet the patient. Anyhow, so history of bipolar, obviously psychiatric disorder is mentioned, and when it is intact, they have specifically mentioned. And if let's say it is broken also, right? It's not about ingestion, it is about inhalation of the mercury, which is more lethal. Okay, so in this case, it is just the observation.
But if that case, if it says that thermometer is broken, then what would be
Nothing much. Again, ingestion is not that lethal. You have to observe, you have to keep the patient in the ICU, right? But again, it's not that lethal. Inhalation of mercury is important, is lethal. Okay, 33rd.
IV adenosine?
IV adenosine.
Narrow QR is called.
And we have narrow complex tachycardia. The first thing you will do is carotid sinus massage with a thumb or two fingers on one side, 5 to 10 seconds, then on the other side. Please do not attempt on both sides.
Both sides.
Have the right to play with the patient, right? You cannot. So one at a time. And whenever you are attempting, by the way, carotid sinus massage, one thing you need to be make sure. Can I have
Carotid stenosis or flaps in the
good. If there's a documented atherosclerosis or narrowing in the carotid area, right, in the carotid artery, because of atherosclerosis, you cannot go ahead. It's a medico-legal. If you press and that embolus presents with ischemic stroke, you are the reason. So always document and usually try checking in an elderly patient, right? If they have gone with those documents, if they have done those investigation, right? Let's say there's a carotid angiography or there's a carotid Doppler, they already have the report. So try not to. Okay. Then adenosine is the next drug. Adenosine. Okay. How much adenosine, by the way?
6 mg, 12
and then 18.
18.
6, 12, 18.
12, 18, perfect. 34th.
CIDP.
CIDP.
CIDP. Reason why?
I thought,
Multifocal motor
seeing
and
that
sensory
and
intelligence.
inflammatory changes.
So the scenario provided is progressive distal. So till this time, I cannot say answer can be GBS or CIDP. Till I see the duration. What is the duration for CIDP?
2 months, man.
It is more than
2
More than 2 months.
4 months.
8 weeks or 2 months. Then it just changes to CIDP. Otherwise, it could be AIDP. GBS is nothing, AIDP. It's acute. acute inflammatory. And with this line, nerve conduction studies, where they talk about latency. This latency is because of demyelination. AIDP is what? Acute inflammatory demyelinating polyneuropathy, or in CIDP it becomes chronic, right? So demyelinating, whenever the myelin is being removed or there's a lysis of the myelin, myelin helps in conduction of the nerve or tells you about the nerve velocity. If this is being destructed, there's a lysis, myelinolysis, there's a myelinolysis, right? Or demyelinating pathology. Obviously, patient will have decreased latencies. The speed will be decreased, right? Okay, so that's about
ये
CID,
तो चलेगा तो
AIDP.
34 क्वेश्चन
And there
चलेंगे
is one more question about AIDP also, right? About GPS also. 35th. Can I have the answer? 35th.
Ibuprofen. Ibuprofen.
Yeah.
Ibuprofen.
Why reason?
I marked it as IB.
AIP.
AIP.
AIP drug, safe drugs.
Yes.
Okay. Okay.
Barbiturate,
How does
diazepam.
how does a patient of AIP present? Where is the enzymatic problem, the defect, and how do you manage AIP? Important for the exam.
Abdominal pain and neuropsychiatric symptoms.
Abdominal pain and neuropsychiatric symptoms.
Phosphorbilinogen.
Amylase is accumulation.
Amylase and
Deficiency.
Of deaminase, right? And
Accumulation of porphobilinogen.
yes, urine porphyrinogens. Yes. So this is what you check, and there's accumulation of porphyrinogens. And how do you manage?
IVRG.
Yeah.
IVRG.
Hemarginate.
Hemin or
Hemin.
hemarginate. Good. Perfect.
Hemarginate.
This is how, and this is AIP. Remember, AIP is very important. Deficiency of deaminase. Remember, deaminase. And these are the drugs to avoid: barbiturate pills, halothane, alcohol, sulfonamides, benzodiazepine, and NSAID. And hemin is, or hemarginate is the one, and patient presents with acute severe abdominal pain plus neuropsychiatric manifestations. Okay, 36th. 36th answer. Why? What are they? What are we talking about?
Hypokalemic periodic paralysis.
Magnesium and calcium.
Yes. Yes, that goes in favor of Barters, and Barters can have all these presentation, right? And specifically, if we talk about Barters, it is in the loop of Henle. Remember, the first thing it starts over here. It is the syndrome.
Fanconi.
It is Fanconi.
Yeah, remember, this is just a fan. This is just a fan at the start. Fanconi syndrome over here at the level of glomerulus or PCT, right? PCT. Then over here in the loop, we have
Barters.
Then over here we have
Gentlemen.
and then we have
Littles.
Remember, fan comes first, then you have to follow the alphabets. B comes first, then G, then L. B, G, L. This is how. So you don't have to remember Barter with a loop and all, right? So just remember this diagram, you'll be able to. Okay.
Can I ask just one question? Because why not Gittelman? Because Gittelman is like specifically comes with a low magnesium, even more than Barter. So I mean, why not Gittelman here?
Also, barter is for babies, isn't it? The
Yeah,
age
it
is
is
30.
babies, but it can present in the later stages also. It can present. It is usually it becomes lethal. Why? Because all the three are involved. Sodium, potassium, chloride. Now, gentlemen, Dr. Honey, what about calcium? What happens to calcium?
Yeah, calcium is low.
Yeah.
So calcium is low.
Hypocalciuria in gentlemen.
Hypocalciuria.
Urea.
Not
Calcemia.
Get that? Okay.
Yeah.
Now, going forward, and these are the patients who present with hypokalemic periodic paralysis. They are very severe. Why? Because of involvement of three channels: sodium, potassium, chloride, NKCC. This is what we say. Okay, 37th.
Bladder cancer.
Bladder cancer.
Why?
Illness, hematuria plus smoking plus old age.
Mainly
TCC.
hematuria with smoking.
Good. Hematuria. Why not? Why not tuberculosis?
There won't be small calcification in upper lobes. They'll be gone for
This is an old healed
It can be
calcification.
healed calcification, but patient has shifted from Asia to UK for the past 15 years. So right now the scenario doesn't go right. This is an acute scenario. It's been 15 years. So tuberculosis, yes, can be a latent or can be this finding can be because of tuberculosis, but right now patient having hematuria, this doesn't go in favor of tuberculosis at this point of time, right? So definitely answer becomes bladder cancer.
In
Okay.
schistosoma hematobema also they mention the same finding also, white calcifications that leads to renal cell carcinoma.
Yeah.
In schistosoma hematobema also they mention the same finding also.
Sir, actually, I thought it's the schistosomia hematobium only.
Calcification कहाँ होगा? It will happen in the
Bladder में
bladder.
होगा.
Bladder.
Bladder में होगा.
There's
हाँ,
a
हाँ.
difference. Bladder. many organs come in between. So that calcification is in the bladder for schistosoma.
Bladder.
Right now we have a calcification in the lungs, and with that, with the Asian background, with the calcification, they are trying to confuse you with the tuberculosis, but it's not because it's an acute finding. This is what I'm explaining you, right? Is that okay?
Yeah.
Okay, great. So that happens in the exam. Don't worry, Dr. Kasturi, it happens, right? But obviously, we keep learning, we keep motivated that yes, we need to avoid these silly mistakes in the exam. Okay.
Yeah, but I answered it correctly, sir. Thinking that as a bladder.
Eventually thought ki no, there's a difference between lung and bladder.
I had noted it proper. I thought it as a bladder instead of lung.
Bladder cancer.
Good. Perfect. Now, 38th. We need to run now. It's almost 11:45 over here in India.
Emergency temporary.
Transvenous.
Yeah.
One.
One.
Pacemaker.
Which one? A or B? And why B?
B.
B because this is
Why is
anterior.
it permanent?
Atropine resistant AV
Next
block.
most important.
Why it is
Next
not
one.
permanent?
Wait a
Yeah,
minute.
because post anterior MI was one of the indications for temporary and not inferior, right? And thinking of that, I went to permanent, but
Wait a minute.
Block
First of all, I'll
happens.
just help you out with that concept. Whenever patient goes into complete heart block after inferior wall being involved, and definitely you are talking about the RCA. Now, this RCA supplies the SA node also, and that is the reason they are very common to go into develop complete heart block. But the patients of inferior wall MI, they just resolve. I mean, the pathology just resolves in a matter of maybe hours or maybe days. So you need to just observe. Nothing to be done. Whereas if you talk about CHB or a complete heart block after post anterior wall MI, this is the area anterior wall of the heart supplied by the LCA, left coronary artery, which is the main area supplying a huge muscle mass over here on the anterior and the lateral side. So the point pathology, if anterior wall MI happens, they cannot resolve by themselves. You have to put pacemaker, right? And that too a permanent one, not temporary. Right now, we have gone with the temporary because the answer, by the way, is B, because patient has inferior wall MI. That's the reason. If I change the answer to anterior, answer will become A. Yes, Dr. Vidya.
When do we use isoprene? Because I thought it was the temporary one, but then I just thought they want next and they haven't given isoprene. So I just thought in the time that we get someone to do the transvenous, we need to start the isoprene? No.
Symptomatic bradycardia, yes, you have to go with atropine second isoprene, but without a block. If block is present, 2:1 block is present, patient is at risk of going into CHP. You cannot try, right? Patient will deteriorate like hell. So right now is a temporary pacemaker needed for the patient. Is that okay, everyone? Should I move forward?
Yes.
I think you all need caffeine. Is it theanine or caffeine or what? Are your energies going down or being distracted with Instagram or YouTube or any other social media? Is it or what? I'm not getting that interaction. Are you all there with me?
Yes.
Yeah,
Yes,
Yes,
sir.
Okay, Dr. Vikrant, you raised
Yeah.
hand. You want caffeine, theanine, or something else, which I can't name over here, which is illegal.
No, sir, just was asking about the last question.
Okay, okay,
Sorry.
okay, no worries. Yeah.
Actually, just I want to ask, in my somewhere in my notes, it was written that we can also go for observation in when there is inferior MI
Yes,
and there is secondary type 2 heart block.
yes.
We can also go for observation.
Okay.
So I was thinking about observation. Okay, I didn't see the blood pressure, right?
Patient will say bye-bye.
The
Or
patient is
Yeah,
buying basically.
or am I
yeah,
saying bye-bye to the patient? No, right?
right, sir,
That is
right, sir.
why I asked you, you need caffeine, theanine, or what?
Caffeine, sir, caffeine. High on caffeine.
Obviously, patient is hypertensive, significantly hypertensive. You cannot observe. Otherwise, if patient is hemodynamically stable for post-inferior MI, patient going into CHB or going towards CHB, you don't have to do anything. Monitor, observe. That's the answer. But right now, there's a hemodynamic compromise, 70 by 50. Definitely, patient will have system involvement. I mean, neurological hypoxic damage to the brain, which is the most threatening. And a kidney can be saved, liver can be saved, but once there's a damage to the brain, hypoxic ischemic encephalopathy, if that happens, that is very, very, very bad for the patient, right? So always make sure about a hemodynamics. That is why every question in emergency keeps talking about hemodynamics. If there's a hemodynamic compromise, you have to be alert, you have to work, and you have to have that intervention then and there. Okay, is that
So,
okay?
sir,
Thank you so much.
isoprenalin is used for, sir, indication?
In symptomatic bradycardia without any blocks. So
Bradycardia without any blocks, right, sir?
So symptomatic bradycardia means patient having decreased sensorium, patient having chest pain, patient having acute heart failure, right? So these are the indications. Or patient having hemodynamic compromise. So you have to go, but without any heart blocks. So atropine first, then isoprene, and then the infusion of adrenaline can be provided, right? Dopamine or adrenaline. If not,
So like
this is not done, then you go ahead with expert consultation or specialist consultation. This is the
so
algorithm.
like in sinus brady.
Yes,
Symptomatic sinus brady. Only in symptomatic sinus brady.
similar. Yes, true.
First line is iso, next is adrenaline, right, sir? What you said?
Atropine, isoprene, adrenaline infusion. Adrenaline or dopamine infusion, right?
Yeah. Thank you, sir.
Most welcome. 39th.
Yes.
I think this is another easiest question. Half at rhabdo, right? Rhabdo was somewhat confusing why it happened, but this is a clear-cut patient. ALL, chemotherapy, what else, right? They have mentioned everything on a higher side, calcium on a lower side. Typical.
Hemolysis.
This is TLS, definitely, right? Okay, question 40th. Question 40th.
Was it
Uric
CKD?
acid, diuretics.
Also stone.
Yes, yes, yes.
Uric acid. Thiazide.
Reason why thiazide?
Because hyperuricemia.
Hyperuricemia,
gout,
Retention of urine.
Exactly. So remember, thiazide diuretics are helpful in
Calcium.
calcium.
Hypercalcemia.
Perfect. It is helpful in calcium stones. Whenever the patient presents with, let's say, calcium stones, you go with thiazide. Why? Because it helps in retention of the calcium. Loop loses calcium. Remember that. So loop diuretic loses calcium. The more the calcium is drained out, there is more chances of calcium stones being formed, right? With the loop diuretic. So in those conditions, we give thiazide diuretic. In a patient who already have uric acid, thiazide diuretics are a risk factor. If you remember the gout table, right? I might have shared a gout table, the causes from Kumar and Clark's, right? Specifically, and that has thiazide diuretics written. So remember that thiazide diuretics is one of the one. And there is one more question about gout also, I believe. 41st. Simple question. A simple question with exactly simple question. So there's a desferoxamine, and you have to. These are the timings provided. Patient can go into phase 3 after 12 to 24 hours. Patient can present with seizures, hepatic injury, right, and hepatic failure in days, 2 to 3 days. Okay, 42nd.
Actually, I went for hemodialysis, sir, because hemodialysis absolute indications there is acidosis. So they asked for next step, so I went for dialysis.
No.
So even seizure were mentioned, so even I went for hemodialysis.
No.
Like nuances seizure, yeah.
Not. No. Hemodialysis. Yes, if seizure is because of urea, uremic encephalopathy, answer would be hemodialysis. But over here it's iron. Iron will not be removed, and that's the reason hemodialysis is not the answer. Have to go with desferoxamine, which is the antidote or a chelating agent, I would say. Okay. 42nd. A simple question again.
Urine osmolality.
But might be confusing to some of you. Can I have the answers from others? Dr. Salwa, you there? Why the answer is E? Dr. Nitu, Dr. Shruti, Dr. Shruti, are there? Dr. Nikita, Nitika, Dr. Hari, anyone can say why the answer is E.
Sir, it is diabetes insipidus in adults.
Cranial diabetes.
There's a severe head injury. There's a RTA. There's a severe head injury. There's a hypernatremia. And now what they've asked, which is the following, is correct. Right? Now, urea and creatinine is the normal range. Potassium somewhat on a lower side. Chloride, very high. Are the two things which we can see. Now, let's go on to the options. Rapid rehydration with 5% is indicated.
No.
Whenever patient has severe head injury,
Cerebral edema.
never ever give
Absolute contraindication.
Absolute contraindication. Why? Because it adds on to the cerebral edema. Because 5% dextrose just metabolizes into free water. It just moves into the cell and causes cerebral edema. So it is always contraindicated in a severe head injury or a head injury patient or a bleed. Okay, she has SIADH. With SIADH, what do you expect? Sodium to be
Hyponatremia.
This is for sure, right? We have discussed all that algorithm for a hyponatremia. It comes under euvolemic, right? But it is hypovolemia. Over here, it is hyper. She should be treated with sodium restriction, okay? But why? Why the hell the patient has sodium chloride on a higher side? Moving on to the next option is hyperchloremic acidosis. Can this be the answer?
Hyperchloremic, there will be hyponatremia. I thought that was.
Yeah.
There is no mention of any pH or anything.
Yes.
Yes.
How can you name it as acidosis? With this head injury,
Negative ion.
Exactly. With this head injury, there might be many reasons, right? There might be many reasons. And definitely patient is might be losing much of the free water, and that is why what you have seen is a collapsed vascular compartment with sodium and chloride on a higher side. That might be a collapse scenario, right? So definitely we cannot call it as acidosis. Now comes urine osmolality will be low. Obviously that matches with the options provided or with the presentation provided. If urine osmolality low, that means what? Urine is totally diluted. Diluted. That means patient is passing dilute urine. Patient is pouring free water. Now with that free water, what is being retained behind is sodium on a higher side and chloride on a higher side. And especially we call these patients as they under
Cranial diabetes insipidus.
Yeah.
CDI.
Especially cranial, exactly. Now I need to discuss how to differentiate cranial versus nephrogenic.
Water deprivation test.
Those, yeah, water deprivation.
Deprivation test. Water deprivation.
Desmopressin.
Desmopressin test.
Good. Desmopressin or DDAVP spray, nasal spray, in which condition the urine osmolality will increase.
So cranial
Cranial
DI.
DI.
Cranial DI.
If normal in
Changed.
So it is just the cranial. And how do you differentiate DI versus primary polydipsia or psychogenic polydipsia?
Water
Water
deprivation.
deprivation.
Water deprivation test.
Okay, 43rd.
18.
Simple. Again,
814.
1814.
814.
now
814.
someone mentioned, in fact, Dr. Kathuri mentioned, if I'm not wrong, that it becomes difficult with a lengthy question, right? And you are wasting time. Dr. Kathuri, are you there? And you
Yeah,
mentioned, right? You mentioned you are not able to go with all the STEM, all the investigation provided. Was that a comment from your side, a feedback from your side? Dr. Kasturi?
yes,
There? Okay. Now there are a lot of investigation mentioned. There is a lot of STEM mentioned. But see what is being asked in the last line.
This question I have Sida. I went right away to the Burkitt lymphoma cells and I mentioned it correctly.
I mean, I'm just with you, I'm helping others also, right? So
Yeah,
don't take it on yourself. Yes, I'm helping others. That yeah, please, and in this STEM, in this question, you have not just saved your time, you have saved the burden onto your brain in those 6 critical hours. So don't think that you have saved time in one question. No, you have saved your brain from unnecessary exercises of understanding anemia is there, platelet WBC is high, so definitely there is some kind of infection, ESR. So you are wasting time evaluating. There's no point. See what is being asked. Translocation bucket, answer is 1. That's it. 814. Move to the next one. The above information is not required at all. Right, so please try that in your exam. If you come across and you have, let's say, out of 100 questions, you are able to say with 6-7 questions, right, without reading much of the STEM or without emphasizing reading much of the STEM, you have not just saved the time, you have saved the pressure on your brain, right? That is also very important. Okay, 44th.
Diphtheria.
Diphtheria.
Again, a simple question. Exudate on pharynx, lymphadenopathy, which is called as bull's neck.
Bull's neck.
Good. So this is diphtheria. And there is a grayish membrane, yellowish grayish membrane. Okay, 45th. Important question. Wonderful question. How many of you were able to mark it correct?
I mentioned Wernicke's.
Confused between C and D.
I did opposite. Cortical motor aphasia, I did.
Okay.
Wernicke's aphasia.
I marked Wernicke's.
Anyone who has marked it correct?
Correct, but I marked it correct, but it's just I think by chance.
Ruled out.
Okay.
Not broadcast because speech is.
That's what I thought, that not Broca's, not Warnick's.
Not global.
Now,
Not global, yes.
If you remember, I discussed aphasias with this slide. Do you remember vaguely? Obviously, you yet have to revise, right? You will be revising again. So type of aphasias becomes easier with this slide, with this presentation. First of all, see whether the patient's speech is fluent or not. If it is not, it goes to this side. With fluency being not maintained and there is comprehension maintained, plus patient is able to repeat, that is called as transcortical motor aphasia. Whereas everything is absent, nothing is there, that's just say global aphasia. Patient doesn't can't repeat, can't comprehend, is not fluent. Answer is global aphasia on this extreme. Now, Broca's, which you all know, patient is not fluent, but patient comprehends what you are saying. You ask a question, where do you live? And patient will say, but with breaks in between, and breaks in the sentence. What do you do for living? He will answer, but with a break. So he is comprehending what you are asking, but there is a break. That is called Broca's. And if you ask, this is the line you have to repeat, they will not be able to repeat. So Prokas, this is absent, repetition is absent. Now, forget about mixed transcortical right now. On the other side, if fluency is present, comprehension is present, repetition is present, but they are not able to name. They don't remember or recollect the name of a person. That is called as anomic aphasia, this extreme. Plus, very commonly, if they say fluency is there, but patient is not comprehending anything, whatever you are saying, and is not able to repeat, it is Wernicke's aphasia. They just keep saying whatever they want to. They are not comprehending what you are asking. If you have asked a question, they will just answer anything, and that too with a fluency, with new words inserted in between those sentences, which is called as neologism. Now there is something called as transcortical sensory. Remember how to go with this stem. Fluency is present, comprehension is absent, but repetition is present. Now remember, there is a sensory component. Sensory means your senses, ears, your eyes. So if you say something to a patient and patient is not able to comprehend, comprehension is absent. Comprehend means he will listen and then he will just think about it, what you have asked, and then will try to answer, right? So comprehension is impaired. Why? Because it's a sensory component involved. So that's a sensory. Whereas if I come on the motor area means you have to speak. Speak is a motor. You are using your ATPs, right? That is a motor component, right? Moving your limbs, using your tongue, saying something, that is a motor component. So motor aphasia has a problem with fluency. Other two things are normal. Comprehension is normal. The repetition is normal. This is normal. This is normal. Only thing which is absent is fluency. That means not able to say much, right? The motor component is impaired. This is how you can remember. In sensory, patient will not be able to comprehend. Does that make sense? Are you able to understand now how to rule out?
Yes, sir.
Yes, sir.
Others, I need to hear the
Yes, sir.
Yes, sir.
Yes, sir.
For a
Yes,
motor,
clear.
patient has to say that, and aphasia means there's a problem, right? Problem with the speech. Motor means patient will not be able to speak in a fluent manner. That's the only problem in a transcortical motor aphasia, but comprehension, repetition will be intact. On the other side, sensory, remember with the sensory, the ears are which picks up the sensations, right? Whatever you are speaking, or your eyes pick up the lip movement, right? Whatever you are speaking, patient is not able to comprehend. Why? Because there's a problem with the sensory component. So transcortical sensory aphasia. Only thing which is absent over here is comprehension. Repetition is present, fluency is present, because pathology happens in the sensory. This is how you can remember these two. Is that okay now?
Yes, sir.
Yes.
Yes, sir.
Okay, great. And Wernicke's, you all know, right? Wernicke's is our loved one. Broca's and Wernicke's is our left one. Fluency is present. Both the things are negative, right? Okay, that's it. Question number 46. So please do not make mistakes in aphasias. Aphasias means they don't speak much. But again and again, I keep saying these aphasias are the questions which speak much in the exam, right? So you need to know how to have that algorithm. When you have this algorithm, it becomes easy. Otherwise, you'll be confused. Procas, and all, right? And these becomes very high yielding. These becomes high scoring in the exam, right? Especially the neurology, cardiology, because these are just like a nightmares for the candidates. Okay, yeah, Dr. Tripathi.
Sir, may I request for the questions? Yes, for the questions.
Okay.
Sir, in this question stem, it is written that when told to raise his arms and place his hand, he doesn't comply. But when visually shown the action, he is able to perform. What does it mean, sir? Actually, I was not able to understand.
So patient can repeat sentences. That means repetition is intact. Plus, if we talk about one of the limb, definitely they are talking about some embolic phenomena. I think they have given a history of atrial fibrillation, is it? Yeah, atrial fibrillation is provided. Pulse is irregular. And that's the reason the power in the arm is low on one side. Plus, if you see, When asked to point to a window, he is unable to do. He's not able to follow. When told to raise his arms and place his, so again, this, what do you mean by this line, Dr. Tripathi?
He is not understanding.
Comprehension.
Comprehension.
Comprehension is impaired. This is what I just mentioned.
Yes.
Comprehension is impaired in
Transcortical. Transcortical and Wernicke's in both.
in Acha. How do you differentiate transcortical sensory with this one?
Comprehension.
Comprehension and see again. The first thing, the division, transcortical sensory and Wernicke's. It is this one and the repetition. What about this patient? Was he able to repeat?
Yes. Yes. He was able to repeat.
Today is a summer.
Wernicke's. What happens in Wernicke's?
Not able
Not
to.
repeat.
Not able to.
Not repeat.
The only thing which they have, Wernicke's patient, they just keep saying fluency. Comprehension impaired, repetition impaired.
Yes.
Okay with everyone? This is
Yes, sir.
using a difficult question, a conceptual question, and based on the algorithm. If you remember this algorithm for aphasia, it becomes easy to manage any question for aphasia, right? Okay, now moving
The
forward.
comprehension in the sense understanding capacity of a patient, right? Sir?
Yes, whatever you are saying, if you are giving asking a question, where do you live? Patient is not able to understand, and he just says that I am a sportsman, I am a cricketer, I am a footballer. You ask where do you live, and he is asking, or you ask something to do, right? Let's say lift a pencil or a pen, and he just throws something out.
Okay.
Not comprehending what you are trying to say or what you are trying to ask.
Okay.
I have something like confusion. I mean, to understand that he wasn't able to follow the commands, but he was able to repeat the sentence. So it's a bit confusion.
Repetition is something else. Comprehension is what you are saying, right? Let's say
Obeying the orders.
you utter something, right? I live near the hospital. You are in the hospital. Just repeat it. But if you ask them to do anything, or if you ask a question, they are not able to comprehend what you are saying. They will repeat behind what you are saying, but they'll not be able to comprehend what does that sentence means.
All right. Okay.
Right?
Thank you.
Okay, most welcome. 46th.
PSGN.
PSG.
Hematuria and protein
A simple, straightforward question, is it? 46th.
Yes, sir.
Yes.
More than 2 weeks.
A reliever
More
after
than 2 weeks
difficult
of.
question.
More than 2
Yeah,
weeks.
this is the question we know, right? Having a smile on the face. Oh, our question became PSGN or IGA. Is it? Okay, so definitely PSGN. And this happens in the actual exam also, right? After 2, 3, 4 questions, they will give a normal, a simple question also. And always try to have that inclination, try to have that mindset that let's say first 10 questions seems to be difficult. Keep thinking that next 10 would be easy. The next 10, and it would be your 90th question. And think maybe the last question, last few questions, maybe they will be easy question, right? And this is how you keep going in the exam also. Don't feel, oh, you are not able to, right? Don't feel that this is the most difficult exam. If it is a difficult exam, let me tell you, that is more favorable than having a simple exam. Because on the one system which is called as equating system, if the questions are very easy, let's say about AF, HOCM, they are just asked the basics, everyone knows it, everyone will answer it, and the competition will increase. So if the questions are somewhat difficult, somewhat confusing, that is favorable if you have prepared, if you have worked hard for it. So don't worry, right? So be happy if it is confusing. If it is so simple, have some kind of occasion thinking, oh, the result can go on the in the other side also, right? But yes, if you are well prepared, then yeah, you might feel this is an easy exam, right? Okay, 46th. Because this happened with the previous batch candidate, right, where we had 50 plus selections in the previous batch, and after the exam we had a word, me and Dr. Beg, we had a word with other candidates, right, who are not from intellect medicals, by the way, and they have not emphasized much on basic sciences and all. So they were saying, and the minor unit especially, and they were saying it was very difficult and all. But our candidates were saying it was easy. And yes, this was the result, right? It was difficult for many because they have not emphasized on the difficult areas. We have discussed those many times in the session, and especially now in the revision sessions also. Then you might feel it seems to be easy, and definitely that comes in the result also. Okay, now 46th.
Yes,
Yeah, it is an easy one. Now move on to the next 47th.
GRDSs.
But why?
Bloating, flatulence, and
More
false.
than 2 and more than 2
Travel
weeks.
and holiday.
All the points are
Traveling history.
traveling history. You have to search for the cyst and the oocytes. And what is the treatment for giardiasis, by the way?
Metronidazole. So I always get confused with tropical sprue.
Okay. Tropical sprue, it is acute in onset, right? And obviously that changes with the Mediterranean areas or the tropical areas of the patient, right? But patient will not have foul smelling. Patient will have GI problem, but not a foul smelling with the bloating, with the excessive flatulence. This is a typical picture of a giardia, right? And traveling history. The other thing can be in that particular area, right? Tropical sprue. Over here, it is the traveling history which is more important. Okay. Then 48.
MR angiography.
Again,
Renal artery
lowered on my hand. Otherwise, it will be fatigued. All the ATPs raising the hand. Okay. So 48 is deteriorating hypertension. So yeah, you all answered it correct. MR angio. Why?
Renal artery stenosis. Asymmetrical kidneys.
Kidney and creatinine is high.
And this causes renal artery stenosis is a cause for
hypertension.
Secondary
Secondary hyperaldosteronism.
where? What do you expect? Renin and aldosterone to go?
Increase.
Aldosterone renin ratio is raised.
Okay, very good. Discuss this. This is important. What happened to renin?
Reninemic hyperaldosteronism.
will increase.
In primary, what happens?
Renin is decreased, aldosterone is increased.
Aldosterone is increased.
In secondary?
It is if both are increased.
And aldosterone will also increase.
What is called as if both are decreased?
Little.
It is called as little. It is called as pseudo hyperaldosteronism, where little is one of the cause. What are the other causes? Very important. You might have done one question about licorice.
Yes.
Medication. Licorice is the one, right? Where both renin and aldosterone is low. Remember, whenever they talk about renin and aldosterone, they sometimes ask about AR, right? So aldosterone renin ratio. Definitely over here, it will be more than equal to 20. It is normal over here, right? And pseudo is this one where you have a little, you have non-classical CH, you have 21 beta hydroxysteroid dehydrogenase. These are the examples of pseudo hyperaldosteronism, right? Okay, and when we talk about RAS comes under secondary. Secondary means pathology happens somewhere else. Primary means it's in the adrenal. So with the adrenal, aldosterone is high. When aldosterone is high, definitely with a negative feedback, renin will come low. But in secondary, what happens because of hyperperfusion of the kidneys, in case of hypovolemia, let's say patient present with pre-renal, yes, patient can develop secondary hyperaldosteronism. The other cause for secondary, can I have the answer? A rarer one. A rare is renin secretion. A renin secretion.
Lung.
So these are the ones. Or let's say patient with diarrhea, with vomiting, with burns, with all these hypovolemic state, patient can go into secondary hyperaldosteronism. Because when there's a hyperperfusion, there's a hypovolemia. Kidney will feel there is no volume in the body and it will secrete renin. This renin will go to angiotensinogen to the liver, angiotensin 81, 82, then aldosterone, and aldosterone will act on the blood vessels and causes sodium and water retention. This is the physiology, right? So remember, aldosterone function is sodium and water retention. Also, if adrenal is the one which is destructed, which has been asked multiple times in the exam, if adrenal is destructive, or there's a destruction, or there's a pathology at the level of adrenal gland, how will you, which is the one symptom or presentation which you will be looking for?
Hypotension.
Hypotension.
More important.
Like
Yes, it can be.
Metabolic acidosis.
Very important is high
hyperkalemia.
ACTH patient presenting with hyperpigmentation. Why? Because ACTH is not able to act. And also, what you rightly mentioned, if there's a loss of mineralocorticoid, patient will present with postural hypertension with electrolyte abnormalities, which is definitely what happens to sodium in a case where aldosterone is not there.
Lost.
Sodium.
Hyponatremia.
And whenever this is the scenario,
Hypernatremia.
whenever this is a scenario, always look for potassium. This is more important because sodium changes with the water, but potassium doesn't, right? So look for, whenever you're talking about adrenal, look for potassium. If hyperkalemia, look for adrenal insufficiency, or you can say adrenal crisis. Okay, great. So 48 done. So this topic for 48 is important. Adrenal, aldosterone, all these things are important for the exam. 49th.
Myalgia rheumatica.
Myalgia rheumatica. Why? Yes.
Elderly patients, stiffness and stiffness.
Muscle stiffness.
So, myalgia rheumatica, PMR, right? 50th. Methotrexate, right? So this is a fact that always, what's the answer?
Full blood count LFT, urea electrolyte at baseline 2 weekly, then every month. C.
And later on?
Sir, every month.
Every month.
Sir, but why the urea electrolyte? It is not affecting the urea electrolyte. It's
Every
affecting
month
the.
for 1 to 2 years, and later on 2 to 3 monthly.
3 months, yeah.
Sir, why we need to monitor the urea electrolytes in this case?
Why they are going for because it can be nephrotoxic also. Hepatotoxic, definitely. Pulmonary toxic. But you have to, and when you are adding these drugs, right, you have to check the renal function. You have to check the renal function. And the urine and electrolytes are important. You have to check for that.
But in the then we have this FPC urea electrolytes should be repeated for weekly. After that, it is 2 to 3 months, right?
Yeah, later on, after 1 to 2 years, when it is stable, when you have checked multiple times, after 1 to 2 years, when it is stable on a dose of methotrexate, now it is 2 to 3 monthly. Later on, once the dose is stable, right? Okay, and what happens to methotrexate toxicity?
Myelosuppression.
Myelosuppression,
pulmonary
mucositis,
fibrosis,
lung and liver fibrosis.
Antidote or treatment for
Polinic acid.
Polinic acid.
IV folinic acid or folinate. Good. 51st. Most significant finding on 72-hour tape.
Alternate.
The mobiles with RBP.
Now, atrial ectopic, nothing. Ventricular ectopic, nothing, right? Bradycardia while asleep, this is a normal. Morbid type 1 with RBP while having a feeling lightheadedness, definitely. This is a significant finding, right? And patient presenting with syncope and pre-syncope. Okay, 52nd.
Celiac
screening.
Again, an easy question for you. I'll give you.
B12 deficiency.
Yeah.
Celiac. Why celiac? Can I have the answer?
B12 deficiency.
B12
deficiency with diarrhea, chronic worsening diarrhea.
Good. Worsening diarrhea, loose motions, patient having edema, and there is
bariatric surgery.
When celiac disease presents, it's so late, it's 75 years of age.
Yes, that can definitely. What is the other option you went forward with?
I went for lactose hydrogen breath test for bacterial overgrowth.
Yeah, emotional, right? Elderly, they have lactose intolerance.
Even I went for the same.
Everything which is given in the STEM, you have just to 75-year-old, that elderly usually have lactose intolerance, and why not to go with this one? Why this patient had progressive sensory and impaired proprioception? Can I have that answer, Dr. Sultan?
So can bacterial overgrowth lead to this malabsorption thing? Malabsorption.
No, not at all. This is, and you don't think of SIBO at this point of time, right? Bacterial overgrowth. There's no risk factor for the SIBO also. But right now, definitely progressive. What do you, just tell me, what do you mean by this line?
So there is a
B12
B12
deficiency.
deficiency.
B12 deficiency with worsening diarrhea. And definitely this patient underwent bariatric surgery. What does that mean?
So he has got a stomach reduction surgery
Exactly.
for this thing. Yes.
Exactly. So all these things, when we talk about having the B12 deficiency with worsening diarrhea, with a surgery, although surgery is not important that much, but this tells you about patient having neuropathy, and that neuropathy is caused by
B12
B12 deficiency. And that happens in a malabsorption. Now, out of these options, which one do you think fits in the picture?
Celiac disease.
You gave the answer by yourself, right?
Yes.
And moreover, bariatric surgery was 10 years ago, sir.
Exactly. That is what I'm saying. That is just given as a, I mean, just to confuse you, that it could be a dumping syndrome or a short bowel syndrome.
Even I went for the same thing, see, lactose hydrogen blood test.
No,
Didn't
but
create a
how
proper
will lactose intolerant give neuropathies?
They have mentioned lactose, but basically it is also used for short bowel syndrome also. This test
Yes,
for both lactose intolerance and for that.
true. But what is the risk factor for SIBO?
That is a extensive surgery which removes much of the intestine.
Okay. So yes, you can have as a differential where your B12 is low, but other thing which is very commonly mentioned in a patient of SIBO is
folate.
high. You have to think which is the more common, which is you have to rule out. The more common to rule out in UK population, you might have seen many other questions about celiac. You cannot. If you have unintentional weight loss, if you have anemia present, if you have malabsorption present, patient presented with malabsorption features with a diarrhea, you have to rule out. And this is what they are. They are asking initial investigation to rule out.
Sir, why folate is
The
increased,
more
sir?
common one, which is,
In SIBO, why folate is increased, sir?
So because of the bacteria overgrowth, it just consumes much and produces folate.
Okay. Thank you, sir.
Okay. So 52nd, done. 53rd, profuse diarrhea after, I think again a simple question.
Tuberculosis.
Why? Reason?
Bloody diarrhea
Bloody
and
diarrhea.
4-day history of
The
bloody diarrhea.
duration.
Duration.
Previously, what we discussed was
Amoebic.
1 week for Giardia and amoeba.
But over here, what we have is just 4-day history, and that to a bloody diarrhea. So Shigella is the one, right? Other options doesn't go in favor. Okay. Then is 54th, a simple question again.
GP syndrome.
Yeah, GBS. So GBS, definitely this is AIDP, this is acute, this is inflammatory, this is post-infectious, this is areflexia, this is ascending paralysis, and the patient has autonomic dysfunction. These are the points to remember, right? And also with another A is something called as ACD, albuminocytological dissociation. But that happens in the second week. You always check the CSF in the second week, right? As it was shown in one of the previous questions, CIDP, the proteins were pretty high, right? That is albuminocytological dissociation. WBCs are on a lower side, let's say less than 5 or 10 maybe in the previous question. But if WBC are 50 or 40, that just rules out. That just rules out. Okay, so GBS is the one, and what is the investigation you or a parameter you look for, or a finding you look for when patient
Albuminocytological dissociation.
when the patient has progressive paralysis involving the respiratory muscles.
FVC.
FVC.
Value? What is the value?
Less than 1,000 is ICU.
Less than 20.
Less than
20
20.
ICU, 15 is ventilation.
It is 20.
20 is HDU. 20. And
kg,
and 15
centimeter,
is
grams, water. What is it? ml, liter, kiloliter, femtoliter.
ml per
ml per
kg.
kg.
ml per kg. 50.
So these what you are checking is actually FVC. Definitely capacity is a volume. So ml per kg, right? So they might change the scenario. They will give a weight and they can ask, right? So you need to know, right? If it is 50, so it becomes 1,000, right? Although we take a ideal body weight, but they will not complicate much. They will just give a weight and they will ask. So if it is less than 1,000 in a case of 50 kg patient, obviously you will, what you will do? You will
ICU admission.
ITU, yeah, ITU or ICU. And less than 15.
Intubate.
Intubate
the patient.
And this has been asked multiple times, right? When do you intubate? When do you refer the patient to the ITU?
So for GB syndrome, they won't necessarily give diarrhea, this thing, CGGN thing, they won't give, right, sir?
Yeah, they can be scenario. It is post-infection, especially with the Campylobacter.
Campylobacter jejuni.
Yeah, I was confused.
7 to 10 days week prior, they can be history, or not just Campylo. Patient can have LRTI. Patient can present with UTI also, or a
Viral
URTI.
infections.
I'm very much sure about GBS, sir, but they haven't given any history of diarrhea, no? So I went for some other.
It's not mandatory for a patient to have diarrhea and then have a GBS. No, not at all. Right? It is usually associated with any post-infectious, but it can happen directly, right? So it's not mandatory to have infection.
Yeah, because I have seen mass infections in my hometown, sir. GBS.
In Maharashtra, is it?
No, sir. Guntur, it's Andhra.
Guntur, Andhra, yes. There were recently increase of GBS in Andhra and Mumbai and Maharashtra also, actually. Okay, 55th. 55th.
Acute
intermittent porphyria.
Abdominal psychiatry.
This is what we just discussed, right? Patient presenting with abdominal pain, right? So we have already discussed AIP, and heme arginate or hemin is the answer. 56th. Again, a simple question. Lymphoma. How do you differentiate?
Multiple ring
solitary ring and multiple
single ring
lesion and multi-ring enhancing lesion.
Toxoplasma ring enhancing lesion.
Okay. Ring enhancing is common. Both has ring.
Lymphoma single.
Multiple and single.
Multiple.
Toxoplasma and multiple.
Dr. Hani.
Mass effect.
So basically, lymphoma is single and SPECT positive. Toxoplasmosis is multiple and SPECT negative.
I need to ask, is he correct? Which one is positive? SPECT thallium. Is it SPECT thallium positive for toxo or lymphoma?
Lymphoma.
Remember, because it's a thallium. It is being taken by the proliferating cells. Lymphoma is a proliferating problem, right? There are proliferating cells, so they just uptake, and that is why it is positive. Whereas toxoplasmosis is an infection, hence there is no uptake of thallium, so it is negative. And toxoplasmosis can be multiple, can be single or multiple. Another difference: lymphoma is a homogeneously enhanced, whereas toxoplasmosis is a heterogeneous. Right? And the treatment for toxoplasma is SPF, sulfonamide, or you can say sulfadiazine plus pyrimethamine plus folinic acid. Right? So this is the treatment.
So this was in your YouTube channel, no, sir?
Yeah?
This was in your YouTube channel, no, sir? Yeah, you explained this concept in your YouTube channel also.
I think so, yes. I think so.
Yeah.
Excuse me, sir. Sir, as the patient is presenting with lethargy, confusion, personality change, and seizure, I mean the CNS symptoms, so can't we give corticosteroid in this patient?
Diagnosis of HIV, immunosuppression, neurocomplication of HIV, and if you can see ring enhancing lesion. So steroid is not the treatment. Had it been, there's a, let's say, there's any tumor. Because of that tumor, there is an edema around. So we give steroids to decrease that edema, right? This is very commonly used. But for toxoplasmosis, if that is a differential, there is no use. Steroid is not used in treatment. This is what I just said, SPF. So there's no role of steroid over here. Is that okay? But yeah, if you have a suspicion of any SOL and you think the pressure is increasing in the brain, and that pressure is because of the edema, it is pushing, right? There's a mass effect. The first thing to do is giving steroid to the patient, right?
I made the diagnosis of toxoplasmosis, but because of this reason, I thought there is edema, cerebral edema, so we should go.
No. When they have mentioned about enhancing lesion and multiple toxo is there. One first differential in a patient of HIV. Okay, 57. So that happens, right? Some other times you just overdo, right? You just think too much that, yeah, this might be something complicated. So you have to refrain. You have to just think about that, yeah, this is a common scenario, a simple scenario being asked. Somehow you believe, no, this cannot be MRCP standard. This is not matching to the MRCP standard. But now, some other questions which will be simple, easier, right? Okay, 57.
Treatment with allopurinol treatment.
After next, 3 questions. Can we take a break for 5 minutes? I need energy. I need some coffee. Or what do you do? Because we are just at 57th, and I think it might take another 1 hour or so. Are you all there with me?
Yes.
Yes, sir. Yes, sir.
I know this is exhausting for you. First of all, you sat for 3 hours, and now the discussion. But are you understanding what I'm trying? I'm investing
Yes, sir.
my time.
Yes, sir.
Investing your time.
Yes, sir.
Yes, sir.
Okay. So after 3 questions on 60th, I'll just have a 5-minute break. We'll have some caffeine because it matters to me most, right? My only thing is either the Coke or Pepsi, I mean the cold drink, that just increases my energy. The other thing is cold coffee. So either of the two, I'll just go. Although my wife is like, nahi, right? In the UK, I had much cold drink, right? All because I used to have many things done. So I used to be awake by using one thing, which is cold drink. But now it's a total no-no by my family. Please refrain yourself, right? So I'll just have my coffee. And I'll just ask you also to get energy, or maybe just stand up, energize yourself, just roam around, and we'll just start after 3 questions, right? Okay, right now, we'll just resume. 57th answer.
Treatment with
Treatment with
allopurinol.
allopurinol.
Why? Reason is?
Acute. It is not
Acute,
complicated.
The flex.
Most likely cause of the presentation, a patient who had chronic gout, right? Chronic alcohol abuse, present with gouty tophi. Tophi means there is a chronic gout. And now he was commenced on allopurinol in this admission or in this visit, and now presented with severe joint pain, which is bound to happen. So you do not add allopurinol during acute attacks. But if I change the stem, patient was already on allopurinol and you continued it. That is what is required.
Okay.
You do not stop. You do not stop. If it is continued, if the patient is allopurinol of a chronic gout, you do not stop. But chronic patient, if presenting to you with an acute flare or acute presentation, you should not add allopurinol. Reason?
It will increase the severity.
Increase the severity.
Exacerbates condition.
Mobilize urate crystal from tissues into the joints. Right, so this is the one. This is the one. So always remember, you should always add. Now, coming on to the most important topic of this rheumat is how do you manage acute gout?
NSAIDs,
NSAIDs, colchicine.
With PPI.
With colchicine.
NSAID plus PPI. Remember, like that, in that manner. If there are contraindication for NSAID, then you have to go.
Colchicine.
Colchicine is not to be given.
Severe renal conditions.
Renal condition.
What is the renal condition?
Less than 30.
Less than 15.
It
Less
should be
than
modified
15.
less than 30.
10.
less than 10.
We discussed that 10 to 30 or 10 to 50 in some other reference book mentioned as you should use as a caution. More than 50 it is normal, it is safe. But less than 10 according to the BNF it is absolute contraindication for colchicine, right? So for colchicine. And third is steroid. Fourth is
Canakinumab.
Rasburicase.
And canakinumab. Yes. And for the
And intra-articular.
you have allopurinol, you have febuxostat, you have lesinurad. So you have all those uric acid agents also, right? Okay, great. 58th. And we'll revise that in our sessions also in the upcoming sessions. DVT and mother also has a history. Most likely is the most commonly seen, right? Then is 59th pro-inflammatory, a question which is a very weird one, I would say.
TNF alpha.
What are the others? What are the others which are the
IL-6.
Interleukin
1 and interleukin 6.
IL-1, right? They are the pathology. Which is IL-1 inhibitor?
Anakinra.
This was asked recently in the exam. Anakinra is recommended for one situation.
Still onset.
Still disease. Another biological agent which is important for you is secukinumab.
P17.
It is
17.
is used in I can Dr.
Yes.
Suhail speak.
Yes.
Dr. Suhail, is it you who mentioned IL-17?
Yeah.
Just figure out your voice. He's so nice, so great that he came 4 hours. He and Shugufta and meet me in the UK in London. He's residing in Liverpool. So they both of them came 4-5 hours, spending 4-5 hours and meeting me in London, and then going back again, taking 5-6 hours. So just this is I believe the second time you answered, right? I was just able to figure out that this is your voice. So great, happy to see you first of all, and see you on.
Likewise.
Okay, so this is secukinumab is ankylosing spondylitis. Secukinumab. Another one which I wanted to discuss is ustekinumab.
IBD.
12 and 23.
Interleukin 12 and interleukin 23.
Good. So these are the ones you have to remember. There are other monoclonal antibodies. Definitely you have the PDF also. Remember not to escape monoclonal antibodies for your exam. It is very, very, very essential, right? Because these are the hot topics. They just give a biological agent or a monoclonal antibody and they just ask a mechanism. That's it. It's a black and white. There's no gray zone. There's no concept, whether you know it or you don't know it. So it's that clear. Okay, last question, and then we'll have a break for 5 minutes. 60th.
Amoxiclav.
Human bite.
Invited animal bite.
Site bite.
So human bite answer is coamoxiclav. Dog bite answer is
Rabies.
who is dangerous? Or both of them are dangerous, human and dog.
Human bite is
dangerous.
Okay, so with both of them we are managing with coamoxiclav. That means they are equally dangerous, right? Okay. So anyhow, and what about the cat scratch?
Bartonella has
Supportive.
We need to manage.
Nothing. Monitoring.
Yeah. Any treatment for cat scratch?
So supportive treatment
Monitoring
unless
to
the patient is
support the-
immunocompromised.
Yeah.
So usually patient will have on the same side has a lymphadenopathy, cervical lymphadenopathy or axillary lymphadenopathy, but nothing to be done. This is supportive. But if it becomes suppurating, if it is severe, patient have systemic features also, it becomes severe lymphadenopathy, there is a treatment. Can I have the answer?
Azithromycin.
That's what I wanted. So azithromycin and a cat scratch if it is severe, otherwise supportive. Dog bite, human bite, answer is co-amoxiclav. Okay, now I'll just take a break for 5 to 10 minutes. I'll just get back to you with my coffee. And you also stretch yourself and definitely try preventing your DVT risk also. Try stretch yourself, try standing out, and then energize yourself. For the next 1 hour, I'll just try to complete the remaining 40 questions. So I'll just resume in 10 minutes. Okay, see you. Yeah, hi. All there?
Yes.
Audible? Okay.
Yes.
Yes, sir.
Yes, sir.
Great. So we completed 60th and 61st. Yeah. Why is the answer? What is the answer, first of all, and why?
Sir, no management is isolated posterior pericardial effusion with no clinical significance. No need to do anything.
No need. And if you talk about the effusion, they have mentioned small posterior with a normal wave, so nothing done, right?
Yes, sir.
Side more than 100 ml with the symptoms, obviously you need to drain, right? But right now, there's no need. So it is equivalence or observation. 60-second. 60-second.
Cerebral venous thrombosis.
Why? Reason?
Pregnancy is risk factor for cerebral venous thrombosis, most commonly, and seizures.
Exactly.
Painful third cranium.
Exactly. So, pregnancy is a risk factor as it can have a prothrombotic condition, right? So, pregnancy just says there's a prothrombotic condition. Plus, presenting with the seizures, which is terminated, right? And all these symptoms, vomiting, nausea, frontal headache, that itself says there's something going in the brain. And very commonly is CVT, cerebral venous thrombosis. This is how they present, right? And obviously, we'll discuss more in our sessions also, in our revision session. I'll discuss about that. 63rd. So,
Short bowel syndrome.
Short bowel syndrome.
Short bowel syndrome.
this is what I was talking about, right? When you have the surgery, right? Colectomy, resection, and now patient presented with a severe watery diarrhea, and whenever he or she able to attempt to eat, then yes, they have a short bowel syndrome and can present with all these features. So this one done. 64th. Important and simple, I would say.
High concentration
Concentration
oxygen.
oxygen.
Yeah, high oxygen. Why? Reason?
Because the patient is used to a low oxygen which drives his respiratory
COPD
syndrome.
patients.
When overwhelming high oxygen is given, his respiratory depression takes place and he gets worse.
Yes. So always aim for 88 to 92% in the COPD patient, right? The saturation. If you increase it, that takes their respiratory drive. So never increasing that. Okay. Then
So
65th.
what is the pulmonary artery relaxation and pulmonary vein relaxation?
Okay. So what happens is whenever there's a hypoxia, pulmonary vessels go into vasoconstriction. Right, so that is a normal mechanism. But when you give this oxygen to these patients, what happens? That effect is taken off, right? There is a that has inhibited. So normally normal response is a hypoxia, right? So basically it is about shunting, and your body is trying to conserve. If there is a hypoxia in these guys, pulmonary vessels constrict in that area. But if you give more of oxygen, it just vasodilate, and that increases the VQ mismatch, right? So that is the another reason why you should not give oxygen to these patients. Okay, 65th. Simple question again.
Hypocalcemia.
Yeah, hypercalcemia. Why? Because of malignancy. And whenever we have malignancy, we have something as PTH related peptide, parathyroid related peptide. And definitely hypercalcemia, if I talk about, you need to remember what is the first cause you have to consider. First differential.
Yes. That's no.
Lung carcinoma. Squamous cell.
Hyperparathyroidism.
Hyperparathyroid is the first differential. You have to think about the PTH, right? So hyperparathyroid. Then comes the malignancies, exactly. So in the lungs, it is
Squamous cell carcinoma.
Squamous cell.
cell carcinoma, right? And it can be multiple myeloma for your patients. It can be sarcoidosis. It can be milk alpha syndrome, and there's something called as FHH.
Familial hypocalciuric hypercalcemia.
Where's the defect? CASR gene, calcium sensing receptor, CASR gene. So familial hypocalciuria, hypercalcemia. So patient has hypercalcemia, and whenever patient has hypercalcemia, remember you have to give hydration. And these are the patient who presents with neurological manifestation, depressed conscious level. They have constipation, they have renal stones, so abdominal pain. This is how they present. More of thirst. So these are the presentation you need to remember, right? Okay. Then 66th.
Beriliosis.
Yeah.
Beriliosis.
Good.
Nuclear
Beriliosis.
power
What is the
plant.
risk factor for beriliosis?
Nuclear power plant.
The
Inhalation
new
of fumes.
power plant.
In power plant, in nuclear plant especially, and working in the electronic areas or electronic industries. These are the terms you need to remember. For beriliosis, nuclear plants, nuclear areas, electronic industries, telecom and semiconductor also, right? So this is what you need to remember for beriliosis. Others, you know it, right? Sarcoid and all those doesn't actually stand over here in front of the question. Okay, then 67th, and these are the patient presents with BHL, bilateral hilar lymphadenopathy also. 67th, a simple question.
Cyclism.
Yes, but can be confusing. It is just what they are talking about. Are these symptoms constipation, dry mouth, increased sleepiness? These are called as
And cholinergic anti.
exactly. So
Cholinergic side effects.
these are the muscarinic side effects, right? Cholinergic or the muscarinic out of that, right? Not nicotinic, it is the muscarinic side effects having all these symptoms, and cyclizine is the one. So this is a pharma question.
So when do we use domperidone?
When to use domperidone? Domperidone is used for
Gastric motility increase.
exactly. So it acts on the gastric center and the neuro center also, the vomiting center. So it is acting on the D2 receptor actually, right? Okay. Then is 68.
No, vasopressin, tolvaptan.
Okay. Now again the same question. This question, I would say, what is being asked?
Last line.
Unnecessary. Wasteful stuff in the exam, right? Reading hyponatremia, then creatinine normal, urine spot on a higher side, thinking hyponatremia algorithm. Why? They just asked what is the mechanism of tolvaptan. That's it. Now the answer would be
V2.
V2 receptors.
and it becomes very painful when you have gone through a whole of the stem and ultimately what they have asked, you don't know it. Anna? They have asked just a mechanism and you don't know it. It becomes very painful. Oh, I have wasted a whole of my minute reading the question, going to the diagnosis, but what they have asked is an unnecessary weird thing, which is a mechanism. Okay. Then is 69th.
Hyponatremia due to diuretics.
Reason?
Bendraflutamide also present.
What are the reasons? What are the reasons? First of all, definitely patient presents with confusion. There is a thiazide and amiodarone which is being used. Further, what they say, postural drop. And pulse is irregular, okay. And then if we see the creatinine somewhat high, urine sodium on a higher side, right? Now, if we see this scenario, whenever we say there is a postural drop, that means what? That suggests autonomic variation or autonomic dysfunction, or you can say there is actually less volume in the body. Now this line just says there is a hypovolemia and patient has hyponatremia. If you remember that whole algorithm which we started and further into volume, hyponatremia, then over here we have true hyponatremia with the serum osmolality also low. Then based on the volume status, we divided into hypo, euvolemic and hyper. If you remember that algorithm, do you? No.
Yes, sir.
Now under hypo, we have two scenarios where it is either less than 20 or more than 20, the urine spot sodium or the spot sodium. Now, when we talk about hypovolemia, remember the diuretics are the ones, right? More than 20 you can remember with med docs. Mineralocorticoid deficiency, osmotic diuresis, and cerebral salt wasting. Remember, whenever we have osmotic diuretics, these are the diuretics which we think about. Patient can be presenting over here hypovolemia with urine sodium more than 20. In endocrine, I'll discuss about this algorithm. Do you want me to discuss this algorithm right now?
Yes.
Yes, sir. Yes, sir. Yes, sir.
Okay. I was just trying to skip, but yeah. So I already have my energy, so don't worry. So hyponatremia. Now, what you right now check is the serum osmolality. Now, if serum osmolality, which the sodium is the main determinant, if it is also lower side, we term it as true hyponatremia. Sorry, true hyponatremia. But if osmolality is either high or low, as in the case of proteins, lipids, mannitol, radiocontrast dyes, glycerine, glycine, glucose, if these are the things, remember they are on the other side, it is called a pseudo hyponatremia because serum osmolality is not low as compared to the sodium. Now, further after that, the step we go for checking the volume status and we divide into three. This one is hypovolemic, where you check the skin turgor, you check the heart rate, the blood pressure, the urine, especially the amount and the color, right? So these are the variables. You check the mucous membranes, whether they are dry or not. The other one is euvolemic and hypervolemic. Under hypo, now is the step where we check urine spot sodium. First place, serum osmolality. Over here, volume status. Third, urine spot sodium. Now, it can be less than 20, more than 20. Less than 20 means it is patient having extra renal causes, as in the case patient having diarrhea, vomiting, burns, anastomotic leak, pancreatitis. These are the causes, right? So remember just as diarrhea, vomiting over here. Or the losses, right? More than 20, remember this mnemonic med docs, mineralocorticoid deficiency, osmotic diuresis, CSW, cerebral salt wasting. So this is CSW, this is osmotic diuresis, this is mineralocorticoid deficiency. Euvolemic, I need to know answers from your side. Can I have?
SIADH.
Okay.
Addison.
Thyroid disorder, which can be hypo or hyper. Then, good, one of you mentioned adrenocorticoid insufficiency.
And adrenal.
Adrenal, yes. Adrenal insufficiency, which is important for the exam. Then there can be one point I just mentioned because it was asked once. It is beer potomania. Just remember that. So these are the ones which is, and also psychogenic polydipsia also that comes under euvolemic. Hyper, as the name says, so you will see edema, the peripheral edema. You can see crackles or crepitation in the lungs. You can see elevated JVP. You can see ascites in a patient. So these are the things which tells you, right? These are the features which tells the patient is in hypervolemia state. There is much of volume in the patient. And obviously, the first thing is congested. Then CLD or liver failure. Then is AKI or you can say nephrotic. And fourth is very important is decreased albumin. So this is the whole algorithm of sodium, and very importantly, please do not forget euvolemic, this one and this place. These are the ones. They don't usually ask about hyper. They don't ask about diarrhea, vomiting. They don't, right? But remember, urine sodium will be on a lower side because body will try to conserve everything, which we read in your pre-renal. Do you remember that table of pre-renal and ATN?
Yes, sir.
Or it tries to retain everything. That is why your FENA is high or less in pre-renal.
Excretion of sodium.
Is high or less?
Less than
1 plus.
In pre-renal AKI. Even the fractional excretion of urea also, it is less than 35%, if you remember.
Yes.
So so all those things we discussed, and definitely I'll discuss in nephrology also. Me or Dr. Beg will discuss. Okay, now going forward to the next. So we are done with this one. You're done. 70th. Another question about spirometry, which is again important. What do you it is associated with?
Obesity.
Yeah.
Obesity.
Obesity, yeah.
Discuss obesity. Exactly. RLD. And now with FEV1, FVC ratio seems to be normal. This is a normal. This is not increased, by the way. Okay? This is normal. And, or you can say more than 0.7, more than 70%. If we see the decrease, we don't see the liters over here. We see the predicted decrease. The predicted decrease over here is much. So FVC is much, but FEV1 is not. That itself goes in favor of RLD. They have provided additional FEV1 by FVC ratio also. Now, out of these options, which is the RLD?
Obesity.
Are the ones? Which are the ones?
Obesity.
Only obesity.
Only obesity. Only obesity. So answer is over. Right? So only obesity is restrictive lung disease. Bronchiectasis is obstructive. Emphysema obstructive. Obliterative bronchiolitis obstructive. Asthma obstructive. That's it. 71st.
10
10
ml
ml,
of 1 in
1 in
10,000.
10,000.
10 ml in 1 in
1 in 1,000.
You sure? All of you?
Yes.
Not this one?
No, sir.
No, sir.
Reason?
And
That's given in
European guideline.
anaphylaxis. IM.
Anaphylaxis. What is the dose? Someone answered anaphylaxis. What is the dose of
0.5 mg.
0.5 ml, 1 in 1,000.
0.3 to 0.5 milligram. In the NICE guidelines, they specifically say 0.3 to 0.5 and specifically 0.5 milligram, right? Of 1 is 1,000.
1,000.
I got confused with this one.
So that is why the question was there. So don't worry. It's just a learning, right? It's just a learning. And now you are able to see where have you made mistakes. Obviously, the main thing is rectification is correcting those mistakes and trying to prevent yourself from those mistakes in the actual exam, right? That is the funda of Grand Mock or IMAT. It's not letting you know, don't know much things. No, it is about just giving you a reality check that you are making mistakes. You know the things, but you are not able to apply them. So the one thing which is very important, which will prevent you doing these things, is revision. If you revise it, your things which you have read, you might have written, or you have a screenshots, or you have let's say the PDFs. If you revise those things, obviously you will feel better, and these mistakes will decrease. Right? So don't worry. You all will do good. And remember why 10 ml is normally क्या है हमारे पास we have ADR as a 1:1,000, right? And we give IM deltoid. I mean, in the thigh anterolateral aspect of the thigh, we can use deltoid also. The NICE guideline says anterolateral aspect of the thigh, by the way, for IM. So you cannot dilute it. If you are giving an IM injection, you cannot dilute and give the drug because absorption will be delayed. So you give undiluted, which is 0.5 milligram in a case of anaphylaxis. Now, if IM is to be given in a cardiac arrest scenario, how much?
0.1.
It is whole 1 ml. If you do not have IV access. This is anaphylaxis. And for cardiac arrest, it is 1 ml of 1:1,000 IM. If IV access is not there. If there is IV access, then it becomes 10 ml of 1:10,000. Why do we do so? 10 ml. Why are we diluting it?
Rapid action.
Because rapid action we are
Rapid, or it will not be able to reach to the heart.
Collapse, venous collapse.
There is no movement of the blood. if let's say you have a IV cannula over here and you give undiluted drug 1 ml or 1:1000 over here, first of all, some of the part will be there in the hub of the cannula. Secondly, there is no venous movement, there is no flow of the drug. So you have to dilute so that 10 ml just goes. And what is recommended is you raise the limb also, right? So that it reaches the heart. Because nowadays there's no such kind of intracardiac, which is now there we can see in the previous Hollywood and Bollywood movies, and intracardiac, but it's not, and in some of the series also, but it's not there. It is either the IM or IV. Next, so 10 in 1:1000 is for IV, 1 ml in 1000 is IM, right? Okay, 72nd.
Clarithromycin.
Clarithromycin.
Legionella.
Legionella.
Forward.
Yes.
Yes.
This question brought a smile on the face.
Yes.
Yes, sir.
Sodium low and liver enzyme is straightforward, right? Nothing can be straightforward than this one. Crack shortness of breath, so definitely it is Legionella, and answer is clarithromycin.
It's a reliever question, sir.
Reliever question. Breathers, yes. Okay, next one.
Sagittal sinus.
Sagittal sinus thrombosis.
Sagittal sinus thrombosis. What happens in sagittal and why the answer is sagittal?
Third nerve palsy.
Third nerve palsy, sir.
Yeah.
So thrombotic, pre-thrombotic state, and all the third nerve palsies features are present.
Hospital headache.
Bilateral bleeding.
Good, bilateral bleeding, and there's a right?
Third nerve palsy.
All these goes in favor of sagittal sinus thrombosis because patient is at a risk of a prothrombotic condition. And when they talk about headaches, they talk about papilledema or blurring of the optic disc. This line itself says papilledema. Papilledema means there is an increased pressure in the brain. That's it. There's an intracranial hypertension. That's it. Okay. Then is 74th. Answer.
Supportive therapy.
Which one?
Supportive therapy.
Reason?
Sir, I was thinking of hereditary spherocytosis.
Okay. Hereditary spherocytosis. What is the... This is a
I
confusion.
was thinking it's pancreatic.
Painless jaundice. I was thinking painless jaundice.
Wait a minute. I'll just give you a hint. Patient having jaundice. Patient
അതല്ല അത് നിന്റെ മുണ്ടാതെ എടുത്ത് വെക്ക് എവിടെ
patient
എടുത്ത്
having
വെക്ക്
I
നീ എല്ലാ
didn't
ഇതിനും കൊടുക്ക വെച്ചോ
Rajila. Just muted you anyhow. So it's high cholesterol, high triglyceride. That means lipid profile is deranged with a jaundice. Plus, there is a hemolysis going on. Is this a kind of triad?
Zeev syndrome.
Zeev syndrome.
Yeah, Zeev syndrome.
Yes, sir. Zeev syndrome.
Alcohol, hemolysis, hyperlipidemia, and nothing to be done. Nothing to be done, right? So observation is the answer. Management is supportive, right?
I could diagnose it, sir, but treatment part that didn't stuck to my mind actually.
So that happens. Acha, if I talk about alcoholic liver disease, what is the ratio of enzymes? Is it AST by ALT or ALT by AST?
AST by ALT.
2:1.
More than ALT. 2:1.
And how do you manage alcoholic hepatitis? That is the question.
Steroids.
Corticosteroids.
Good. When do we add steroids? Good.
Madly scored.
Yeah. Yes.
Madly
Discrimination factor scores, right? So this is MDF. Remember, MDF more than 32, add steroids to the management. And whether you need to stop or continue depends on Lilly score. These are the two scores I want you to remember for alcoholic hepatitis, which is again a hot topic for exams. Okay, then 75th. A simple question.
Sorry, can you please repeat the MDF score and Lilly score once again, please?
So in a case of alcoholic hepatitis, how do you manage is obviously you go ahead with, you check MDF score. We don't have to see the variables of it. Remember MDF score, if it is more than 32, add steroids, patient benefit out of it. But the other question is, if you have added steroids, how to see or how to monitor whether patient is benefited? Should you continue or should you stop it? Is with a score which is Lilly score. 0.45 is the number actually for the Lilly score. Anyhow, don't go into much depth. Just remember MDF and Lilly's. These are the two scores used for the management of alcoholic hepatitis for steroids. MDF more than 32, add steroid. You need to continue or you need to stop, go with Lilly score. Right, that's it. Is that okay, Dr. Kriti?
Yeah, thank you.
Welcome. 75th.
Iosine butyl bromide.
Iosine butyl
A simple
bromide.
question, right? A simple question for pooling of
Secretions.
exactly iosine butyl bromide, and obviously you have those infusion pumps, right?
Sir, you said one topic regarding the same thing. When to give this high dose morphine when we can't do anything to the patient. You said some topic relating to that, sir. I couldn't remember it right now.
Okay, no idea what you're talking about. Topic of morphine.
Not morphine, sir. This death rattle thing itself.
Okay, so whenever you come across the same question, do let me know, right? We'll share it and we'll discuss in the revision batch. Okay.
Before exam.
76th. Can I have the answer for this one? Again, analog or what are they talking about first of all?
VIPoma.
VIPoma, or it is called as Werner Morrison syndrome, right? And patient has something called as WDHA.
Watery diarrhea.
Watery diarrhea.
Watery diarrhea.
Hypokalemia.
And
Alkalosis.
Acidosis.
Acidosis and
achlorhydria or achlorhydria, right? And you add somatostatin analog. And this is a very common thing they usually do, providing somatostatin analog, and they can just say analog or antagonist. They can add these, right? They can confuse you in the exam. Analog or antagonist. It is actrotide is somatostatin analogs. Okay, class 2 MHC again, a waste question from
B cells.
Yeah, you have to remember B cell dendritic macrophages. So these are basic sciences. I can't help it much, but yes, we have to remember, we have to mug up, we have to cram, and keep last few days, especially obviously according to our revision batch, also the schedule also will be revising the last. So you have to, right? You don't have to escape from these questions. Okay, 78, because these are very high scoring in the exam. 78.
It says scleroderma, systemic sclerosis.
Systemic sclerosis.
Most commonly seen in secondary Raynaud's phenomenon.
So now what they have mentioned is Raynaud's, right? And patient has difficulty swallowing also.
It's the phasodactyly.
It's a feature of digestive ILD.
Still here, it is going in favor of CREST
syndrome. CREST syndrome with ILD.
Good. When they say ILD, so scenario changes to diffuse. And if I talk about limited, it is limited to
Face and
peripheries.
below
elbows
and
peripheries.
Distal to the elbows and distal to the knees. That is a periphery.
Distal to the
That is the reason you have anti-centromere. Center se bahar, right? It is anti-centromere. Whereas the diffuse in this area, the trunk area, the chest area, the back area, proximal to the elbows, proximal to the knees, this is diffuse. And diffuse, what you have is this antibody. But if they say which is the most likely antibody to be seen,
ANA.
Please don't make that mistake. Most likely antibody to be found, answer in these two situations, whether it is sclerosis, if it is dermatomyositis, if it is polymyositis, if it is PBC, in all these situations, if they have asked most likely to be seen, answer is ANA. Right? Okay, 78th done, then 79th.
Methemoglobinemia.
Methemoglobin, right? So bluish discoloration of the lips, and what changes? The answer is this one. Why?
Symmetry.
85% despite having a good PaO2. Why? Because what is the
Pulse
difference?
oximeter is not detecting the
Like
Pulse
pulse oximeter
oximeter is not able to detect the
exactly, it's not able to detect, right? Because methemoglobin, this hemoglobin is not able to carry the oxygen, right? And this is not able to detect the methemoglobin, right? The pulse oximeter, and that is why the saturation is on a lower side. But in the serum, PO2 is normal, and that's the reason because saturation is on a lower side. Remember, the color for methemoglobin patient is chocolate,
Blue.
whereas for carbon monoxide poisoning,
cherry red.
Cherry red.
cherry red.
how do you manage carbon monoxide poisoning?
Hyperbaric
100%.
Oxygen.
100%
oxygen.
oxygen.
And then
Try
100% O2.
try for 100% oxygen first of all. If there's an option and if they say patient is not improving, then it becomes hyperbaric, right? Okay, that's it. And whereas what is the treatment for methemoglobinemia?
Methylene blue.
Methylene blue.
Methylene blue.
IV methylene blue.
Congenital vitamin C.
Like a vitamin C.
Good. If it is a congenital, not acquired one, then it is IV, right? Vitamin C. Good, good, good. Great. 80th. What is the management? What is the cyanide poisoning?
Bitter almond smell.
Bitter almond smell and
Bitter.
Bitter
And
thiosulfate. I think
yeah.
thiosulfate or
saturation is
sodium
Hydroxycobalamin.
thiosulfate is used for the treatment.
Sodium thiosulfate and hydroxychloroquine.
Dr. Ajila, kindly go ahead.
Yeah.
What happens to PO2, SAO2, and how do you come to know patient has cyanide? Let's say patient has
The SPO2 might not detect it, it will show it as normal, but the affinity is actually reduced. Their cytochrome is affected, I think cytochrome P4. And there is management, we go for sodium thiosulfate and hydroxycobalamin.
Good. Hydroxycobalamin is the main plus minus thiosulfate. Good. Perfect. Perfect. That is cyanide. And both carbon monoxide and cyanide can happen with the fumes, right? They can give a scenario of fire at home, at house. So both can be a scenario. And the only thing which favors cyanide would be lactic acidosis, remember, right? If the stem says there's a lactic acidosis, obviously that's the answer. Okay. Coming on to the 80th question.
Right superior oblique palsy.
Right, yeah.
Right superior oblique palsy.
Superior oblique palsy.
Palsy, why?
Because it's upward.
It's cranial
It's not able to do it upwards. So torsioning.
Upwards.
No, like it's difficult to see the
downstairs.
downstairs.
Downwards.
It's not able to see the down.
This is
Not
the
able
answer,
to see
right?
the down.
In torsion,
Down and out.
down. In torsion and down. And when you are walking down, obviously you will not be, right? You are walking down the stairs, you'll not be able to, and you have that problem, right? That is superior oblique. And what about inferior oblique?
Not able to see
Upwards.
upwards.
Up
Not
and
able
up
to
and
see
up and out.
upwards.
Oh, yes.
Up and out.
Good, good. And we'll talk
How
about
did you figure out the right? Because I could not figure out if it's right. Because right was not mentioned. I just did not pick the right answer then.
All the options.
All other options are not right. All other options are not there.
Yeah, I know, but as it was not mentioned in the stem, I just got confused that.
Okay, so they have just provided that, right? Obviously, they have not mentioned, but none of the options is right or left, right? So it's
Yeah, I thought. Okay.
and then after the session, I'll discuss more about all the palsies, right? What happens with the lateral is obviously related to your abduction. Medial rectus is related. Actually, one thing I need to discuss is INO, important. INO and MS. If they say bilateral INO, answer is
MS.
MS.
What do you mean by INO? Internuclear.
Internuclear of
Painful eye movements.
With nystagmus.
1%. I can
Painful eye
see
movements.
the twin sisters again, Dr. Pratima and Dr. Pratibha. Yeah, so yeah. So one of you, Dr. Pratima.
Diplopia and painful eye movements.
Diplopia and okay. How diplopia? What happens to the pupil, right? Which one goes into nystagmus?
Okay. Unaffected one.
Normal one.
Normal one goes to
Normal one will go
It's
to
contralateral nystagmus and ipsilateral diplopia.
Ipsilateral, you have mid pupil. It will not be able to adduct. Contralateral, you have nystagmus. You ask a patient to see on the left side. This pupil, this eye will go onto the left side, abduct, but there will be nystagmus. Why? Because this eye is not able to adduct. So this eye, the other eye, is trying to go back, trying to create an image on the retina, because problem is over here, right? This is not able to adduct, and that happened. That adduction is not because of third nerve. Remember, in INO, the pathology happens at the level of MLF. Right now, I'll not go into concept, right? There's a concept I might have discussed with you, right? With that figures and all. Remember, there's a medial longitudinal fasciculus which is involved, and this just correlate. There's the third nerve and the sixth nerve involvement. Now, remember, when the third nerve medial is not working, this eye will not able to adduct. So, ये center में होगा. It will be in center position. Whereas this eye will go abduct, AB abduct, but will have nystagmus. So remember, contralateral nystagmus and ipsilateral mid pupil. This is what you need to remember for INO, right? For your exam. Forget about the concept, forget about the illustration and the diagram. This is what you need to remember. And when they talk about unilateral INO, can I have the answer? Most common cause? Yeah.
Optic neuritis.
Optic neuritis, nahin, optic neuritis is a common symptom, a sign of
Demyelinating doesn't.
optic neuritis is just there is a optic nerve which is inflamed, and whenever patient have a eye movement, it's a painful eye movement. That is what optic neuritis is. Very commonly seen in MS. But unilateral INO seen in stroke, bilateral INO seen in MS. But for your exam, MRCP, INO means MS. If they mention about abducting and mid pupil, answer is 99% MS. Okay, 81.
Patent for an innovate.
We have had a discussion about PFO, right? So this is again the same, and we discussed about how PFO differs from ASD, right? And this is another topic, another question, because patient had neurological manifestation after having a long flight, right? This is a risk factor. So what you have to rule out, you have to check is a PFO, and PFO can be checked out with your bubble echo or fast echo. 82nd.
Prothrombin complex.
Yeah.
What should have been the best answer for rivaroxaban?
Adnexate alpha.
Wait a minute. And Exanet alpha. This is the name. And Exanet alpha is a antidote for rivaroxaban. For another one is apixaban. Remember, right? So very commonly. But if that's not available, you go with PCC. What is an antidote for dabigatran? Idarucizumab. Yes. What is the antidote for warfarin?
Vitamin
K.
Vitamin K.
What is the antidote for heparin?
Protamine sulfate.
Great. Okay.
Can you write them just down for the PDF later?
Dr. Suha, kindly mute yourself. Yeah. 83rd.
Say again?
No, I was just saying you were talking somewhere else.
Oh yeah. I just wanted to say if you can just write the antidotes just on the PDF so we can.
Okay, you want the PDF, Acha. You are requesting me. So I think that is there in the group already, no?
Yeah, I think it will be somewhere, but just because when I go through this PDF, I
go ahead in the revision sessions. Don't worry. 83rd.
Con syndrome.
Why? Reason is obviously you have to look for these electrolytes which are important. Hypoxemia and alkalosis, which is Con syndrome. Okay.
Sorry. I think I got confused. So I thought CAH is more common, and I ended up thinking like that more than cons. Or am I missing something?
Which one is common? CAH is more common. Congenital at 20 years.
Fine. Yeah, fine.
That happens.
Okay, sorry.
Okay, no worries. 24th. This is again a headache. I mean the ophtha, I know, but yeah, this is how it presents. CPEO, which is another pathology you need to know how the ophthalmoplegia, the CPEO presents, is especially symmetrical involvement. There is bilateral ptosis, and the diagnosis is done with muscle biopsy, and no surgery or no specific treatment is required. But if there is a blurring of vision with the ptosis, obviously then ptosis surgery is provided. Otherwise, nothing done. So a key word is symmetrical, slowly progressive, and bilateral ptosis in CPEO. This is what you need to remember.
So
And there is no evidence of convergence, distraction, nystagmus, which is key feature of
Perinod.
Perinod syndrome.
There's one sign in perinod, which is called as
Coleus.
Coleus sign. There's a lid lag. That's it. Yeah, someone was asking a doubt. Okay, never mind. Next, 85th.
Factor 8.
Yeah.
Hemophilia factor 8.
Factor 8, hemophilia, isolated rise of APTT, it is factor 8. 8, is it a factor or an extrinsic factor? It comes under intrinsic. Extrinsic, you have only one.
7.
First.
And tissue factor.
And you can see 7 written in E, the upside down 7, right? So 7. Remember that. And there's a mnemonic which you all know, wept. Often extrinsic PT or INR. The other one is winner. Warfarin affects INR, right? The others are over here. Then the common pathway are 2, 5, 10, right? So this is the common pathway. Okay. So if you have the 7 extrinsic gone, then only you have the PT-INR. Otherwise, if intrinsic is involved, then you have APTT. If common 2, 5, 10 are involved, you have both derange. PT-INR derange, APTT derange. But what about the bleeding time? That tells you platelet.
Von Willebrand and
Good. So von Willebrand, what do you expect? Von Willebrand disease? Increase
bleeding time.
And increase
And APTT.
Yeah, APTT.
And what about PT-INR?
Normal.
Good, perfect. Because von Willebrand has a problem with the platelet adhesion, first of all, which is required at the step. Plus, it carries factor 8. Because factor 8 is involved, 8 comes over here, intrinsic. So APTT high. And PT-INR, because it is extrinsic and 7, so PT-INR will be normal in von Willebrand disease. Okay, now moving forward is 86th. Again, a question we have already discussed. 100%. So always remember, next intervention is 100% oxygen. If patient doesn't respond, then only go to hyperbaric, otherwise not. Remember that.
pH is 7.15. Severe acidosis.
Thinking of that, I went to hypercarb.
I went for the bicarbonate. pH is severe metabolic acidosis, right?
Okay.
Even I went for the same.
Okay.
So I thought of it is bicarbonate will be the first to.
Bicarb is never the answer, it's just TC.
I think it's ABCD.
ABCD.
Exactly. What is the first thing?
Yeah.
Maintaining the airway. Give oxygen, and that is the main treatment. Everything resolves if you give oxygen to a carbon monoxide patient. Why this is happening, why this deterioration is happening is why? Because carbon monoxide has attached. Why patient is, I'll just go into some concept already, it's quite low. Why patient present with acidosis? It is attached. It is not being released, and OTC curve just shift to the left. And because oxygen is not released, what happens in the peripheries throughout the body is more of lactate because of anaerobic metabolism. And that lactate is responsible for this 7.15. So what will be the answer, Dr. Pratima or Pratibha?
Yes, sir. 100% oxygen.
So when the patient is extremely drowsy, so we should go for hyperbaric oxygen, right?
उस हिसाब से इंडिकेट कर देना चाहिए ना Hyperbaric will do what? Hyperbaric is nothing. It is a risky for this kind of patient to even enter into a dead chamber. Have you seen that? It's a very suffocating chamber. Hyperbaric. It's very suffocating. It's an enclosed one. And you cannot have all these things inside, right? IV cannulation, giving drugs, no, nothing. It is totally packed. And the pressure is pretty high. You do not give these drugs. You do not enter into these situations when the patient is already drowsy, right? So it is already a no. But according to the NICE guideline, I would again say, if this kind of question comes and you have both the option, always check and go with, first of all, is 100% oxygen first. If not responding, now go to HBOT, hyperbaric oxygen therapy, right? Okay. 87th.
So how about if the percentage is like in this scenario it was 12%, or how about if it's like more than 30%, which is a severe carbon monoxide poisoning? In that case, would we still follow the same route of going of 100% first?
More than
No, then
25 to 30%, it is indicated for hyperbaric actually.
hyperbaric. Okay, all right. Thank you.
So, and we have seen these kind of patients, and actually hyperbaric helped, right? We had two patients who presented in that manner. There is something called as what kind of geysers? There's a name, gas blowing.
Gas geyser.
Yeah.
There's the LPG gas geyser, closed ventilation.
Exactly. So this is how there was a 19-year-old female who presented to our ICU with the fire in the washroom, and she was collapsed, and she was presented. She was in carbon monoxide poisoning, and we rapidly, as she we just resuscitated and we shifted to hyperbaric, and she responded dramatically, right? So this is, and the carbon monoxide level was very high in that patient. So again, yes, if it is very high, you have to the HBOT, but NICE doesn't say, right? NICE doesn't recommend. It just says if 100% is not effective, then go to it. But 25-30% is actually very high for these kind of patients. Okay, now going on to the next one, 87th, again a off-the question. RA patient
Episcleritis.
with a dull pain. So remember two pathology, episcleritis and scleritis. Episcleritis already have P, so there is no pain.
No pain.
Scleritis doesn't have P, so pain, a very painful eye will be present with scleritis. Remember that, right? And conjunctivitis definitely not, because there is no discharge. Angle closure glaucoma is another one. This is a rare one, scleromalacia perforans. This is a rare one, right? So done with this one.
Patient is having dull pain, so it will be scleritis, right?
Yeah, even I went to scleritis.
Even I went to scleritis.
It is dull pain.
This is a confusion created. It's a dull pain.
Yeah.
They
Dull
have
pain.
constant and intense pain, intense severe pain. Right?
Episcleritis is painless, then how do
Yeah,
we really?
exactly. We say painless or a very less painful, less, right? And that is what they tried to confuse with a dull pain. Anyhow, 88. So these are part and parcel, right? So these questions comes along. 88.
Warfarin with INR 2 to
Warfarin 2 to 3.
Why? What is the score for this patient? Chad was score.
2.
Why?
PIA.
History of PIA.
PIA.
Patient already had a previous history of stroke or a TIA, gets a score of 2, right? Although age is 60. So you have to go with warfarin and keep a range of 2 to 3. 89. A simple one again.
Pulmonary.
10 blisters, no mucosal involvement. Mucosal
Sorry,
involvement is
Dr.
there in.
Can I ask you one
PS
thing?
vulgaris.
Yeah.
Dr. Shah, can I ask you one thing?
Yes, you go ahead.
Regarding the previous question, so this patient had a TIA. So we don't give aspirin.
We don't give
usually for
aspirin is the initial management. Yes, acute management is aspirin, definitely, whether it is TIA, whether it is ischemic stroke. But appropriate is definitely the patient over here is at a risk of developing another thrombus. So what you will give mainly is the warfarin, not, and the other option is saying giving warfarin and then aspirin. No, you have to give anticoagulant. There's no role of antiplatelet after 6 months. Acute stages, yes, you are correct. Aspirin is given. Along with that, warfarin is given as an oral anticoagulant to prevent another episode. or to prevent embolic phenomena. Do you get that, Dr.
Right. Yeah.
Okay, great. Then we did
Thank
this.
you.
Most welcome. 89th. Yeah. So yeah, bullous pemphigoid. Bullous pemphigoid has tense bulla, right? And there is no mucosal involvement and there is no pain. If you talk about the other one, which is PV,
Infectious vulgaris.
much pain. Why? Because there's an erosion and there's one sign which is present called as
Mucosa.
mucosal involvement is there, right? So though that goes in favor of pemphigus vulgaris. What are the antibodies related to bullous?
IgG.
Basement.
BP121 and
BP121, 230.
230, sorry. 230 and 180.
230 and 180.
I think that is for pemphigus vulgaris.
Yeah, there is pemphigoid. No, pemphigoid would be G1
and the other one is for
Pemphigus vulgaris is
Desmoglein
hemodesmoglein.
Yeah, 1 and 3, DSG 1
Yeah.
and 3.
one is below the basement membrane, which is
Vulgaris. Pemphigus vulgaris.
Pemphigus
pemphigoid.
and
Below pemphigoid.
No, bullous pemphigoid will be
Pemphigoid is on the basement
Above the
membrane.
basement membrane.
this is bullous pemphigoid. BP is bullous pemphigoid. So BP 230, 180. Now, one pathology is between the desmosomes. Answer.
Pemphigus
Pemphigus vulgaris.
Desmoglein 1.
Desmoglein 1 and 3.
True. Okay, now done and then 90th.
Topical ketoconazole shampoo.
topical antifungal.
Versicolor. Versicolor.
Depigmentation, especially scaling, right? So patient having brown, pink, hyperpigmentation. So that is a versicolor by malassezia fervor, and you have to go with oral, topical, and then later on can go with oral, right? 91st.
LFT and lipid level.
And lipids. LFT and lipids. 92nd.
Vitamin B12 deficiency.
B12.
B12
We have discussed.
Acute degeneration of spinal cord.
Yeah, SCD.
Whenever there's this posterior coronary involvement, keep SCD as one. So pinprick sensation, neuropathy plus there's a posterior coronary involvement. You have to think about SCD, please. So vitamin B12 deficiency. Then is 93rd.
Depression.
Great. So over here, patient is saying feeling terrible and all those features, none of the features going in favor. How does a Lewy body dementia patient presents?
Hallucinations.
Hallucination with Parkinson's.
How does the patient of Alzheimer presents?
Long history of dementia.
Long history of dementia.
2 years, 3 years, 4 years down the line, right? And there's a gradual worsening or progression of the disease, or you can say cognitive decline in the patient. There's a global thing which patient has forgotten, right? All the memory loss. Vascular means
Stepwise decline.
Personality change.
Personality change.
Personality change, or you can say focal neurological deficits. Because with the vascular, what you have is a common type as multi-infarct or ischemic, right? And these definitely have, let's say, the patient is not able to move the limb much. It is just 4/5 power. What do you think? That is a focal neurological deficit. That goes in favor of vascular. Okay. 94th.
Trauma focused CBT.
So yes, you go with CBT. There's something called as eye movement desensitization. Also, this is also therapy used, but not used much. A CBT में क्या है? You discuss. देखो, let's say patient has PTSD, right? Patient had some kind of trauma, as this given in there's some kind of accident, there was a child and all those things. So you sit down, there's a therapy session, you sit down with the patient, you discuss with him what are the problem, what are the nightmares, what are his thoughts, what happened at this point of time, and then initially, gradually, you keep telling him the scenario, and then you move. Initially, you go and take the patient in the quieter area at the quieter time at that same place, right? just changing the scenarios, going just nearby to the other lane, and then coming to the. So this is called as cognitive behavior therapy. Slowly and progressively, when you are talking, and then you are going in that manner. Eye movement desensitization. This is with let's say some kind of movement, right? You just ask, and you have the pictures also involved. So that is another thing. If patient doesn't respond to trauma focused CBT, next is go on to this one. But again, don't go into much. Has never been asked. This has never been asked.
Sir, but in question bank, in every question, sir, in past medicine, there was an answer of eye movement, desensitization, reprocessing. Sir, in PTSD, so initial therapy.
CBT was not given in the options.
Yes, sir.
Exactly.
Yes,
When CBT is not given in the option. Exactly. CBT remains the first line. You have to have a word with the cognitive. You are changing the brain. यहाँ पे क्या है? You are showing the, let's say you are using those sounds, the horns and all. You are mimicking that scenario. You are having those pictures, and you ask the patient to look here and there. So this is used. This technique or therapy is used after CBT. Right? Okay. Then the other one is 95th.
Paranoid.
Paranoid.
Patient is paranoid about these, and every other point they don't trust. Mainly it is the trust, right? They don't trust. So this is how it goes, and definitely we'll talk more about it. About these schizoid. Schizoid is they are socially detached, right? Schizotypal, they have eccentric and odd belief. Remember that eccentric and odd belief, and definitely we'll discuss later on also. And schizophrenia. How you say schizophrenia?
Positive and
Hallucinations.
Auditory
Delusion, hallucination,
Mhm.
disorganized speech. These are the three very important, right? And also there can be negative symptoms also, anhedonia and all. But yeah, these three: delusion, hallucination, disorganized speech, important. 96th.
Propranolol.
This is what do you just mention? Thyroid storm.
No, postpartum
Postpartum.
Postpartum thyroid.
It can happen up to 1 year, right? Usually it is 6 months. So you have hyper, hypo, and U phase. So right now, if you can see patient is in hyper phase, relieve the symptoms, it is propranolol. 97th. How many of you marked it correct?
Sir, I just made one silly
How
mistake.
many
It
of
was
you,
in
how many of you were just in the search of finishing the exam? Ki khatam ho, bas. I'm just about to end the exam. I don't want these calculation anymore. Huh? Dr. Honey did right. Okay, Dr. Pratima. Dr. Pratima, yeah, can you go ahead?
Yes, sir. Incident is like how many new cases on the particular disease or whatever it is. So here the patient they're having 6 new cases in 6 months for over 3 lakh people.
Exactly.
So we are in 6 months we have to count for 1 year. It is double 12 months. If it is
Exactly.
3 lakh 12, it is for 1 lakh. It will be 4.
So 12 per annum in a population of 300,000. What they've asked is 100,000. We need to divide by 3. So answer becomes 4 per 100,000. It was not that difficult, but yeah, it is just a matter of time, right? It's just a matter of time. When you have that tension in the exam, you're not able to understand what they are asking, and you make silly mistakes, not seeing that it is 6 months, not seeing it is 6, and they have asked about 300,000. So these mistakes happen. But again, there will be just 1 or 2 calculation questions. Thankfully, fortunately, there are not many calculation questions for the past 4-5 diets. They have not asked a single question. Much difficult. One other question they have asked about PPV. That's it. Otherwise, they have not asked. Okay.
But I didn't get the calculation part, sir. How it came like 4 per 1 lakh?
Okay. Dr. Kasturi, in past
Yeah.
6 months, what they say, 6 were newly diagnosed with RA. What they ask is incidence rate, right? So if in 6 months there were 6 newly diagnosed, what about per annum in 12 months?
12.
12 new cases per annum. Is that okay?
Yeah.
And that happens in a population of
300,000.
300,000.
What they have asked is incidence rate, which is always calculated in 100,000, not 300,000. So if 12 in 300,000, how many out of 100,000?
4.
You yourself answer.
300. Yes.
Okay, is that okay?
Yes, sir. Yeah.
Okay, great. 98 ppv. This is the question for asked.
True positive divided by all positive.
All positives.
90%.
Now, how many of you were able to answer this? It's an easy one.
Easy
Yes.
one.
Yes.
Wow, wonderful. Good. Out of 240 confirmed to have 180 tested positive. So 240 confirmed to have lymphoma, 180 found to be positive. That means true positives are
180.
180.
for sure. Additionally, the test was positive in 20 who were later confirmed to be disease free. That means test was positive, but that was actually false result.
False.
Please try to look in that. The test came out to be positive, but patient didn't have the disease. So that's a false report. False positive. The false positive come out to be
20.
and you don't need negatives. For predictive positive value, you just have true positive and false positive. Answer is 180 by
200.
So it is 90%, right? 99th. This is a confusing one. But again, this is what you need to assume. Marfan's, how is the inheritance?
Autosomal
Dominant, autosomal dominant.
What they have given is patient's father was recently treated, right? His partner doesn't have any medical illness, no history. Now this patient, this man has a history, family history. Female, forget about. Female doesn't have anything. The male partner, what we are worried why they have gone to a genetic counseling is what is the risk if he is diseased, if he has got that from the patient, let's say, what is the chances of child inheriting it?
50%.
50%.
50%.
Because if it is autosomal dominant and if only one gene is also affected or defected, it will be inherited and patient will express the disease, right? So it is 50%. Yes, Dr. Priscilla.
Sir, in this, they mentioned they were asking about the 30-year-old man's sons, right? Like they came for genetic, so they were asking his risk, but they've not mentioned that 30-year-old man was either deceased or not deceased. So I thought probably not deceased.
What you
So
thought is absolutely okay.
0%.
What you
I did the
thought-
same thing.
Absolutely okay. Now the patient is worried. What you need to assume is chances of him being a defective. Otherwise, the answer is 0. You will just send the patient back. No worries. So maybe patient is defective and they have not mentioned about it. They just mentioned about the inheritance. If father was affected, yes, there is chance patient might be affected, and that is what you have to assume. This is what I just mentioned. In these kind of patients, these kind of questions, you have to assume it. If there's an inheritance pattern mentioned. The
So
other
if in case they're not mentioned,
you cannot think about, right? But yeah, on the male side, yes, there is a family history. Assume it that patient has one defected allele or gene. Then what about the offspring? This is what you need to assume, right?
yes, sir.
Unfortunately, this is what you need to do. Okay, 100th, last.
Hypothyroid.
Hypothyroid.
Hypothyroid. Why not microprolactinoma? Anyone?
It has to be more than 1,000.
Perfect. The value is not going in favor. This is just a mild increase in prolactin level, which you can see with hypothyroid situation, and that's the reason. So that brings us to the end, and thank you so much. It's 2 a.m. in India, and definitely quite an exhaustive discussion. And still, there are many candidates. And so, can I again request? I know it's late. Again, have your front cameras on, and I can see whether you are awake, whether you are lying down on couch, on sofa, resting, or maybe on your night duties, or something like that. So anyhow, most welcome, Dr. Ajila. And definitely we have covered all of it, right? Majority of initially I thought I'll be just rushing and I'll be just talking around 25-30 questions, but I thought you are energetic right now, right? And you scored well, so you might have that energy to go ahead with 4-5 hours discussion. So ultimately it happened, and you did well, all of you. If you have scored again, now I'll summarize whatever about the mock exam. If you have scored more than 60%, it's good. 50 to 60, it is borderline. You have to push yourself. Less than 50, you have to actually take leaves at this point of time. Now, this was just a score. This was just an analysis for this day. Next, following which, I will just say, keep that number as just a score for 31st August. That's it. This month is over. Just finish it. We are starting with another month, which is September. Start afresh. That yes, next 15 days I'll dedicate totally into the studies, into the revision, grabbing things, and especially cramming the bullet points or seeing those bullet points which you have already read. Now, if you have made your own notes, obviously the first thing is please go ahead with those notes first. Second, if you have the PDFs, please go ahead with the PDFs. All those who are from Intellect Medicos, obviously you have the PDF with you. All those who were there in the UK workshop, you all have those PDFs also. So go ahead with those PDFs. Now comes the fact of your question bank. It doesn't matter how many questions have you practiced, whether it is 500 out of 6,000, whether it is 0 out of 6,000, it doesn't matter. I have many examples, many doctors in the past who have not done even a single question, and yet they were able to clear the exam. They are 10% who are the people who have just done 10% of the question bank or 20% of the question bank, but still they managed to clear the exam. So it doesn't matter whether you have whether you have watched whether you have solved the questions or not. It doesn't actually matter. What matters how you are moving. So read the PDFs, read your notes, and now comes, if at all, if you have seen some questions from your question bank, see just the incorrect ones or the flat one. That's it. And if you are somewhat not sure about your performance, you are not sure how you will manage the time. This time you just struggled with the time limit, right? 3 hours you're not able to manage, or you are just really able to complete it, and you are struggling with options, you are struggling with the time management. I would just strongly recommend, please solve 2 or 3 previous A papers. That's it. Do not go with solving 10 question papers or 8 or 12 or 14. No, not at all. If you have time, yes, that's the best scenario. If you have revised, you are well versed with the topics, yes, please go ahead with the previous papers. But just for the previous year papers, do not compromise your revision, your notes, your facts, your PDFs, please. Because if you know a fact, if you talk about the pituitary, if you talk about hemochromatosis, if you know all these things, or let's say conus medullaris, today we discussed about conus, or we discussed, let's say, about brown sequard or any other thing, right? Definitely you need to know the theory, why it is happening, or SCD. You need to know posterior column is involved over here. You need to know what are the other differentials of upper motor and lower motor. So if you are well versed, you'll be able to see those hints in the exam. If you have not revised, you will have great anxiety in the exam. What will happen, right? So that I would just say, when you revise, your anxiety decreases, your output increases, and this is what is to be done in the last few days. Do not practice a single new question at this point of time apart from previous year papers. No new question, no unit, right? If you have done your basic sciences minor units, it's good, right? If you have practiced. If you have not, then also I would say it's okay. When we have that one day, right, 1 or 1.5 days for revision of basic science and the biostats, I would just say go with the same strategy, marking the option and seeing the answer. If let's say answer is about MHC, histocompatibility complex, or let's say ABO incompatibility, I would just say read the answer and explanation afterwards. If you know the fact, if you know the topic, move to the next one. That is true only for the minor units, basic sciences and biostat. Other units, please do not bother. If neurology, you have done 50 out of 300 or 600 question, doesn't matter. If you have not done any single question of neurology, it's okay. This is not the time to go with neurology or hematology or pharmacology or any other question, any other unit. Okay, so just revise. On second, we have, I believe we have cardio and pulmo. Is it the first session on second?
Yes, sir.
Okay, so just revise the PDFs, and then comes your incorrect question. This is how you need to move. What about your sample papers or the sample questions? Have you checked? Have you done those?
Yes, sir.
Yes, sir.
I've
On the
done
way.
150
Almost.
questions.
Okay, good. Again, so if you have not seen those, that is another thing I can say, but that's again not mandatory. You have to do it if you have time, but do not compromise your revision based on this, based on the sample question or the previous year papers. First thing first comes is your revision, revising your PDFs and your notes, right? Yeah, Dr. Sadia.
Sir, considering that minor subjects questions, it's just wondering, don't we just see the topics from past medicine? Do I have to go through each questions?
Each question of the minor units, is it?
If I haven't done the MCQ
Yes.
much,
This is
that
what
case.
you should aim for. This is what you should aim for. You have to see all the question of minors. Yes. Right. And again, if you don't have much time, just mark the option and see the answer. Do not read the question that a 40-year-old presented with blurring of vision and this happened, although those happened, nothing. Just option, see the answer, see the topic on which the discussion is. Let's say it's about acute angle closure glaucoma. So you need to know how an acute angle closure glaucoma patient presents. That's it. How is the presentation, how to diagnose, how to treat it. Over. So this is the way you have to do not read the question, because once, let's say you plan to read, first of all, it takes time. Second, bad thing which happens is you tend to analyze in the last few days, which is never to be done. Because if you read a question and you try to mark option by yourself, let's say you go ahead and you thought about it's a angle closure glaucoma, but answer comes as uveitis. You will be like, oh, just 10 days left or just 18 days left or 15 days left. I don't know, even know, and that will increase your anxiety. So at this point of time, please do not see any new question. Do not analyze yourself. Do not judge yourself. Are you good to go for the exam or not? Because you are actually going for the exam. You have to go for the exam. There's no option of backing out right now. When you are on a battlefield, you have already moved so far. There is no such option of backing out. You have to go. Right. So, and definitely, I'm pretty sure if you revise in a best way, the last 15 days, you will get a great outcome. Trust me, trust this process, trust these last 15 days. Push yourself to the maximum limit, right? However hard you can push yourself, right? Try to fetch the time. Request your relatives, request even the neighbors also, right? Whatever you can do, you have to fetch time by yourself, right? You are on duty. Ask your colleagues, right? Which usually are not helpful. But yes, you have to take that help, right? Adjust your duties, take leaves. But this is your career, this is your goal, you have to work on it, right? You can't be just pleasing others, right? Pleasing consultant, pleasing your colleagues. It's okay, I'll just manage, I'll manage with my time. No, at this point of time, you have to be that selfish that yes, it's my career, it's my goal, I have to clear it, and I'll utilize every other single second of these last 15 days. Is that okay with everyone?
Yes, sir.
Yes, sir. Yes, sir.
So before, most welcome, Dr. Mayuri, Dr. Kende, and Dr. Arjit. Yeah, most welcome. And I would just say, that just keep believing in the process and keep believing in yourself. Give yourself time. Try to be motivated. I'm always there. Mustafa is there. Shruti is there. We all are there, right? If you are feeling low, if you want that support, we are there to help you out, right? We are there, but just take that step forward. Try and have a word with you, with us. Yes, this is the problem you are facing, but I want every single person of you that, yeah, please keep going, go forward, take that step, and you will conquer it. Just have that confidence, that have that belief in yourself, right? And you will definitely clear the exam as like others, right? And I hope the best for this batch, because I've seen the performance, I've seen the marks, I've seen the way you interact in the groups, right? Obviously, I was somewhat occupied for the last few weeks with the visit to the UK, having the workshop and all. So I was somewhat occupied, but eventually I was just seeing our group, the kind of interaction, the kind of questions, and also the result of the mock exams. I used to analyze everything. So I'm happy about your performance. You are going good. Just be there, just keep going forward, just keep doing the hard work. and success is waiting for you, right? And that's on 17th of September. Just have that on your brain that yes, the day is 17th September. Now, before logging out, can I have everyone who is there with the screens on, can I have that smile on the face and have that confidence? Yes, yes, we will do it. We will do it on 17th September. Can I have that?
Yes.
Yes,
Yes, sir, we'll do it.
Have that energy? Can I have that smile? Can I have that determination? Can I have that confidence on the faces? Can I have that?
Yes, sir. We will
Yes,
do
sir.
it, sir.
I can't see that
Yes, sir.
energy. I can't see that energy. I need to see more energy. Can I have that? I know it's 2 a.m.
Yeah.
Late.
We'll do it.
Yes.
We will do
We'll
it,
do
sir.
it, sir.
We'll
Yes.
do it, sir.
Yes.
We'll do it.
Good. Perfect.
Thank you, sir.
That's it.
Thank you. Thank you.
Thank you so
Thank
much,
you,
sir.
sir. Thank you so
Thank you
much.
so much, sir.
Most welcome. Most welcome.
Thank you.
And be there in the live sessions and in the revision session. Definitely, it will be very, very fruitful. I just want all of you to be there. I'll be discussing all the bullet points which have been asked in the exam or which will be asked in the exam. So those are the high yielding points, essential points which you don't have to miss, right? So if in the end, if you are not able to revise, even let's say one day is gone, right? Just be there in the session, listen and try to interact, try to answer, try to gather information in that 3 hours or 4 hours session itself, right? Limit yourself that yes, I need these 3-4 hours. I'll try to be live, I'll try to listen, right? So if you dedicate that time for yourself, it becomes fruitful, remember, right? Okay, so see you there on 2nd of
Yes, sir.
September with the revision. Just keep moving forward, keep revising, and do not think much about other units. Abhi, right now it's cardio and pulmo. Don't think about neuro, endo. Ho jayega. Everything will be done, right? Ho jayega. Just have that confidence and keep going forward.
Thank you once again, sir.
Thank you.
Thank you.
Thank you so much.
Most welcome, and I'll see you live on 2nd of September. Bye bye. Take care, and whatever doubts you might be having, we can have the discussion in the group, and keep that live, keep that interactive. That is what matters the most, right? How you are reacting, how you are interacting, how you are catching up the points. Okay. Bye bye. Take care. Good night, and best wishes.
Thank you.
Thank you, sir.